thank you very much for being there early and on time. If we don't start on time, I think we'll just keep on sliding through the day. So I'm going to start off inviting the chairpersons, Dr. S.K. Raghunath and Dr. Divya Meeda, and Dr. Anurima Patra and Dr. Puneet Sharma. Thank you very much. If you wanted to invite the speakers. Okay, we'll start off with the first one, going down the investigational pathway. I'm going to request Dr. Aditya Pradhan sir to talk about the investigational pathway for the prostate cancer, emphasizing on the MRI of the prostate. Thank you.
Pointer. Good morning, Calcutta, or should I say good morning, Paris. We're sitting right next to the Eiffel Tower. So right at the outset, I'd like to thank the organizers for giving me this opportunity. And I am speaking on three separate, should I say, views on MRI of the prostate. I have no disclosures relevant to this talk. Well, to set the ball rolling, most of us know that we are using the MRI first protocol for our prostate biopsies. And all MRIs have more or less been synchronized to a PIRAD score, which has been, the framework of which has been laid down in this latest version. However, a lot depends on the quality of what you get on the MRI. So you need a good machine. You need to have a high volume center doing this MRI work for you. Significantly important is the attention
Slides are
paid.
not seen.
Sorry? Yeah, should I go back? Right. So, as I was mentioning, the quality of the MRI depends a lot on many factors. The machine, it needs to be of a good quality. You need to have a high volume center doing MRI work. Important is the attention paid to the patient's preparation. Examples are that you have the rectum empty before the study. So you've asked him to get an enema done. You've asked him to avoid ejaculation for at least 48 hours. More important than all of this is the experience of the radiographer actually doing the study and the diligence which he pays to giving you a good study done. And I shall dwell a little more in detail on the experience of the radiologist. First off, this point about MR spectroscopy, I think we can get it right off the list. We no longer use it. Why is that so? Because we have better sequences. So the PIRADS 2 version doesn't any longer recommend doing an MRI sequence. So speaking then on the major chunk of this talk, which is biparametric versus multiparametric. This is the schema for PIRADS version 2. And as I can show you here, the peripheral zone is read principally on strength of the diffusion imaging. So you grade them 1 to 5 based on what you see on diffusion. And in the transitional zone, it is the T2 sequences which decide the score. And then, therefore, what is the place of contrast? It's right here. So as far as this sequence goes, the aim of giving contrast is basically in the indecision zone. The PIRADS 3 lesions, if they are contrast enhancing, you will upgrade that to a PIRADS 4 in your final score. If it doesn't enhance, a PIRADS 3 stays 3. So that's the importance actually as far as the contrast goes. So it's got a limited utility overall. So why are we talking of biparametric? Why are we saying do non-contrast? Some of the reasons are obvious. There's a lesser acquisition time, less effects of the contrast gadolinium, and results are sometimes comparable. We'll go a little more into that. And obviously it reduces the cost to you. So when you use biparametric, what is the experience of major centers? This is data collated from a number of studies. So let's focus on this. So by and large, about 20% of all MRIs are reported at PIRAD 3. Now you had the opportunity of using contrast, so some of them would have become PIRADS 4. So if you don't use the contrast, like in biparametric, all stay there. So your PIRADS 3 actually would go up in numbers. You would have more of them. You would have about 30%. A third of your readings would be 3. And therefore, if you biopsy all of these, as we tend to do, you'll have more insignificant cancers picked up. So one way to get about and get around this problem is see the risk of the patient. Is he a low or is he a high risk? So if he's low risk, then you might do biparametric. If he's high risk, you should do multiparametric. I'll give you some examples as I put here. So if you have high density but 1 and 2, or you have a pyrite 3 but the density is about 0.15, here you want to be more specific. Here you want to maintain your negative predictive value. So you should use MPMRI. The other settings may be if he's a rebiopsy candidate or if his family history is positive, use contrast. But in the low-risk patients, like a screened patient, you probably don't need to use a contrast study. And the other settings may be if it's very obvious disease, like he's DRE positive or a high load, you can avoid contrast. So here is an example, very obvious lesions, you probably don't need MPMRI. I mean, some might say you don't even need an MRI at all. So when you compare these two, what does the data tell you? So here, there are many data. One meta-analysis in the AJR says the sensitivity and specificity are almost exactly the same. But there are many caveats to these meta-analyses. The biggest one of them seems to be the experience of the radiologist. So here is a study looking at two groups, R1, which is a less experienced with less than 500 readings, to more experienced, who's done more than 5,000. So those less experienced guys missed at least 20% of significant cancers, even with multi-parametric. So if they did the readings on biparametric, that number went up even higher. But the more experienced radiologist reading an MPMRI and biparametric, they had comparable results. In fact, on the MPMRI, they were able to pick up about 10% more cancer. So the experience determines whether you use contrast or don't use contrast. So summarizing this all, we would be safe in saying MPMRI is okay if you have a high throughput center, you're dealing with a low-risk patient or in a very obvious disease, and most importantly, the radiologist reading the study is experienced. The next point, 1.5 versus a 3 Tesla machine. So by and large, we all know the bigger the magnet, the better the images, and the reason is, for us, is that the diffusion images are better. The reason for this better image is that you have a better signal to noise ratio, so it's a sharper image with a higher gradient. So here are an examples on a 1.5 versus a 3 Tesla, and those amongst you who read it would see that the 3 Tesla machine gives sharper peripheral zone imaging, and also the innocuous anterior lesions which are difficult to pick up are better seen on this. Direct comparisons on two machines of different companies of different types of coils is difficult. There is little data, and what data we have tells us that the sensitivity and specificity actually on a 3 and 1.5 Tesla are quite similar. But where 1.5 scores specifically is in such instances where you have a hip prosthesis. On a 3 Tesla, it's a washout. You don't see anything. There's a lot of artifact coming in. But you get a reasonable image on 1.5. I'll just cut out briefly this point about endorectal coils, which sometimes comes into discussion. So it's no longer used. There are many reasons. The coil itself produces compression, gives artifacts. It's painful because it's a big coil and stays there for the whole study. And of course, the matter of cost. So here are examples where the endorectal coil has completely compressed the prostate, and therefore what you see comparing this panel to that panel, so without endorectal coil is better. So I'll conclude by saying we don't use MR spectroscopy ever now. The biparametric is reasonable, but in low-risk situations, or if you have a high-volume center with experts reading that study for you. And within the 3 and 1.5 Tesla machines, the differences are marginal, and therefore the current PIRATS committee has not made any specific machine recommendations. Thank you.
Should we take up the questions now or at the end? Okay. Thank you, Dr. Pradhan, for excellent talk. Where are we now with AI? So what are the
Well,
advantages
see,
of AI with
Right.
respect to
So we're
MRI?
talking of something outside of the parameters what we had given me, but the little literature which I've read is basically, I think the AI has been trying to hone on to getting the indecision part sorted out. The very obvious 4 and 5s are not going to change much, but it does help you in deciding where the threes, the score, the Pirates 3 are going to reduce. So there's a lot of deep learning involved in this matter. So that number currently, like I showed you in the data, is about 20%. So AI might help you to improve on that. The second is the turnaround time of reporting has been reduced significantly. But I'm not aware of any large experience in this field as of yet.
There are studies where it reduces the inter-observer variability, that's number one. And even if PIRAS 2 is there, around 6 to 7% of cancers are missed in PIRAS 2. So those are going to be picked up by AI.
Adit, this
Yes, sir.
biparametric or multiparametric, I think debate is there, and most of the one trial was presented in EAU also, which recommended biparametric equal to multiparametric. My question is, when you do biparametric MRI, and if you go for fusion biopsy, does this make any difference, or it is as good as MP-MRI?
So I'll be honest with you, I've not come on data specifically on this fusion outputs on bi versus multiparametric. I'm not aware of the outputs.
Sir, may I make just a comments or observation? This AI deep learning, actually whatever research is going on is between 3 plus 4, 4 plus 3. Pirates 2 versus Pirates 3. So what is the actual scoring? So probably that is the fact in coming 2 years. There will be a lot of data which will change the entire scenario and help uro-oncologists better understanding.
That's what I was alluding to. Our zone of indecision is Pirates 3,
Exactly.
which is pretty high. It's a fifth of all our output on an MRI.
Exactly.
And that's where the AI is going to make a difference. 1 and 2 is not going to change things much.
Same is uro-onco pathology.
Thank you.
3 plus 4, 4 plus 3.
So, there was a brutal murder of a fellow doctor yesterday in Calcutta, and in memory of her, I would request everybody to stand in solidarity and mourn her death for 1 minute. Thank you very much. I'm going to request all speakers, there will be an alarm at 8 and we'll switch off the mics at 9 minutes. Yeah, thank you.
Can we have the slides, please? Thank you so much. Yeah, so it's a transperineal fusion biopsy, which is the topic allocated for me today. And the question is whether it is an ideal procedure for prostate biopsy. So when it comes to the discussion about the ideal procedure, what is my aim out of the biopsy? I should have minimum side effects. That is one important thing. Pickup rates of significant cancer should be more, and minimization of overdiagnosis of clinically insignificant cancer. So that's the content which I'm going to run through for the whole PPT. Courtesy Dr. Adla for the slide. So the transperineal needle aspiration has been spoken about in 1922. So that's a era almost 100 years prior to what we are talking today. And then the evolution slowly started from there to truss getting described in 1960s, and the MRIs happening later on, and then the sextant biopsies. So we know a lot of papers, promise, precision, etc., but when we actually ask a gentleman about the details, we do not know the numbers precisely, we do not know about the details. So what I thought, to simplify it in one particular slide, I took help from my son. I enjoyed doing that. Thank you for organizers for that opportunity. And jotted down all the papers on a whiteboard. So essentially we divide biopsies in truss era and TP era. For the biopsies done, let's focus on the top side. So for the truss era, biopsies can be either primary or can be the repeat biopsies. For the primary biopsies, I'm just going to give us an inference of each trial and the name of the trial, no details anymore. So PROMISE trial told us about emphasis on MRI before the biopsy. Precision compared targeted versus systematic truss, and targeted was better in terms of significant cancer detection. MRI first, paired cap, and the article from NEGM, that's a US article, Maryland, they all told us that if you combine systematic as well as the targeted biopsies, they are better for diagnosis of clinically significant cancers as compared to systematic. The US article, NEGM article told us, the one in the right extreme corner told us that upgradations are least if you combine both when the patients eventually undergo RP. So that's something which is important. The only trial which told us that potentially systematic can be skippable is 4M. It compared again targeted as well as systematic versus systematic. Results were comparable, and if you avoid doing systematic in a primary setting, you only miss 4% significant cancer. So that's the only trial which told us that potentially do targeted only. We are coming to the repeat biopsy in a truss era setting. We have about 2 papers. Definitely they have all compared only targeted with systematic. It's not a combination, only targeted compared to systematic, and targeted are better, almost double the rates of detection of significant cancers, and potentially systematic can be skipped. A trial called Future compared various types of fusions. They did only targeted. They compared various types of fusion and they stood comparable. The fusion, the cognitive pairing, and in-bore guidance. Now we come to the TP era. It's as recent as last couple of years trials. 2 papers, Perfect and Journal of Urology, Young Academic Urology Group. So Perfect paper Perfect trial compared transperineal and transrectal targeted biopsies for the primary diagnosis again. Results are comparable. However, posterior lesions are better suited for transrectal and anterior lesions are better suited for transperineal. So they asked us to keep a pragmatic approach. That's an inference. A Young Academic Urology Group from EAU, however, has compared, that's again, it's not a trial, it's a retrospective audit. But they have mentioned that transperineal is better in every respect of diagnosis as well as clinical significant cancer diagnosis, especially if you have lesions at apex, anterior fibromuscular stroma, and transition and central zone, and the odds ratio are 4 and 5 almost. So understanding about minimization of rates of clinically insignificant biopsies, of course we know that targeted will have the least possible extent, so that's an advantage of targeted biopsy. What does EAU say? Let's only focus on the 2 columns which are marked in, or the rows which are marked in the red ones. When MRI is positive, perform only targeted biopsy in a primary setting, that is what it says, but it's a weak recommendation. So potentially at this point of time, we have not reached there to skip systematic biopsy. Potentially the combination of targeted and systematic has to go on based on the data so far. And this is a question mark in my mind as well. Systematic transperineal biopsies are preferred over systematic transrectal biopsies. It's a strong recommendation for detection of significant cancer. Potential inference to me out of this is, it says that significant cancer diagnosis is similar, but because of the infection and other complications rates, you give a strong recommendation for TP over transrectal. Now we compare about various transperineal, transrectal fusion approaches. So targeted is definitely better for clinically significant cancer diagnosis. Let's focus only on the right bit of it. Cognitive biopsy, fusion, and MRI trans in bore. It gives a sensitivity for clinical significant cancer diagnosis to about 85, 88, and 90% approximately. So again, now emphasis about why transperineal we are talking about. The term called Trexit 2020, it's basically a eponym of exit of transrectal biopsies. That happened because of the various reasons of infective etiologies related to transrectal biopsies, and the EAU guidelines emphasize on that it reduces infection significantly. In transperineal cohort, if you have biopsy been done with or without antibiotics, the infection rates do not differ a lot. So potentially we are heading towards no antibiotic policy, or at least minimal antibiotic policy. It's a strong recommendation by the AAU. I'm going to utilize the opportunity for a quick emphasis on one of my papers which I contributed. It was an analysis of decade of a prostate biopsy, total 500,000 biopsies from UK NHS, comparing only infections and sepsis rates, which were definitely significantly better for transperineal. One important highlight was for transrectal group, the overall outcomes of infections are increasing in last 2 years. Typically, the admissions which happen are more for infections in transrectal and urinary problems in transperineal. So the cost of managing these transrectal complications or admissions is more as compared to the transperineal. We call it downstream cost. So in a way, the downstream cost is beneficial for transperineal, and it was cited in AAU guidelines at one point of time, 2020 as well. So systematic review about various approaches. So whenever you are doing a fusion, these are the available fusions which we have. In India, we have MIM, the one in the lower box. You have all the other availabilities. All these are US FDA and EMA approved. One thing which is inquisitive is you have either a rigid or elastic registration for tracking the for understanding the lesion, and secondly, the navigation is either an organ-based or electromagnetic tracking. So it is up to us how to use it. One important line. So in transperineal, I think biopsies, there were two protocols. Ginsburg protocol was it came in evolution in 2017. So two good lines out of the paper were targeted biopsies always have to be done before the systematic biopsies. One important line here, you don't have to do systematic first because targeted ones are more important. And if you're doing transperineal, do the anterior first because you're visualizing the prostate from the back. So do the anterior first and then come to the posterior ones. So that's the Ginsburg protocol. And a vector prostate biopsy, that's the another thing. I couldn't get a full paper, so I'm sorry for the not having the details of the machine and etc. So coming to the cons, Indian thing, we know that the biology of the disease which we treat here is not something similar to a screen detected Western driven country concept. So it's more relevant, fusion transperineal is more relevant for screen detected cancers, which we just, Dr. Pradhan just spoke about the same, very early lesions. However, for Indian context, you majority have high PSAs, patient is already been worked up, MRI is done somewhere else, all these things will come into picture for decision making. The costs sometimes are a little more, it's about 1 CR cost, and a BK machine installation itself is 1.5 CR. The procedure cost is almost tripled, 75K versus 25K. Antibiotic wise, we are improving. I've spoken to Dr. Manohar and Dr. Adla who are potentially doing it this at this point of time. And that's my last slide, ideal procedure. So giving answer, I probably feel we should have a pragmatic approach. One size fits all cannot be a strategy. Primary biopsies, definitely systematic cannot be skipped. So targeted plus systematic combination can be the way forward. Repeat biopsies, definitely you potentially skip systematics and think about targeted biopsies, especially for the lesions which are located in AFS, apex, central and transition zones, and understand the biology and take your decisions accordingly. With this, I would conclude. I would like to invite you all for the Apollo Cancer Conclave on behalf of all the Apollo team members here. That's going to happen on 19th of November. The tagline is navigating the changing cancer concept landscape from contemporary to precise. That's exactly what we are speaking about. Contemporary was the trust-guided biopsy and precise is transperineal fusion biopsies.
Thank you, Ashwin. Any questions, comments?
Dr. Ashwin, thank you for the information. You raised the cost of the machine and said it's very costly. You can get a Hitachi machine for 12 lakhs, which I'm using, and it works well. The cost is in the pathology. Yeah. The pathologist, it's variable, but if we speak to them, they reduce. If you don't, it's high. So the cost is not in the machine. You showed a 1.5 crore machine. We don't need that. The main problem I see...
Which machine we are using? So I just mentioned about that BK machine cost.
Yeah. So you don't need a BK machine for that. So I am saying I am using a Hitachi which is 12 lakhs. But obviously I bought it 8 years ago. But one more thing is that posterior lesions, when you use a grid and stabilizer, it's not a problem at all. Because maybe to transrectal you will approach easier. But in with a stepper and grid, there is no problem to reach any part of the prostate.
Right. Absolutely. So transperineal is the way forward, definitely yes.
According to me, but everybody has to come on the same page. Thank you.
I have a small comment as well. See, the controversy of the controversy of the infection rate with transrectal and transperineal is small. Even in the Journal of Urology that was recently published, they said actually there is no difference. So I think the argument of the infection per se, I'm not sure is valid. But agreed to the extent of the approach to anterior and fibromuscular at this. But how many of your cancers are going to be in the transitional and the other zones is of question, especially in the Indian setting. So if given a choice of all the 4 options, including fusion, non-fusion, transperineal, transrectal, what would you go for?
Transrectal at this point of time, but if I do transperineal myself and I have a feasibility of doing it, I will go for transperineal. The infections are comparable, reason being we are bombarding with antibiotics on the transrectal group. At least 4 to 5 days of antibiotics, IV antibiotics. Against that, transperineal is only 1 dose of augmentin maybe, or maybe no antibiotics. That's the whole story.
Thank you, Dr. Ashwin. Can you provide one mic to Dr. Sanjay?
Should I start?
So he can manage from there. Thank you. Yeah, please go ahead.
Thank you, Dr. Sanjay sir, for this wonderful opportunity, and SOGOCON for this wonderful opportunity. I'd be speaking on imaging in chronic kidney diseases with reference to urological malignancies. I have nothing to disclose. This is why are we discussing this situation? We are discussing this situation because the incidence of renal malignancies, urothelial malignancies is more in patients with CKD. CKD3 has an odds ratio or hazard ratio of about 1.8, and 4 and 5 have a hazard ratio of about 2.3. At this point, let me just remind you, we are talking about patients who have GFR less than 60 or a UPCR of more than 30. So more incidence of malignancies pertaining to urology in these patients, therefore special imaging considerations. Why special imaging considerations? Because of 2 factors, toxicity and different biodistribution. When we talk about toxicity, we are talking about acute kidney injuries and with reference to the dyes used in MRI, nephrogenic systemic fibrosis. Look at this 3 index situation. On the left, a 10 centimeter mass in a 67-year-old gentleman, CKD3 with a caval thrombus. In the center, a patient who's nearly CKD5, not on dialysis, but a left lower polar mass, difficult characterization. Last situation, a patient in a pre-transplant workup, an incidentaloma of about 2.5 centimeters. They're similar yet different. For example, once you do a radical nephrectomy for a patient who's awaiting transplant, how are you going to follow this patient up? With which imaging? In the center, are you able to characterize this lesion vis-a-vis an inflammatory situation? So these are the challenges that we are going to face. What are the tools that are available? Contrast enhanced ultrasound, CT scans, MR, and nuclear imaging. What is the problem with CT scan? IV contrast. Whenever you give IV contrast, there is a possibility of acute kidney injury. Is it really real? It was touted to be about 30%. But again, it is like a situation, what is the GFR? Whenever the patient has a GFR of less than 30, that is the time there is a 15% real chance of these patients having AKI, and it is in this situation that it really matters. When it's the GFR is between 30 and 60, the rate of AKI may be numerically higher. It may not be statistically different. And let us not talk about a situation where the GFR is more than 30 because all is equal there. Is one contrast media better than the other? There may be difference in visualization and other toxicities, but when it comes to incidence of AKI, low osmolar versus very low osmolar is not going to make a difference. So all the non-ionic low osmolar contrasts are good enough. What are you going to do in a situation which has a greater propensity for AKI? Let us say a situation, a diabetic, high-risk patient, last history of AKI and a creatinine GFR between 30 to 60 or an absolute GFR less than 30. Volume expansion, alkalinization, N-acetylcysteine, statins. Out of this, only volume expansion has been thought to be of some of productive value. Using or disusing all the nephrotoxic drugs is of great value. Vitamin C, high flow oxygen are not useful. So what is the consensus? If the patient has a GFR of more than 30 and less than 60 and no risk feature, like he's not diabetic, does not have a history of AKI, he doesn't have proteinuria, these patients can be subjected to non-ionic contrast. But if the GFR is less than 30, these are the patients you need to hydrate, though alkalinization will not be of any benefit, but stop all the nephrotoxic drugs. And these are the patients which should be actually done, and the CT should be done in a hospital setting. And these are the patients who are at risk. So avoid when the GFR is less than 30, between 30 and 60, you can go ahead and do it. Be careful about the high-risk features of these patients. What about contrast-enhanced ultrasound? It is an alternative to CT and MRI, no ionizing radiation, portable, can be used in kidney dysfunction, has a sensitivity of about 80%, specificity of about 70%. Different types of microbubbles are used. Typically, sulfur hexafluorine is one which is available in India. The product name is Sonovist. This is our experience at MPUH of 30 patients. Typically, whenever the enhancement is homogeneous and the washout is quick, these are the patients or these are the mass lesions which have a higher propensity of malignancy. That is what we found in the small series that, that we did. So the procedure is that you dilute the dye into 50 cc, give it at a rate of 6 to 8 ml per minute, and then do the conventional sweeps to establish whether the mass lesion is malignant or not. And sensitivity is around 70 to 80%, and specificity around 70%. What about MRI in CKD patients? Problem, gadolinium, group 1 and group 3 agents. The problem was nephrogenic systemic fibrosis, but as you can see, the incidence after early 2010 has decreased drastically and was seen only in patients in which linear molecules were used and eGFR was less than 30. So this is a table which tells you that group 2 agents which are in green are relatively safer. So if the conventional agent which is used is gadopentate diameglumine, but as opposed to this, the group 2 agents which are gadotriol or buterol are safer in CKD patients. So again, look at the GFR. If the GFR is less than 30 and you were to use an agent, then that agent is going to be a group 2 contrast for MRI. Between 30 and 60 GFR, don't worry, use whatever you like. And in patients who are on dialysis, prefer to use a CT. What is the status of nephrogenic systemic fibrosis today? It is more theoretical than real. Look at this meta-analysis, pooled group. With group 2 agents, it is nearly zero. American, European, and Canadian urological and radiological societies permit use of group 2 gadolinium-based agents. If you look at the guideline, American guidelines 24 and the European guidelines 24, both allow the use of group 2 dyes as with reference to MRI. The at-risk patients, GFR less than 30, AKI, or on dialysis, group 1 and group 3 agents are contraindicated. What about FDG PET? Is it renal friendly? Yes, it is renal friendly, no problem. The problem may be potentially with biodistribution. But CKD patients also have found to be having no problems with the biodistribution of FDG. So what are the options? Whenever the GFR is more than 30, you can use it with contrast. Whenever GFR is less than 30, you use it with a plain PET, a plain CT PET, so that you can follow up urothelial malignancies. What about PSMA PET scan? The PSMA PET scan can be done in all patients with all renal function. In fact, it has been compared to DMSA to calculate the quantitative function. Only problem is it is a tubular agent, not a glomerular agent. If you were to use another agent than PSMA, rather than gallium-68, you can use the PSMA 1007 because it has biliary excretion. It has been pitched as an agent which can be used to detect renal masses. So it is safe, does not have a lot of altered biodistribution, can tomorrow be potentially used for renal imaging also. What about bone scan? Problem, renal functions, causes poor bone scintigraphy, but no toxicity. The MDP, MDP complexes with hydroxyapatite of bone, but there is so much soft tissue activity that overlays, and therefore you get a poor quality bone scan. Solution, hydrate and wait up to 4 hours. So PSMA, sodium fluoride, MDP, DTPA, EC, all can be used without any toxicity. Only the question is of biodistribution. So what is the best foot forward? CKD1, 2, don't worry. CKD3, slight increased risk. If high risk features are there, then use CT contrast, but use it with hydration. Patient on CKD 4 and 5, not on dialysis, use MRI, group 2 agents. Patient on hemodialysis or peritoneal dialysis, use CT with contrast rather than MRI. Patients with AKI, use group 2 agents. PET is safe in all situations. Contrast enhanced ultrasound can be used, and PSMA can.
Thank you, Dr. Abhishek. Any questions, comments?
That was brilliant talk, Abhishek. Exactly what we wanted to hear, and it clarifies to us when we are requesting what we wanted to. So now the main marker is the 30 ml per minute GFR. That's where everything seems to change, isn't it?
Yes, sir, and UPCR, albumin to creatinine ratio. Whenever it is more than 30, it is a danger sign. So basically proteinuria, you look at proteinuria, don't look at serum creatinine. Okay. Only serum creatinine is not going to give you adequate value.
Okay. Thank you.
Thank you, sir.
I'm going to request Dr. Sanjay Sureka to talk about that next one, alternate. Shall we just alter? So whether we like it or not, we keep requesting for PET CT for all staging. So I want to hear whether this is the standard for Indian patients. Thank you.
Thank you, Dr. Sanjay. So today we are toggling like a robotic arm from prostate to kidney to bladder. So I don't know why Dr. Sanjay has added India. Probably he knows that I have a special fondness for Modi ji. Anyhow, I'll carry on. So if we see the guidelines, the American guidelines mostly, and most of the guidelines, they very categorically favored CCT contrast enhanced CT scan for both abdominopelvic and thoracic staging in muscle invasive bladder cancer. But if we see the NCCN guidelines, they have just mentioned after CT is the preferred modality, there may be some role of FDG PET in certain scenario. So as you know, the conventional CCT is the standard of investigation till date. However, in certain clinical scenario, like a indeterminate lymph node, like indeterminate metastasis, or to evaluate the response to neoadjuvant chemotherapy, the FDG PET may have some measure. I will not talk about the different PET modality, only I will talk about FDG PET. So probably in India, we don't have reimbursement issues and it is easily available, and most of us are practicing or we are prescribing FDG PET, or most of our patients used to come to us with FDG PET in a muscle invasive bladder cancer, though we still don't know how it can be optimized or judicially useful in our setup. So I look into how it helps in primary staging, lymph nodal detection, metastatic evaluation, follow-up, and I'll share our experience and I'll give take-home message. If we see the role of FDG PET in the evaluation of the primary tumor, the good thing about FDG PET is usually very good avidity in urothelial cancer as compared to kidney cancer. However, urinary excretion of FDG interferes with tumor activity. PET CT showed no superiority in detecting the local bladder tumor, and it is not accurate enough for primary evaluation of primary tumor T staging. For lymph node staging, the lymph node evaluation accuracy of the CT is basically 70 to 92%. The major problem is the sensitivity, because it basically primarily focus on the size. Sometimes we can have metastasis in normal size lymph node. Several studies found that FDG PET is superior for detection of lymph nodal metastasis as compared to CT scan. In two recent meta-analyses, the sensitivity and specificity of detecting lymph nodal mets was between 50 to 70%. That is, sensitivity is much higher as compared to conventional CT, and good specificity. And it has potential to change the management in 20 to 40% of the cases as described in literature. If we see here, the sensitivity is much better in PET CT as compared to the conventional CT scan. With a specificity is almost same, but the accuracy is also again the same. But overall, if we see the lymph node outside the extrapelvic lymph node, then if we do the weighted average, the accuracy improved by 5 to 6%, which is huge. We are giving neoadjuvant chemotherapy for this 5 to 6% benefit. So this is 5 to 6% is a very good number. If you see the in-depth analysis of various studies, we found that the positive predictive value increased by PET CT and also negative predictive, but the negative predictive value is the same. And FDG PET compared to conventional MRI or CT scan detect more lesions in maybe 20 to 40% in different series. And the prospective studies done supported that it should be the first line of investigation for specific detection of the lymph node whenever there is a doubt. If we just forget all the literature, so the gist is the FDG PET has a potential role in lymph node detection with a higher accuracy with a moderate level of evidence. For detection of metastasis, again, the sensitivity is much better, and the result of FDG PET may change the treatment plan in 20 to 30%. If you see the various studies, the sensitivity, we can see that it improved from 40% at the tune of 40% with conventional CT MRI to more than 70% with the PET scan, and accuracy also increased by 5 to 7%. So if we just summarize the literature, the FDG PET is probably superior with a low level of evidence. For response evaluation of neoadjuvant chemotherapy, as we know that neoadjuvant chemotherapy has a good response in approximately 50% patient, poor response in 20% or 25%, and 25% patient progress. So if we can detect after 2 or 3 cycle that this patient probably is not responding, so that may help in segregating our patient or selecting our patient for chemotherapy vis-a-vis the radical nephrectomy or definitive therapy, radical cystectomy or definitive therapy. The results are very promising. The overall tumor downstaging was identified in more than 80% patient with sensitivity and specificity. Now I'll come to the prognostic value of the FDG PET CT. So if we see the FDG PET negative and compare with FDG PET positive patient, we can see that it has a good prognostic value, and it showed that 85% patient has a 2 years overall survival with PET negative versus 37% with PET positive. For detection of recurrence in follow-up, again the PET versus conventional imaging detection rate, the PET is performing much better as compared to the conventional CT scan. And they also probably detect more local recurrence as compared to the PET. So it may be useful with a low level of evidence. But if we see the literature, overall the studies, the SUV max protocols, the protocol for the measurement of the lymph nodes are so variable, and the study design. So it's the level of evidence in most of the studies as of now are low, it's weak. We don't have much of Indian data. I'll share a small our HGPJ study. We have done 65 study in 65 patients, and we found that the 20% shows upstaging. There is lymph nodal upstaging within the pelvis is 13%. And overall sensitivity for lymph nodal detection is much higher as compared to conventional CT as described in literature. The positive predictive value is also good. So in 15% patient approximately we have changed our decision. Just a few example, like there is a very small 1 centimeter node in the retroperitoneum. You can see the FDG PET has detected and good lit up, and we can conclusively we can say that this is a metastatic lymph node. In a patient where we have given a chemotherapy in 2 into 2 centimeter lymph node, but CT is showing the lymph node size is same, but PET we can see that there is a good response in the PET, and those sizes not that decreased, but the SUV max significantly reduced. Sometimes we had a patient with a recurrence in the penile urethra, which probably missed by the conventional CT scan, but we could pick up with the FDG PET. Sometimes we found a second malignancy. To conclude with, however, PET FDG may not be accurate enough for T staging, but it may be better for lymph nodal and distant metastasis. Sometimes we can find second malignancy. The results for evaluating the response is encouraging, and it is can be used for detection of local recurrence and distant metastasis in follow-up, though routine use cannot be recommended. A possible role in Indian setting should be evaluated further, and probably we can all get a good study, prospective study to get the final answer. Thank you.
Thank you, Dr. Sanjay. I have one question. This is specific for Indian scenario. Many patients will come with the CT scan, CT of the abdomen, where 3 centimeter tumor is there. You have done a resection TURBT. It is showing muscle invasive bladder cancer. Do you advise PET CT before contemplating cystectomy or bladder preservation protocol?
Yeah, as of
Or what are the alternatives?
as of now, in our center, the usually routinely we perform CT scan of pelvis and
Yes,
abdomen.
yes, already come with CT scan. You have done TURBT, it's muscle invasive disease.
So we'll give the neoadjuvant chemotherapy and we'll proceed for
So you don't do PET CT.
PET CT routinely. But since we are doing a study, for a study protocol, we are doing PET CT in all patients.
So what is the recommendation?
The recommendation as of now is CACT. Standard of care is CACT.
Any CT just is required
Yes.
before contemplating?
CACT thorax is also the recommendation. It's a part of.
Thank you. Dr. Raghu.
The problem with the PET and is that even if you look at the Australian studies on PSMA PET as well,
You're
there
talking
is-
about PSMA PET or FDG PET?
including any PET. The problem with the PET is that when it picks up abnormal things, we don't do biopsies of them. That small lymph node that you're showing in the retroperitoneum, there is no way you can prove that it is a malignancy or not. Just because there is an SUV uptake, we assume that it is malignant. We are changing the life course of a patient based on a test which has very little proof. And that is very uncomfortable. Yes? And this has happened time and again for many patients, be it prostate, be it with bladder as well. I'm also looking at PET. In fact, recently we finished the thesis of one of our students on PSMA PET. One of the patient had a PET of SUV of 9.5. Nodes were completely negative. And Raghunath had, multiple rib resections done for PSMA positive and found nothing as well. The problem is our ability to accurately come up with the PET is quite difficult unless the PET is corroborated with an MR of the same area and the findings are in 2 different scans and therefore they can corroborate well, or a biopsy of it. So my only word of caution is, yes, in India even for a running nose PET is being done. And Sanjay's question probably comes from that my patient is walking in with a PET scan and what am I supposed to do? And I will only say, be cautious. That's all I would say.
Yes, sir, I agree with your comment, and the sensitivity comes with over detection or over staging in some percentage of patients. Just agree.
Thank you, Sanjay.
We have discussion of 10 minutes at the end, then we can ask in that one.
Yeah, may I request the next speaker, Dr. Santosh. He's going to speak on waves of AI hitting uropathology shows, how to keep sailing. Over to you, Dr. Santosh.
Thank you, chairpersons, and thank you, SOGOCON, for having me here. I am a little terrified by Sanjay's dhamki of stopping it in 8 minutes, so I'll start immediately. So this is a relatively new topic on uropathology and artificial intelligence. My conflict of interest involved in some AI projects, but do not have any commercial interest. I think this is a very familiar picture for everybody who's interested in AI. So AI is a broad category, which basically means that they're trying to mimic what human beings do. And then you have machine learning, in which you train a program, you test it, you validate it, and you retest it. And deep learning is something based on a very convoluted neural network, just like a human brain, when you have a lot of programs intermingled with each other and the processes resemble a human brain. That's called deep learning. A simple example is, you want to teach a program to distinguish between a dog and a cat. You feed them 1,000 images of dogs and 1,000 of cat, and finally the program will learn, or you can software program to tell that this is a dog versus a cat. When you have unlabeled data, supposing you have these cars and buses and scooters, you feed them with these pictures and you make a program to say that how to segregate the images. So basically in pathology what we are doing is the same thing. We have histopathology slides of a tumor and we feed it into a program, and the software is developed in such a way that it starts reading the images. So the first thing in pathology is to go to images. So when it comes to GU cancers, what are the different types of deep learning or AI programs which we have classification of cancers, grading of cancers, predicting treatment response, devising treatment plans, and how the patient responds to different plans. These are the different things which can be done with AI. The most important starting point for any AI development is to have a lot of data. Lot of nicely annotated data, a lot of data which can be compiled and segregated into groups so that it can be fed and the programs can be made accordingly. So what happens in pathology? We have to have basic histopathology slides, which we already have. We have to have a digital pathology system because we need to scan the images and make them into digitized images. You have to have very strong computational pathology and annotation of lesions. You have to develop AI algorithms. The most important and problematic issues in AI is the standardization validation of different kind of AI algorithms. And then the approval and acceptance and integration into a day-to-day practice. So this is from my own department. We have different scanners, single slide scanners. The Philips is a 300 slide scanner. The 3D Histic is a 12 slide scanner. The Roche is 6. So you have different kind of scanners now in the market which can digitize these histopathology slides before you slide. This is a short video which I can show. So this is our digital pathology room. You look, these are all different kinds of workstations which we have, in which you have, and this is the scanner which you see on this end. So you can scan the images and these are available. So once you have scanned the images, that's only when you start doing the second part, which is the applications of digital pathology, which includes AI and deep learning. There are several other things which are being done. In our department, we have this ERPR, HER2, Ki67 calculation, which is based on a software algorithm which can be done. Prediction of lymph node metastasis can be done. Some of our colleagues in different DMGs have done this processes. And these are some of the other AI-based projects which we are doing in TMH. So when it comes to uropathology, what is being done? So currently our department is involved in some prostate grading AI algorithms. What was there in the literature is this. So this is a prostate core biopsy. And how do we go about doing this annotations? So see this, this is how an image is annotated. You have a 3 gland, you have a 4 kind of a gland and a 5. These are given different annotations by the pathologist. And then several such images are fed into an algorithm to say that how to identify and distinguish these 3 from 4. So this is the prostate core biopsy. Once you start annotating, these are the different things which you annotate as a pathologist, and this goes into the feeding system. How does the system learn? The large image is converted into small pixelated images, or what we call as the styling of the images, or stacking of the images, and each is given based on its features. They're giving some points or some numbers are there. So the machine learns in a numerical value, but the images are fed from pathology images. And then you have a whole lot of training program and lot of algorithms. The heat maps which you see here, these are the heat maps which are given to different Gleason scoring, and that's how the output comes out from the machine when you have feed. The important things is to have a very well annotated data and very well algorithm which can pick up these things. So there are several other literature you can see here, development and validation programs, and these are again pictures to show how these are annotated by this and how the gold standard is compared with the ground truth. So experts will have a consensus diagnosis, and the program will be trained again and again, and it would be validated till it reaches a concordance level with the experts in this. Almost most of the prostate the bigger companies have now developed programs which are almost at the level of a 15-year experienced uropathologist. So at least for Gleason scoring and Gleason grading, we have reached that level. Just to show a study from Daniel Spratt's, one of his papers in ESCO, pre-treatment biopsy slides were digitized from different studies for radiotherapy with and without it, and this is the validation which they did. So they did a biomarker study based on the digitized images. With the digitized images, They found that the biomarker positive groups could really predict the distant metastasis and metastasis-free survival in prostate cancer specific metastatic better than the trial-based design. So adding these values in future based on AI images and digitized images is going to be part of several trials also. We'll be seeing that in the future. There are several other things. I'll not go into the details of these. When it comes to bladder, we are very poor at grading bladder tumors as pathologists. And this is one area where a lot of work is being done to grade bladder tumors. We can predict several groups within the bladder tumors based on histological images. So for a T8 tumor versus a T1 tumor versus a grade 1, 2, 3 tumor, based on the histopathological features of nuclear features, the stacking of the nuclei, those features can be picked up and you can have different risk stratification based on these images, and that's what is going to happen. Again, you can predict mutations, but the point is you initially to train the program, you need to have the mutations with you, and you have these digitized images, compare them with the FGFR mutation, say in this case as a bladder cancer, and then you can compare whether the images can itself predict. So based on histopathology images, you can almost predict molecular mutations also in patient. Again, in renal cancer, similar things, image-based analysis to predict outcomes and survival, lot of graphs. But I wonder when several different programs are there, which are we going to choose? That would be the problem which we are going to face in the. So this is my current state of mind. Have I lost my job? Will I have to compete with robots in the future? And do I need to press a panic button is a question. I think AI is going to empower the pathologist. We'll become more efficient. Most of the mundane work will be taken up by the AI. So in the morning when I come for reporting, the AI program will tell me, just see 2 of the slides, that's got cancer. The rest 10 slides of prostate do not have cancer. And it will help me work more efficiently. Again, there will be a whole lot of integration with the patient data and clinical informatics. And this will help us in developing different programs for diagnosis, follow-up, prognosis, and treatment. Coming to the last part on issues and limitations, there are a lot of problems with the hardware. We need to have a lot of image storing capacity because these are large size images. Heavily dependent on graphics, computational pathology, computational team has to be there to develop these algorithms. And then there is a big question of ethics. When you're keeping these images in the cloud, the security features, the patient information may be hacked and can leak out. And those problems of ethical issues are a very, very important problem, and regulatory issues have to be taken into consideration. This is a paper which was just came up in an article. These authors just put the prompt, pathology and AI, what could possibly go wrong? And the answer from ChatGPT is this, that lack of data diversity. If you don't do this AI algorithm across the board, you cannot. So the question is whether you want to sync or whether you want to go with the wave. A simple example is, do you want to use apps like DigiYatra or do you want to stand in a line before it? It's as simple as that. We are using it in our day-to-day life, but when it comes to medicine, we are still far away from doing a clinical-based approach in this AI management. Yes, Sanjay.
Thank you very much. So we have got, anybody wants to ask questions on any of the...
Yes,
Thank you, Dr. Santosh, for an excellent insight into the future. If a genie granted you 3 wishes, and the wishes were, please use AI-based softwares in uropathology, which are the 3 softwares you would ask the genie
So I would
for?
definitely, so there are certain mundane areas which you can definitely, so like I said, Gleason scoring, Gleason grading, when you have a pile of 12 core biopsies of 10 patients, it does take time. If it can really sift out the clear-cut areas, that would be really helpful in day-to-day practice. And I think if we can really develop some molecular imaging kind of thing, so like I said, if FGFR and uro, similarly in lung cancer, you have EGFR and all that. If that can be picked on digital images, it can save costs of doing molecular tests. But again, they are never 100% efficient, these things.
Santosh, Ginil here.
Santosh, Ginil, please go ahead.
Yes, Ginil.
Now everything you're, after initial histopathology, you are going for IHC. So when IHC factor is there, where the AI will stand, because you are not depending on the IHC now, only in the patterns. Will you be, the IHC factor also will be incorporated into the artificial intelligence thing?
Yes. So see, Ginil, everything is not. So just based on HNE, you can do a lot of stuff actually. But IHC will also be integrated. Many a times you will be able to predict the IHC. So based on certain H&E images, you will be able to say this is going to be positive for this marker. So those things have also come into practice where you actually do not need to do IHC marker on that slide. You just do
So
an
usage
H&E
of
image.
IHC may be reduced.
Yes,
you can be
based on
more
the
focused.
characters of the nuclei, cytoplasm, the architecture, the AI programs are able to, these days, some of them are able to predict that this is going to be positive for this IHC marker, this molecular marker, this response. So that's the work which is going on in AI field.
Just to comment on that, we are working with the 10X lab in US. It's just started preliminary work. With the help of computer vision based imaging, they're able to predict what is the genetic background of the tumor without doing sequencing.
Yes. So
It's at a preliminary stage.
Yes.
Santosh,
Yes,
is AI in pathology currently used anywhere?
Yes, so even in India, there are certain, I don't want to name the lab, but they are using AI algorithm,
so if
at
it
least
is
in prostate.
used, and as you mentioned in between, suppose the report is totally negative, what are the implications? Do they give a certificate that the AI is correct? The pathologist has to see the whole thing again before saying negative?
So
today?
somebody is still signing, Ganesh, those are the issues.
Signing anybody can do because most of your reports are digitally signed.
Yes, no, signing means somebody is actually cross-checking these. in any
Cross-checking
case, yes.
completely. So
Sort
that's
of.
what.
At least some part of it, especially when there is a red flag. It is like,
like
hemogram. You do
Dizzy
you do a blood test. The blood
Yatra
test gives a
allows me to
printout.
go inside,
Yes,
but
but
then
somebody
if
signs.
you say negative, it should be negative to the
So
clinician.
those are the regulatory issues. Who will take the responsibility if it's wrong? So those
Is
are
there
the
any
questions.
work on that front?
Yes. Regulation, yeah, there are a lot of laws and regulations which are coming in here, yes.
Excuse me.
Yes.
Yeah, Dr. Saranjit. You told that many of the predictors can be based on IHC, may not be required. Actually, we came across one of the very difficult case which had a dilemma from one of the most reputed lab in Calcutta regarding prostate rhabdomyosarcoma versus leiomyosarcoma versus spindle cell. So in that case, actually, this sample had to be sent to Tata, and then it came as leiomyosarcoma prostate based on 17 IHC panels. Do you see that even, foresee in the future that IHC can be replaced by AI?
I don't think it will be replaced. Not in our country for a long time. I'm sure about it. We'll still continue to use them. Thank you.
Thank you very much. I thank you the panel, Dr. S.K. Raghunath, Dr. Anurima Patra, Dr. Puneet Sharma, and Dr. Divya Meeder. And that was a brilliant start to the meeting, and every speaker was very, very good and to the point. So continuing the journey, we want to know what is the standard of care for 2024. I'm going to request Dr. N.P. Gupta sir, Anand Raja, Dr. Suman Malik, and Dr. Somnath Roy to be the chairpersons. And I'm going to start inviting the speaker, Dr. Keval Patel. Piche. Okay. And we are going to alternate the podium so that they are already set up. So one speaker starts there, then the next speaker will be on the other side. Dr. Keval, I want to know what is the, it's on the other side, isn't it? Okay. What is the standard of care for a clinically N1 penile cancer in 2024?
At the outset, I'd like to thank the organizers for providing me this opportunity. And basically, so I'll be talking today about management of CN plus and not N1 in carcinoma penis. So I have no disclosures to reveal. The conventional definition of a staging, clinical staging is based on clinical findings. That is, in case of carcinoma penis, it will be palpable lymph nodes, whereas pathological staging is based on histopathological examination after definitive surgery. Now, the management of lymph nodes is a bit tricky in case of carcinoma penis. Let us understand with these two case capsules. The first one, they are similarly looking capsules. The first one is a 57-year male, a low socioeconomic class, coming from rural Ahmedabad, 2-centimeter ulcer over corona, presenting with palpable lymph nodes. Ultrasound shows 1.2 centimeter size lymph node with preserved fatty hyla, and biopsy is showing moderate differentiation with LVI positive. The second capsule shows, again a 57-year male, low socioeconomic class, coming from rural area, 2-centimeter growth now over glands. It's again palpable lymph nodes. Ultrasound shows 1.5 centimeter nodes, positive preserved fatty hyla, and biopsy showing well differentiation with no LVR or PNI. So now if we go by the guidelines of palpable lymph nodes management, like both have to be managed in the same way. So let us take opinion of the house. How many of us would advise FNAC in these cases? So I think most of us would do that, and I also did that. There was no opinion possible. Again, with negative FNAC or no opinion, what will we do? Again, we'll advise for a biopsy. There was a single lymph node which was negative. Again, the same dilemma exists, whether we should do lymph node dissection or observe these cases. Both the cases are having palpable lymph nodes. So now before adapting any guidelines, we should understand our own population first. So Indian population is quite different from the population of the West. I quote here a paper from an Apex Institute, AIMS. They did a retrospective study of 102 cases, and they found out that 58.8, that is 60% population of our countries, of CA-penis comes from rural area. 47% have no formal education at all. 70% of them present with palpable lymph nodes. However, of all the patients who come from rural and don't have a formal education, all of them present with higher stages presentation and have higher chances of nodal metastasis. So these aspects has to be taken care in our patients. Secondly, of the 70% which have clinical lymph node positive, only 40% have metastasis. As compared to the West, where 70% of the patients who present with palpable lymph nodes, almost 80% of the patients who present with palpable lymph nodes have inguinal lymph node metastasis. So with that background in mind, we did analysis of our own cases. We did analysis of 125 cases, divided them into 2 cohorts. And then from previously published literature, we derived some parameters, and then did a univariate analysis. All the factors which are significant were progressed to multivariate. And then we found out some 8 factors which are listed in the table, which were significant for inguinal lymph node metastasis in multivariate analysis. And then based on the regression coefficient, we assigned them score. Based on the lymph node positivity, we divided them into low, intermediate, high risk. To validate our own scoring, we did a prospective validation of over 100 cases, and these are the findings. We'll concentrate only on the palpable lymph node table. So even if the lymph nodes are palpable and the CRIS group is high, 87% of the patients will have positive lymph nodes. Whereas if the CRIS group is low in palpable lymph nodes also, we didn't find any lymph node metastasis. So again, if we come to our case capsules, if we assign CRIS score to all case 1, the CRIS score comes out to be, okay. So CRIS score is 6 based on the assignment of the scores in first case, whereas it's only 2 in second case. So now, as we can see, even though the lymph nodes are positive based on CRIS score, the management changes. So now we know, is palpable lymph nodes alone enough to classify clinically node positive cases? I think the definition needs an expansion. And what are the scopes? We can include FNAC positive lymph node detected cases or biopsy SLNB positive cases, and clinically they are not node positive. Then superficial inguinal lymph node dissected cases and high risk CRIS group cases. So we can include that in clinically node positive cases for better management of our patients. Now there has been a lot of controversy going on regarding the timing of ILND. Classically, it was always done with penectomy. All oncosurgeons, they want to do ILND along with pelvic. But which are the cases, because since ILND is associated with too much of complications, which are the cases in which we can avoid that? So most of the time, CRIS helps the cases to identify which can we avoid simultaneous or concomitant management. But I like to quote a recent paper from America. They compared concomitant versus staged therapeutic lymphadenectomy in case of clinically node positive cases of carcinoma penis. It was a multi-center, multinational study of 253 cases, and they concluded that there is no difference in any survival, recurrence-free, cancer-free, or overall survival. However, before contemplating these findings in our practice, we should have a caution, because the study period was too long in these cases. The heterogeneity was not addressed among the practices. 16% patient had missing data, 30% underwent only unilateral IND. The cause is, the indication is not known, and the Cox analysis was not adjusted for histological features. Again, interest is being generated in minimal invasive methods for treating inguinal lymph nodes in this segment as well. I'll quote some data from our country. So way back in 2018, a paper from RGCIL, they compared robotic versus open inguinal lymph node dissection. And they concluded that the known yield is same, the morbidity is less, but it only in cases with non-bulky lymph nodes. Yuvraja sir compared it with whale and open inguinal lymph node dissection, and they found that it is safe, it is associated with less complications, and the survival outcomes are equal. We did a meta-analysis of at least 8 cases, 8 studies, and 2 were RCTs, where 6 were cohort studies. And from our meta-analysis, we concluded, this was in 2021, and we concluded that the minimal invasive lymph node dissection has lesser skin complication, lymphedema, and better lymph node yield, but that does not translate into survival advantage. Also, the incidences of lymphocyl and recurrences are the same. The latest addition to this is another meta-analysis, but it again says that multi-centric studies are needed for further confirmation of the findings. So, in absence of high-level evidence, minimal invasive ILND should be performed at high-volume centers and not in bulky lymph nodes. Now, last 2 slides of my presentation. Now, 2 slides regarding pelvic lymph node dissections. The traditional indications have been radiological evidence of pelvic lymph nodes, or a biopsy-proven pelvic lymph node, or more than 2 inguinal lymph nodes, and presence of an extraneural extension in the histopathological examination of inguinal lymph nodes. If we look at data from our country, recently a paper came from TNH which studied 56 patients, and it was a retrospective study. But they found that more than 5, not 2, more than 5 positive lymph nodes are important predictor of pelvic lymph nodes. We studied inguinal lymph node ratio in our patients of 56 cases, and we found that ratio of more than 0.25 was better than positive lymph nodes alone. And when it was combined with ENE and LVI of the primary specimen, ENE of inguinal lymph node and LVI of the primary specimen, the specificity increased, and the probability of finding lymph node increased from 0 to 83%, if from 0 to 3 risk factors respectively. So the take home, yeah, I have not included NACT because of time constraint, but we do NACT in cases where the lymph node size is more than 4 centimeter, they are matted and they are fixed. So take home message from my presentation is that Indian population is heterogeneous as compared to West. The definition of CN+ has a scope of expansion to include FNAC, biopsy, SLNB, SILD proven cases, and high-risk risk groups. Thank you.
Anandraya, sir, any comments?
Yeah, so I think the whole idea about the CN+, which comes from Western literature, I think that entire thing is inapplicable to the Indian scenario. For the simple reason that people in West don't have palpable nodes. Our studies, the one that we published from our center, as well as studies from Tata that have been published, even from other centers, have said that in an unselected population with patients with penile cancer, when they come to your OPD, about 40% of those patients will actually have palpable lymph nodes. So the whole trick here is to find out. So we cannot use, even the impact trial does not use a pathological, they don't say it should be PN+ before you treat. They treat any CN+ as a malignant node. So the entire idea is to see in those 40% of those patients who have a palpable node, whether it is actually pathologically positive or it is actually pathologically negative. So that's the whole idea.
Yes, sir.
So, the first thing there that we need to do is to identify whether that is CN+ or PN+. Again, if you look at the EUA risk stratification systems, whether you need to address the nodes or not. So that is based on the EUA risk stratification.
That is in PN0, CN0.
CN+. So EUA would tell you that you have to address them because it's a positive node. Whereas in the Indian scenario, you don't necessarily need to address any or all of them.
50% may be negative.
Just a critical appraisal of the CRIS score. I don't do that much of prenatal practice, and he knows everything about it. You know a bit more about. Do you think that's applicable and we should be using it more regularly?
I've been talking to Keval. His CRIS criteria, I think, is very exciting. It's something that's very, very new. And we are trying to see in our own data set whether we can validate the findings that they've come across. It's something very, very novel. and we're trying to validate that in our own center.
Yes, sir.
Thank you very much. Thank you, Kay.
Thank you,
That
sir.
was brilliant. So we move on to Dr. Mahendra Pal talking about advancement in testicular cancer.
Good morning, everyone. So the talk is on advancement in treatment of testicular cancer. So I'm just going through this shift in incidence, what going to happen in CA testis in 2026, and we found that if you see the graph, the red line basically, the red line shows the age group of 25 to 35, and the blue and the second graph, blue and red, they show NSGCT. Again, age group 15 to 35. Only NSGCT is going to be rise by 2026, and the last one is the seminoma. It is going to be stationary. And NSGCT is, we all know, is more lethal than the seminoma. So this insight, the rising incidence of the cancer, is giving us, we should do something new or something different and do something advancement in the management of CA testis. So coming to that, the first is the improved understanding of the genomics. So I found this article which read about the alternative splicing and the somatic mutation in the TGCT, and they found that embryonal carcinoma and the seminoma, they harbor a different set of genes, a completely different set of genes in their pathogenesis, and maybe this gives us insight for the further treatment like immunotherapy or the targeted therapy in the future, and also about the diagnosis of the cancer. Coming to new marker, novel markers, mRNA, very extensively studies in last maybe through 3 to 5 years. And there are, basically they found miRNA, RNA 371 to 371 through cluster is the most important related to the GCT. This study found that the miRNA 371 3P is more consistently found in seminoma compared to NSGCT, and among the NSGCT, it is the embryonal carcinoma that reflects more miRNA compared to the other NSGCT. So again, this will mean the diagnosis purpose, it will be useful. Teratoma, it is a different domain. Teratoma doesn't have raised tumor markers, and it is chemoresistance. So can we predict this better with the miRNA? So this review article studies multiple studies, and it concluded that if we combine the miRNA 371 and 375, it may enhance that we can identify the silent killer before it becomes inoperable. And you all know who treats teratoma and RPLND, the growing teratoma syndrome, how difficult to manage. Something new, it is T cell. This study found that T cell indulging the Treg and TFH is the most abundant in seminoma, but less abundant in the embryonal carcinoma. So again, this targeted study may be in future give us an insight into that targeted therapy T cell related in the testicular cancer. Now coming to update advancement in the IGCCC group. So in the seminoma group, what they have done new is now it is now called as IGCCC 2 group changes. They did that LDH in seminoma, they divide into more than 2.5 and less than 2.5, which was more than 10 times of the normal value. And they found that there is a 12% increase OS survival if we divide the LDH in this group. And we see the right box. For the good risk, there is a 7%, and for the intermediate risk, it is approximately 8% survival benefit is there if we apply this grouping score. Coming to NSGCT, what they did, they include the older age and presence of lung metastasis. And again, they divide the LDH into the less than 2.5 times, more than 2.5 compared to 10 times previously. And if you see the poor group, in the poor group, there is a OS benefit of 13% in the PFS and approximately 19% benefit in the overall survival group. So this advancement has been done in the IGCCC group classification. About the technique, we know the robotic is the only advancement in the RPLND, and in the RPLND group, I would like to highlight this technique, and the surgeon doesn't need any introduction. It is a robotic assisted supine extraperitoneal RPLND, which was done as an advancement in the technical surgical things in the RPL, management of RPLND. Role of RPLND in seminoma, this is something emerging for past couple of years. And this review article highlighted the trials going on in the RPLND seminoma, which are the in prime test, SAMS, COTRIMS, and Royal Marsden. So what is the common thing in that? They all included the patient in the seminoma stage 2A and B. This is a primary RPLND. They are not post-chemo. They are all the primary RPLNDs. Treatments were done either open on the robotic. Interesting thing is that all surgeries are null-sparing RPLND, either modified or unilateral. And if you see the median size, approximately 3 centimeter, the only drawback of these studies are very short follow-up. Only Royal Marsden study has a follow-up of 51 months with PFS is 94% compared to other with the 70 and 80% around. Time of recurrence is between 6 to 14 months and all managed by the adjuvant chemotherapy. And complications were 4 to 12% like that. So this review article concluded that in men with the stage 2 seminoma, RPLND is an emerging treatment option for reduced long-term toxicity compared to the RT and the chemotherapy and can be feasible for the selected patients. Now coming to RT in seminoma, what is new going on? This is a study from the Tata Hospital, documented by Dr. Vedang Murthy. This is PROSEM. So FDG PET-based adaptation studies for the post-chemotherapy, either RT or the radiation therapy. So SUV max 3 is a cutoff value. Recruiting is still going on. The important thing is that in this study, also included serum miRNA 330 we let you see how it's going to affect the further management post-chemotherapy residual mass in the seminoma. Chemotherapy. In chemotherapy, the new update is that standard versus accelerated therapy. That means instead of 3-week, give every 2-week therapy. The result are this accepted in 2025. The Tiger study, it is going to compare with the standard study with including the cisplatin or paclitaxel based study in the future, but again the results are awaited. There are many more chemotherapy agents are being tested like cabozantinib, brentuximab, vedotin, and Swantokia AVC trial is going on, SAKK01, SEMI-TEP trial, and again maintenance oral etoposide drug in HCT is also going on. But it will take time us to know what are they, how much they are helpful. So in conclusion, based on the current advancement in the testicular cancer, I like to conclude that we all know GCT presents a unique cancer in terms of their dynamic biology, diagnosis, and achievable cure rate, we all know. Advancement in the understanding of molecular basis and pathologies chemotherapy, chemoresistance may lead to develop new drugs and new techniques. Define surgical procedure, I really do not know what is the next level of RPLND in future, and the new indication and other things. Innovative biomarker has been discovered, and maybe they will implement clinically very soon. And new method of chemotherapy strategies are emerging. So overall, the all advancement of the testicular management should be there to achieve the more better survival with minimal complication, whatever we have at present. Thank you.
So thank you, Dr. Pal, for excellent presentation. So I have one question that regarding the chemotherapy in the germ cell tumor seminoma, as you mentioned, the newer approaches like 2-weekly P regimen, or there's brentuximab vedotin data, or the other comings. So is this, or is there, I just want to know, is it randomized control trial is going on, result is published, or the biomarker based escalation or de-escalation of therapy?
So at present there is no RCT has been done about the biomarkers are concerned. About the chemotherapy, it's a Tiger trial and the first trial, they are going on, but still results are awaited. So we really do not know how much they are benefit, but trials are going on for the chemotherapy.
So the future results will come in this?
Definitely, definitely.
And the biomarker-based approach is also tested or a trial going on the randomized control?
So there's no RCT, there's a comparative studies are there, and they found that the largest study for the teratoma, that study has 51 patients, and they found that if we mix the two biomarkers, we can identify the teratoma component by the plasma may have in the body or not.
Mainly the siRNA and this, as you mentioned.
MI, it is miRNA, miRNA.
I think Dr. Jagdish Kulkarni has a question.
Mahendra, the question which is lingering since 80s is what happens to the progeny? Have we progressed on that line? Because this is one tumor where we need to have that answer now by now.
Yes.
Can we do genetic manipulation in progeny if it is likely to be, or can we prevent it? This would be the answer we are looking at.
Yes, sir.
Just one question, either you or Dr. Vedang is there. So that is on that randomized trial on seminoma that you have taken ACUV value as for randomized or for stratification. So we know that ACUV max is very non-specific for and different from different machines. So how can you take it further?
So we had to have some value to enter the patients into the trial to randomize, and this was based on our retrospective data that somewhere between, if the SUV is somewhere between 3 to 3.5, the chance that actually harbors disease is about 30%, 30-35%. So I know SUV varies, but this is being done in one hospital only. We are also doing something called as the TL ratio. Tumor to liver ratio as a method to validate that. So, but I know it is arbitrary.
Hi, Mahendra. You spoke about microRNA in testicular cancer. In your opinion, what do you think the microRNA is going to play a role in future? What exactly its role will be?
So sometime where we are clinical dilemma is there, like recurrence is there, not some very small RPL node is there, post-chemotherapy, whether to operate or not to operate. I think there we can use that about the recurrence. And maybe in future, they may replace the tumor markers in deciding the disease progression and the prognosis. So at present, they are proposing this miRNA as a patient prognosis, the disease response, and the pathology.
Maybe for actually retroperitoneal lymph node dissection, when you operate in post-chemo setting, you actually find viable tumors in 15 to 20% of the cases, and another 40 will be teratoma. Rest around 40% of the patient are only necrosis. So it's not for actually less than 1 centimeter or 1 centimeter recurrence cases. Even in primary post-chemo setting, we do actually RPLND unnecessarily in around 40% of the patients, those actually come out to be only necrosis. The microRNA may be actually able to tell us whether actually we should undertake this bigger a surgery for 40% of the patient, which is actually of no benefits. The microRNA, if you can actually more sensitively tell if there is any viable disease in the patient.
So for that, still we don't have that comparison.
Yeah, but
about
that's
the
actually
nodal
what
and
its
NAT.
role is going to be.
Yeah, one more thing I want to highlight, one stage, one condition.
We have got 10 minutes at the end.
Okay.
Sorry. As Amandeep walks up to the stage, I just wanted to ask Vedang for clarity. When do we do this PET CT? What time in the overall time scale of the patient management?
I'll tell you, it should not be done early.
Yeah.
You should give at least 8, preferably 12 weeks after
12
chemo, because there's a lot of false positives otherwise.
So at around 3 months is when...
3 months is FDG PET, and based on that SUV, there is no standard. Some would observe, some would needle it, some would think about it, some would fret a little, but there's no standard.
But not to do early?
No, not to do early.
Okay. Thank you.
Hello, yeah. Good morning. So I've been asked to speak on the management of CN plus prostate cancer. So when we do have a patient with node-positive prostate cancer, these are the questions that come to our mind. Whether our patient actually is CN plus, and these are around 10% of the patients that we have in our OPD. Should they be getting intensified systemic treatment beyond just ADT alone? Should they all also get local therapy? And if yes, then what should that local therapy be? Over the next 10 minutes or 8 minutes, we'll go through the entire story of CN plus and see if we get answers to these questions. So once upon a time, which was not so long ago, till 2015, CN plus prostate cancer was considered metastatic disease. And it was managed as widely metastatic disease and treated only with ADT. Some patients also did receive RT, and that is why we had 2 retrospective cohort studies published in 14 and 15, which compared ADT alone versus patients who got ADT plus RT from the SEER and the NCD databases, and we know how confounding these databases can be. But the final conclusion was there is some OS benefit of adding RT to ADT. So we had some retrospective evidence that adding RT to ADT helps in CN plus prostate cancer. Around this time, the STAMPEDE trial was recruiting, and it was testing ADT alone versus ADT plus some multiple agents in advanced prostate cancer. So it included patients who required long-term ADT, and this also did include some N plus M0 prostate cancers, the patients that we're talking about right now. So not all patients in STAMPEDE were metastatic. So the first prospective evidence for these patients came out in 2016. So what did this paper say? It looked at only the non-metastatic patients in the STAMPEDE trial in the control arm. So the control arm of STAMPEDE had only ADT. But for the non-metastatic patients, they were also getting RT. So some patients were getting ADT only, non-metastatic, and some non-metastatic patients were getting ADT plus RT. So they wanted to see these non-metastatic patients. So 157 CN plus, but M0 patients, 71 got ADT plus RT, 86 got ADT alone because it was not standard of care at that time. And they found that adding RT has survival benefit. And the conclusion was that routine use of RT is supported in patients with N plus M0 prostate cancer. So from retrospective evidence, we now had prospective evidence that adding RT to ADT helps in non-metastatic, node-positive prostate cancer. But STAMPEDE was about intensifying systemic therapy, right? So these were the arms in STAMPEDE. Let us look at this arm, standard of care plus ABI. It began recruiting around 2012, recruited till 14 and published in 17. So we looked at the control arm. In the control arm, the patients were getting only ADT, right? This is our landmark paper in 2017, based on which we said that patients with metastatic prostate cancer should not be getting just ADT, they should be getting ADT plus ABI. But not all patients were metastatic, right, in the STAMPEDE trial. Some were non-metastatic. 27% were N0-M0, 20% were N plus M0. 47% patients in STAMPEDE were M0 patients. For these M0 patients, they found that there is a non-significant OS benefit by adding RT to ADT plus ABI. So hazards ratio was 0.75. This OS data is not very mature. So now we for the first time had prospective randomized trial evidence. So from retrospective data, which told us that adding RT to ADT helps in N plus prostate cancer, we then moved to prospective data from the control arm, which told us that RT to ADT helps in N plus prostate cancer. And then now finally, with the abiraterone arm, the treatment for N plus prostate cancer in 2017 became RT plus ADT plus ABI. But the overall survival benefit of adding ABI, the data was not very mature, as it was mature for the metastatic patients. So after this was published, radiation oncologists began looking at their own cohorts and whether ADT plus RT was having benefit over just ADT alone. And we had multiple papers published accounting for about 4,000 patients, and all of them said that addition of RT improves RFS and OS significantly when RT is added to ADT and not just ADT alone for our N plus patients. So this is what happened. A lot of papers, started coming from radiation oncologists looking at their CN plus patients. So the surgeons were not to be left behind. They said, we have our N plus patients for whom we have been doing prostatectomy as well. So they began also digging into the databases. So we had this first really good paper which came in for association between radical prostatectomy and survival in men with clinically node-positive prostate cancer. Let us not read this. Let us look at what I've underlined. US National Database. So the surgeons now dug into the database. They found that, we have 741 patients who were CN plus, and we've done prostatectomy in them apart from giving ADT. And the conclusion was RP is associated with favorable survival outcomes. Surgeons went a step beyond. They said, let us compare these CN plus patients based on whether they received RT or whether they received RP. So they looked at the SEER database. They found that they have 3,500 patients, CN plus, who have had RP plus ADT versus 1,100 patients, CN plus, who have had RT plus ADT. They did some propensity score matching, otherwise the paper would not have been published. They were left with 894 patients on each side. And this was the conclusion. RP may hold a CSM advantage over RT in CN1 prostate cancer patients. And these were the potential other advantages with RP, that you have more accurate staging You can tailor the adjuvant therapy, and you may also relieve LUTs. So now what should the guidelines be saying today? We've seen all the evidence that has happened, and we should probably be saying that RT, RP both are fine, and probably RP is better than RT, right? This is what the AU guidelines say in 2024. Offer radiation therapy to the prostate plus pelvis in combination with long-term ADT and 2 years of ABI to CN1 patients. AAU guidelines in 2024 do not even speak about radical prostatectomy in CN1 patients. Till last year, they were saying that RP could be offered to select patients. And why so? Because the only prospective evidence is coming for RT from the Stampede trial. But even that evidence is a subgroup analysis, which was an unplanned analysis, and the OS data in that subgroup is also not yet mature. The NCCN guidelines also say that EBRT plus ADT plus abiraterone is preferred, but they also say that EBRT plus ADT could be offered. You may not give ABI, again because the OS data is not mature. RP could be offered in selected patients as per the NCCN guidelines. So we've seen the story. What are the problems with this story? We had this systematic review about all these studies published just 2 months back in European Urology Oncology. The problems are, all these studies have been using conventional imaging, but right now we are using PSMA. There is no standard definition of what was CN1 with that conventional imaging. Some studies said that a node more than 10 mm is CN1. But with this, we have seen that when you take that 10 mm cutoff as calling it a positive node, only 33% of your patients would actually be PN1. The rest would just be reactive enlarged nodes. The duration of ADT in these studies was variable, and not even all patients got the ADT along with the local therapy. What about abiraterone, right? The Stampede trial used abiraterone, but none of these retrospective studies give any evidence about how many patients got abiraterone. And CN1 is a spectrum. You have this patient with a very small node, which might be CN0 as per your conventional imaging, and then even this patient is called CN1. Both these patients are not the same, right? So in the future, we might have CN1 broken down into N1, N2, N3 as we have for other cancers. Do we have any data for PSMA in CN1? I just found one abstract which was published in 2024 EAU, and they said that 9% of their patients were downstage to PN0, but the oncological outcomes were not very great, but they also did not mention how many of them got ADT and ABI. The moral of the story is that we don't have answer to what are our CN1 patients because we do not use the imaging modality that is mentioned in the guidelines. Should they all get ABI? Probably yes, because Stampede said so. Should they all get local therapy? Definitely yes. What should that local therapy be? Probably RT, probably RP. What we need is this. We need an arm with ADT plus ABI plus RT. We need arm 2 with ADT plus ABI plus RP. The thing is, we're not getting this answer from the US or the UK. We'll probably have to find this answer on our own. Thank you.
Thank you, Aman. Again, in clinical suspected lymph node positive patient, see, the surgery gives us the accurate histopathology.
Yes.
I think so. Definitely, where there is a doubt, surgical treatment should be the first modality of the treatment.
Yes,
according
sir.
to me.
Yes, sir, but we do not have any evidence to back the statement. We are all doing it in our clinical
now,
practice.
Probably a study is going on in future, so we'll come to know in due course of time. But you know, when you are giving radiation therapy, you are just presuming that lymph node is positive, which may not be positive at all.
Yes.
So that's why the surgical option is a better option according to us.
Amandeep, so how you select your patient between RP and RT in CN1 or N+?
Right, sir. So, sir, as I said, CN1 is a spectrum. For someone sitting with multiple nodes, big nodes, which would also be CN1 on conventional imaging, level 1 evidence is that you give RT as the local therapy. But for somebody with a very small node lighting up on PSMA, which is probably positive, probably negative, both options can be offered because this patient would probably be CN0 in my practice. Again, sir, for small one node lighting up here and there, both local therapy options can be offered. But for someone with obviously enlarged or multiple enlarged nodes, the local therapy would be RT.
So it does not have any impact of T staging and the Gleason grade. Also, I think.
So I think once you have multiple enlarged nodes, the T stage is a secondary factor for the prognostication of the patient.
So I have one question. Yes. So selecting patient in abiraterone and node positive disease, are you favor only looking the node positivity or any others risk factor like Gleason, like baseline PSA, like these things? Is any risk factors like T size for selecting patient with only node positive prostate with the 2S abiraterone?
Thank you. I just want to give, yes, go ahead.
Yeah,
Dr. Arora, thank you for this wonderful presentation. In our practice, what happens is that patients who get a radical prostatectomy for a CN1 or a PN1 patient almost always have adjuvant radiotherapy.
Yes.
So it's not a single modality,
Yes.
local therapy anymore, it becomes two modalities. So that's one thing that has to be kept in mind. And second point is that when we look at data from Stampede or data from these trials, somehow, our results, and I'm pretty sure if you ask Dr. Vedang, our results with, ADT plus radiotherapy for CN1 patients is more than 80%. And in direct contrast to the approximately 60% or 65% that we get in these studies, we don't know why, but our results without surgery are very good. The third thing is that when you have bimodality local treatment for CN1 patients, you are also at risk of increasing toxicities.
Yes.
And that also has to be kept in mind.
Yeah, so,
Aman,
okay.
I didn't want a debate, I wanted an equipoised talk, and that was brilliant. Raghavan, statement.
I'll go away.
Okay, thank you very much. That was brilliant. We'll move on to the next one. Now that we have done a radical prostatectomy and we've got a pathological N1, what do we do as the next step? Thank you.
Good morning, everyone. At the onset, I'd like to thank the organizers for giving the opportunity. So to begin with, the topic is management of P and N1 prostate cancer, and I must congratulate Dr. Amandeep with a beautiful CN1 presentation to be done. And this is the way I'll progress. What is the trends in the prostate cancer stage migration? What is the natural history of the pathological lymph node positive cases? How to manage the PN1 disease, and what are the guidelines relating to PN1? A beautiful paper published a couple years back from Germany by Tilke et al. It did show that 20 years trend in prostate cancer stage and grade migration has changed. And what is the change is that from 3.7% it has gone to 10.5% in 20 years, and the number of patients were 21,000. And this is because the surgeons have really done a fabulous job by increasing the rate of prostatectomy. Now, how do we manage once these PN1 patients come? And this comes from the study from the Zareba et al. From MSKCC. It's a national cancer database study in which majority of the patient, as you see on the left, is managed by observation or by ADT alone. If we classify it further, it looks like the patients who are having a higher grade tumors were more likely to be treated with ADT alone than either observation or RT or combination therapy. Men with higher stage tumors with or without positive surgical margins were mostly treated by combination therapy than observation. And finally, men with higher positive lymph nodes were managed with ADT alone as compared to other modalities. When we talk about the ADT alone in the PN1 disease, we do expect that PN1 disease have traditionally, they are thought to have a widely disseminated disease, and consequently they will have a poor prognosis and poor outcome. And that exactly, this paradigm led to the ball rolling of this trial, that is ECOG 3886, which did see that patients who were given immediate ADT versus delayed ADT, there was a survival advantage if the patients were given ADT immediately post-op. However, there was a contradictory result because other retrospective observational studies, both the studies from Italy, did show a result which was not like the ECOG 3886, and this suggested that immediate and lifelong ADT represents overtreatment in many men, and that further treatment must be individualized based on the risk factors rather than giving blanket ADT to all. This was also like, what is the long-term outcome with the patient who have a lymph nodal metastasis and who have not been given ADT? 28% of the patients with a pathological lymph node positive will remain disease-free at 10 years. And most recurrences, if it has to happen, it will be happening in the first 5 years. And higher pathological Gleason score, the number of positive lymph nodes which is high, will have increased chances of biochemical recurrences and also metastasis. And 10-year survival will be to the tune of almost till 60% plus. Now, what is the role of adjuvant radiation as an additional benefit to ADT in PN1 disease alone? Now, if you look at this paper from Briganti et al. From Italy, adjuvant RT definitely adds benefit to ADT in PN1 disease. And this benefit is not only in the terms of cancer-specific survival, where your ADT is added with RT, but also the survival is in the terms of overall survival. And this is something really encouraging. However, this study was based on the propensity score matched analysis based on the surgical staging, T-stage Gleason's case, and other parameters were also included into it. The same thing was also exhibited by Toggier et al. Again from MSKCC, where the patients were observed, and what it was seen that men with lymph node metastasis treated with adjuvant ADT and RT has a better overall survival than observation or ADT alone. So adding ADT to RT definitely has an advantage. Again, Tilke et al. Published 2 years ago in JCO, where she searched the question like, which is better? Is it the adjuvant RT or is it an early salvage RT? And this question came because we lacked level 1 evidence regarding the timing of radiation, where we prefer to give adjuvant or we are planning to give early salvage. And the result was, again, it was very encouraging, where it was shown that adjuvant RT was associated with a significant reduction in all-cause mortality compared to early salvage radiation therapy. And the magnitude of reduction was more if the number of lymph nodes were more, to the tune that every additional lymph node that had an advantage of nearly 8% by adding RT. And men with having higher lymph node, that is 4 or more lymph node, appears to be having a beneficial effect by the use of adjuvant RT. Now, the next question is like, should the adjuvant RT be used with or without ADT in PN1 disease? And here we have a contradicting data. If you see on the left side from Bravi et al. From Italian study, they did show that if you add RT with ADT, you might not have a difference in overall survival. But on the right side, the paper from US by Wong et al., it did show that if radiation is added to ADT, it has an advantage in the terms of overall survival. So these are the contradicting data, whether adding RT really gives a benefit or not. Then the question arises that what should be the duration of ADT, or can the short course duration be equivalent to the long course duration? And this paper was published just in Lancet in May this year itself, called as Radical HD trial. And Radical HD trial found that addition of 6 months of ADT did not improve metastasis-free survival, and these findings are not sufficient to routinely recommend the use of short-course ADT with post-operative RT. So it was a bit disheartening because this trial was eagerly being waited. Now, what is the role of chemotherapy in PN1 disease? And the answer comes from SPCG12 trial, where the patients were randomized of high-risk patient into docetaxel for 6 cycles versus observations, and the median follow-up was good, 56 months plus, but the result was negative. There was no improvement in biochemical disease-free survival. This can also be attributed because the high risk, what it has been called, it also includes PT2 and T3, Gleason score 4 plus 3 plus 8 to 10. So there can be a masking effect, but still there was no improvement in biochemical survival. One paper which we all will be eagerly waiting, called as innovative study, that is NRG-GU 008 study, which accrual is going on. And what is unique about this study is that it includes specifically PN1 disease and a detectable PSA. It has 2 arms. One arm will be having RT plus ADT for 2 years, and the other arm will be having RT plus ADT plus systemic agent, that is apalutamide, for 2 years. So we'll have to wait for few years more to really see what is the result of this paper. I like to conclude my presentation with this systematic review published again a few years back, where if we see the PN1, which includes almost from this study 26 studies, 12,000 patients, it is really heterogeneous group.
And if we see, majority of the men with PN1 disease experiences biochemical recurrences after surgery, and long-term disease-free survival has been reported in very selective patients. Use of adjuvant RT with or without ADT has shown to improve overall survival in men with locally advanced and a higher number of positive lymph node, but risk stratification should be the key. Even if you look at the guidelines, we have a muffled guidelines because the present in 2024, the European guidelines for the PN1 still says that all the options can be there, like observation, adjuvant RT, and RT plus ADT, and the strength of rating is still weak. So it is something which is a contentious issue. We don't have an answer, but this is what the evidence says. Thank you so much. So if you have to summarize the evidence, a patient who's had an RP comes to you with a node positive, what would be your practice? Would you stratify it just as P positive, negative, or would you consider other factors to come to a treatment algorithm? What is your current practice? So even Dr. Indranil also did mention that it is not wise to delay the observation certainly not, but the number of lymph node positive will be a big factor to decide. But irrespective of number of lymph nodes, still as present we don't have an evidence, but still ADT plus RT, or at least RT, should be the way forward.
No, if there is only 1 or 2 lymph node and his PSA has come down to 0, will you like to wait or you want to start immediately?
It becomes a controversial issue in that if the PSA has gone down to 0, we can still wait and plan for an early salvage RT rather than immediate RT.
Shahid,
okay, thank you.
You said short course is not good. So now what is long course? How long? ADT.
We are, so as of now, at least 2 years is the long course what we are looking at.
At least?
At least, yeah.
So, and maximum?
Maximum 3 years, that's what.
Okay, so in these cases, just relugolix will do, or any studies on that? Because just a tablet, keep going however long, because you will have to give 3 years of hormone post radical prostatectomy. You're going to waste that person.
Absolutely.
So, see, it's not all easy. So we should have some evidence to say, 2 years or 3 years. Do we have any?
I think the evidence is the evidence is for 2 years, isn't it?
Evidence is for 2 years as of now.
2 years.
Yeah.
Yes.
So
2 years.
Yeah. What's the data on intensification of hormones? So single versus doublet.
In the adjuvant setting.
In the adjuvant setting,
Escalation of hormonal therapy.
Hormone therapy escalation. So single agent or doublet, what is the evidence? Where are we going?
Sorry, sir, I did not get that question.
In the adjuvant setting, do we just go with ADT plus RT or ADT plus and RT? So, do you want to advise any androgen receptor pathway inhibitors?
Like addition of abiraterone, enzalutamide, or apalutamide.
Okay. As of now.
So as of now, the evidence is ADT plus RT. Now, adding further agents for PN1, still we don't have an evidence. Like as I told, NRG GU 008.
Thank you. Thank you very much. We'll move on to the next one. That was brilliant, sir. Management of, I should have corrected, apologize for writing CN1. These are all CN plus with RCC, clinically lymph node positive RCC.
Thank you, sir, and thank you, the SOGOCON organizers, to give an opportunity to talk. So I'm medical oncologist, disclosure. Other than that, surgical questions Dr. Anand will take. So in RCC, most of the metastases are hematogenous, and lymphogenetic spread is very rare. Only one RCT which is done, which has shown 4% of 400 patients. So any node positive, irrespective of T, it becomes stage 3. Any node positive with M1 becomes stage 4. This is the prognosis. So guideline wise, NCCN says that regional lymph nodes should be optional and should be considered for patients who have resectable lymph nodes during preoperative screening or palpable or visible lymph nodes during the time of surgery. Whereas EU says the statement they'd make is still the role of lymph node dissection is controversial. and only one study, that ERCT study, where they looked closely the randomization for patients who underwent a dissection or no dissection. There was no survival benefit. There was only 4% incidence in that 400 patients, and there are a lot of other studies which were retrospective, which have shown survival benefit, but those are all retrospective studies. So coming to managing a clinically lymph node disease, so when you do, chances of them being positive is from anywhere 0 to 25. It depends upon the size, grade of tumor, necrosis, and presence of distance mat. It is justifiable if we have a visible or palpable during surgery. And now with adjuvant therapy available, it can be used for adjuvant therapy or immunotherapy, or at least for staging and prognosis. We're coming to the lymph node positive, which are on imaging or on the pre-op. Definitely the chances of picking up is 10 to 54%, and this same indications are justified for staging, prognosis, and adjuvant therapy and follow-up indications. As of now, neoadjuvant systemic therapy, there are no trials other than clinical trials are not recommended. The systemic review have shown that adjuvant radiation therapy for these patients who are node positive are no evidence. And coming to the RCT randomized study for using adjuvant TKI, there are at least 6 studies, among which only one study, that is the extract study, where they did sunitinib versus placebo. It had shown demonstrated a DFS benefit, but which is not reproduced in ASSURE study. So these are the studies, extract study, where they did compare sunitinib with placebo. This is only one study till date which has shown DFS benefit without OS benefit. Rest is ASSURE, which is done subsequently after the extract, which has shown no DFS benefit. SORAS, mTOR inhibitor in Everest pathway, the everolimus was done, PROTECT, pazopanib, and adjuvant axitinib. These all studies have failed. Various treatment duration as well as the subset of patients were included. With this data, there is no recommendation to do an adjuvant VEGFR or mTOR inhibitor. There is a school of thought where we offer sunitinib for patients who cannot afford immunotherapy, but recommendation wise, they are not strongly recommended. The main reason is the adverse effects. Almost more than 30 to 40% of patients will have side effects, at least grade 3. So coming to IO therapy, so there are 4 studies which have looked closely immunotherapy in node positive, which include a subset of node positive RCC in them. Keynote 564, IM01. So in Keynote, there was pembrolizumab 1 year with placebo. In that, they include node positive. Almost 4% of patients were node positive. Whereas atezolizumab study, Prospero nivolumab study, and nivolumab and ipi perioperative immunotherapy. So among all these 4 studies, only the Keynote study has survival benefit as well as DFS benefit. We're going to look closely. This was a phase 3 study, multicentric study. It was placebo controlled study where they include only clear cell histology. No non-clear cells were included. It was post nephrectomy, and the risk stratification was done by Levy score, and only patients who were on high, intermediate to high or high risk were included in the study. And for our question, lymph node metastasis. So if in the overall study, out of 400 patients, only 31 patients on each arm were the patients who were lymph node positive included in studies. And they were not very clear in these patients whether their other systemic mets were there or not. So I looked closely that metastatic site profile, there are at least discordance between the pembrolizumab AB and as well as in the placebo arm. So what it happens is lymph node mets are more in the placebo arm compared to a pembrolizumab arm. So it's not very clarified, but that's the data. So what they have seen is based on this scoring they've taken. So there is clear-cut DFS benefit. So 77% of patients were having no recurrence or progression or death, whereas 68% on placebo had no recurrence or death. Whereas coming to patients, the OS data is not mature. We have to take with that caveat. Definitely there is a separation of the curves between pembrolizumab and placebo, and this survival median OS is not reached. So whatever data is there at the cutoff of 30 months has been taken, which is showing clearly a trend for a non-significant trend benefit term for the pembrolizumab. So, but the main thing is compared to VGFR, toxicity profile. So, they're almost double, like 17% of placebo having some adverse effects, and patients with 32% were in the pembrolizumab, and these are grade 3 and higher. So, based on this study, both FDA and European organizations have approved this drug. FDA has approved and recommended by NCCN and this thing. So, one thing is interesting which we will have to look closely is, if you see intermediate high risk, and M1 NED, the benefit is much more in M1 NED. So, it shows that it is like early initiation of systemic therapy, where it benefit is we only have to give for 1 year. So, most of our patients we try to convince that if you can take this in option now, your systemic relapses are less and you get the benefit within 1 year. As if you say a metastatic disease, stage 4 disease, we have to give at least minimum of 2 years, whereas here get away with M1 NED in less than almost a year. So, these are other failed studies. I am not going to depth of it. There were studies which were perioperative. There are studies with dual drugs. There was a study with atezolizumab. There is a study of nivolumab. So, any other drug than pembrolizumab is not recommended. Even there is no study for low dose nivolumab for this subset of patients. So, one of the very nicely summarized contexting done by EU recommendation when they recommended this drug to be part of their recommendation was weak recommendations, because most of the patients, if you see the survival curve, are much benefited with just surgery. So, you are going to treat a large number of patients with immunotherapy. Second, even though the side effects are tolerable, but the percentage of patients who are grade 4 to grade 5 are quite significant in pembrolizumab. It's almost to the tune of 14%, and 18% of patients discontinued, which indicates the gravity of A. So, I just to put a context, a lot of patients will develop some kind of autoimmune disorder which are not reversible, like myasthenia gravis, where we will feel always apologetic for a patient who will develop a potentially non-curable autoimmune disorders. So, with that in mind, the OS data is still not mature, the median survival is not achieved. So, to conclude, the lymph node role of lymph node dissection for RCC is little controversial. There is both doubt on the survival benefit. The main problem is the rarity of the nodes. Second, in patients, not only ask them to remove for staging and prognosis, even you can decide on adjuvant therapy. Currently, neoadjuvant systemic therapy or adjuvant radiation therapy is not recommended. Then adjuvant therapy, pembrolizumab data is there. A subset of patients whom we can offer VGFR patients who have node, you are doubtful about resection. So, sometimes we get from our surgeons saying like, I think node was positive, even by pathology it is not picked up. There we can use.
Thank you very much. So, I just want, the first statement was a bit confusing for majority of the surgeons in that lymph node, the template for the lymph node dissection and a prophylactic lymph node dissection, there is a discussion on it. But the summary of your talk was, for a clinically N1 positive RCC, surgery is the primary modality of treatment, and then try to resect all the lymph nodes that are positive on the scan. Then you will know what is the chance of them being pathologically involved. That's one. And second, if you have got an R0 resection, whether you would give an adjuvant treatment or not, especially that statement from the EAU says, have a discussion, but do consider the significant side effect profile that are associated with this adjuvant treatment. Am I right in summarizing your talk with those two?
Yes, sir.
Okay, thank you very
much.
you.
One comment is there that if we look at the metastatic data where TKI plus IO is used, the reported adverse effect is not significant, whereas in the adjuvant IO monotherapy, it is 34% of the population grade 3 and higher adverse effect. That is the reason is don't know, because all the metastatic data, their combinations therapy is used and the significant response and OS benefit. But when it is used in the adjuvant settings with the monotherapy, why the reported outcome toxicity is 34%? This is unanswered.
Sir, one of the things which we see the placebo has 17%. So you have to take out 17%, which is related to surgical thing. They may complain of back pain or whatever is that.
Yeah, so the contribution of the effects is likely due to postoperative or likely due to only IO. That is not answered.
Not answered, not being clear.
I think the surgical effects don't go so long. The therapy is 1 year.
Yes, 1 year.
So you should check the time duration when these complications happen if you want to relate it with surgery.
So I think it's not just surgery. I think there are 17% placebo. I was just looking why the placebo has so much adverse effect.
Okay.
Maybe subtyping of the AI will be.
I really must commend Vinayak in this era of IO to present a very balanced view on really the role of IO, whether it should or should not be given. I think the balanced view that you provided is really commendable. Only one more comment and one question. There's for people who are interested in reading, there's a wonderful paper by Vinay Prasad on the pitfalls of the keynote 564 and whether it should or should not be incorporated into practice. People who are interested can really read up. It's an amazing paper. And second question is, if you have to give pembrolizumab as adjuvant therapy, would you just go by the keynote recommendations and say that you would give it because it's node positive? Or would you use the UISS or the Leibovitz scoring and add to it and then give it?
I have a risk scoring to it. And the last question is, I would prefer more in M1 NED than compared to the high risk thing, because that is where the data is much more rewarding.
Vinayak, one question. Why do you feel that only one agent works, none of the others work? Only Pembro works?
Sir, selection. The criteria selections are not similar. That's what I was trying to do. Histology is different. But honestly speaking, I find the pembrolizumab data working much more better than compared to other IOs in all other diseases of the therapies.
So I actually had a different question, but on your last comment that I think it will work more in M0 rendered post-surgery. In that, there is a group of patients who will have a IVC thrombus going up. There will be a group of patients who will have grade 4 ISUP. Or those also probably should be.
So one of the hypothesis they have is you're treating the disease, M1 disease early, and you're getting the most of the benefit.
So that's it.
Sure, thank you.
So the question next was to all the surgeons here actually. We had a talk on CN1 in renal cancer where we say surgery is the standard treatment. So how many of us are doing the template dissections in that? Say I have a right kidney tumor. The template goes to complete interaortocaval. You take a flank incision. Are you clearing the complete interaortocaval for the right as well as the left?
I think
everybody should discuss this because we have 5 minutes discussion time left.
Yeah, I think
we get enough pathology reports in second opinion. Only kidneys there. There is a compromise from either side, surgeons as well as pathologists. Not many pathologists will dig into the lymph nodes in a specimen. I think pathologists can also join. I'm trying to incite them.
As far as RCC is concerned, if the nodes are there, one has to remove as much as node possible. This is for a long time. We take out the nodes when the nodes are positive. Otherwise, if the nodes are not there and if you are doing radical nephrectomy, we do hilar dissection completely. Now, I think it is done. I want to make some comment on previous talks because we have some time. So there was talk on testicular tumor and there was discussion on FDG PET scan. To just clarify and tell you that a lot of time people do FDG PET scan in NSGCT. It's not required. NSGCT has a special situation when you will do PET scan. Otherwise, there is no need of doing PET scan in NSGCT. Seminoma, it is a standard of care. Because there is marker in NSGCT, and when you do the chemotherapy to these patients, if there is a no fall in the marker, and you want to do whether the disease is in anywhere else except in the retroperitoneum, you can do FDG PET scan. It's a desperate situation when you offer the desperate RPLND. So in non-seminomatous germ cell tumor, and FDG PET scan is not routine. You should do it only in seminoma and to see that what is happening, whether there is a retroperitoneal tumor, there is uptake, you want to treat them. Now the things have changed because of the PET scan, because even the 3 centimeter, the tumor which is less than 3 centimeter in the lymph node, they can have intense uptake and they may require the desperation, the RPLND or excision of the tumor mass in seminoma, which was not there before. We were deciding only on the CT scan. So things have changed. Same thing is N1 prostate cancer, where locally advanced or high-risk prostate cancer is. The things of the literature, I think the doctor who presented those, he talked very well that this is that Aymandeep was there. So this is from the Western literature where they are not using PSMA PET scan and all. When you start using PSMA PET scan, the things they change. You can offer them ADT plus RT, you can plus HT, you can offer them HT alone, you can offer them ADT alone, RT alone. The future, I think, will decide when you do operate these patients and when they have biochemical recurrence. Many of them will not fail even biochemically, as Dr. Gupta has said, because with the lymph node, if there is no E&E, most of these patients will not fail. Even if they fail, the PSA doubling time is so high that they may not require anything for a long time. So every patient is different and we have to decide according to that. And when they fail biochemically, you see on PSMA PET scan, there is a localized recurrence which can be given cell-based RT with the SBRT and HT short-term SC. So these are few comments to make.
Thank you, sir.
Jagdish.
Yeah. No more question for me, I assume.
No.
Yeah. Jagdish.
I have feeling like Vaiva someone is asking me different questions.
There are two comments.
Yes, sir.
One was on a FDG PET scan in MIBC. There was a lecture. Yes. To my mind, what we are finding in India, patients of bladder cancer are tobacco related. And they all have some kind of propensity for lung cancer. So we are finding a lot of parenchymal lung shadows, which adds to the confusion. And you can't do the biopsy. So that's the problem of the FDG PET scan in MIBC. Now, as for the Ganesh's problem, which was saying the node dissection, when we started, Robson et al., from the crus of the diaphragm to the bifurcation of the aorta, we used to do that. But we realized that was overdoing it. And the reason was post-op RT was one of the time that post-op RT for nodes. But duodenal ulcer perforations were very high. Therefore, we had to cut down those things. So, but that data will continue. However, my personal belief is, as far as the RCC is concerned, if the nodes are seen, you got to do the template which is correct. That should be the mandatory, be it minimal invasive or open. Thank you.
Thank you. Give me last comment.
About Sanjay's presentation, one new entity that has come is oligometastatic thing. So these oligometastatic patients have come out because of the advancement in the investigation aspect. So oligometastatic, because in bladder cancer also there is some papers telling that oligometastatic cancers has to be aggressively treated. So with PSMA PET, are we making again a second category like a prostate thing, which was included in the organ confined earlier? So is that causing the difference in the management because of the FDG PET?
Dr. Ginnerly, if I can answer that question, there is data from the Mayo Clinic. There is data from the Mayo Clinic paper which sets out which patients are candidates for oligometastatic disease in muscle-invasive bladder cancer. It has paper on what is the criteria for the nodes, what is the criteria for the metastatic sites. So 3 or 4 nodes confined to the retroperitoneum below the renal veins. If that is the only site of disease and that has got a good response, both clinical and metabolic, though they may be those patients that can be offered curative, again within brackets, potentially curative treatment where you include RPL-ND along with cystectomy.
Thank you very much. I thank the chairpersons, Dr. Gupta sir, Anand Raja sir, Suman Malik and Somnath Roy. We've got 10 minutes of coffee break and then we'll have the SOGO session of inauguration and the SOGO oration to follow after that. 10 minutes, we'll try to be back for around 11:22.
Good morning, everybody from the SOGO organizing team. We would request all of you to come back to the auditorium and be a part of the SOGO session that we are about to start. It is a request to all delegates and faculty to come back to the auditorium and be a part of the SOGO session. I would invite Dr. Raghunath on stage to take over from now.
Very good morning. May I request Dr. Jagdish Kulkarni sir, Dr. Raval sir, Dr. Vedang, Dr. Satyadeep and Dr. Giril to come on stage. This is a very simple, straightforward inaugural ceremony because we need to give more time for the scientific session. So we are going to wind up in 30 minutes. Thank you. You can probably keep timer for this as well. So without wasting time, so can we start? Because we don't want to waste time for all these things, sir. So may I request all of you to take your seats. Very good morning, dear SOGO President, Dr. J.N. Kulkarni sir, President-elect Dr. Raval sir, all the members of the SOGO Core Committee and Scientific Committee, members of the local organizing committee, Organizing Secretary Dr. Satyadeep, all the speakers, delegates and SOGO members, members from the pharma industry and audiovisual team, ladies and gentlemen. It's my distinct pleasure to welcome you all to the inaugural ceremony of the SOGOCON 2024. This year's conference marks another milestone in our shared journey of innovation, collaboration, and growth. We are gathered here to explore new horizons and inspire each other to push the boundaries of what is possible in our respective fields. As you know, SOGO encompasses specialties like uro-oncology, surgical part, the radiation oncology, medical oncology, nuclear medicine, uropathology, radiology, and other specialties. SOGOCON has always been more than just a conference. It is a community of thinkers, doers, and visionaries who believe in the power of collective wisdom. This year, we are proud to host an extraordinary lineup of speakers. Thanks to Sanjay for excellent scientific program. Each bringing their unique perspectives and insights. These contributions will undoubtedly spark a meaningful conversation to enhance our understanding of uro-oncology, and that in turn improves the patient care and outcomes. Once again, I welcome you all to SOGOCON 2024. Let's mark this year's conference a truly memorable and transformative experience for all of you. Welcome you all to this inaugural ceremony. Thank you. So, may I request address by Dr. J.N. Kulkarni sir, then later on by
Thank you.
Raval sir, Dr. Satyadeep and Dr. Vedang Murthy. Finally, vote of thanks by Dr. Ginil. Thank you.
Do we have a mic? Collar mic you have? No. You have a collar mic? Thank you. Thank you. Thank you. Good morning. We are on the 5th year of SOGO. Just to give you historical perspective, 25th February, rather 28th February 2020, when the COVID was just knocking the door, we had a meeting at Tata Memorial. Dr. Ganesh would be there. He must remember that. And where 4 of us decided, and of course, the idea for this was Dr. Raval. He said, now we've got to do that. I was all the time, I must confess, Dr. Raval, that I was skeptical whether this will survive, because we don't want to make it as a, another section of uro-oncology under the behest of USI. Well, the concept took off. The first meeting was supposed to be in June 2020. Then the COVID struck, so we had to actually go back. So again, it was revived by that time, we got charity commissioner approval, everything was happened. Society formed. We started functioning virtually for year 2021. We had a first meeting in 2021, virtual, which was attended very well. And then as the COVID died down, first meeting of SOGOCON was held under leadership of Dr. Raghunath, who was the secretary. And then from then on, we have seen the progress as you saw today. Now, what are the takeaways? What did I get out of this? I've got 3 lessons. And one lesson is that multidisciplinary treatment and a society which takes only academic and some kind of evolutional path stays. What I mean was that surgery, radiation oncology, and this is the single platform where they become a primary member. Most of the societies have their own membership, and you may not be a primary member of that society, the invited membership. This experiment, of course, was tried first in SEO, which I mentioned years ago, which I attended first in 1986, when Dr. Donahue was a secretary of the SEO. Now, so what is the second lesson? Second lesson is that, yes, there can be progress achieved in terms of first academic exchange. Let's not get into the numbers, how many attend or something. That should not be our, because we are level 2. And third lesson, which I understand now, or we should do, is the questions raised by some of the speakers and I was very impressed. Some of them said, these answers will have to come from India, and possibly this SOGO is the one where we have to, take these answers, be clinical, well, of course, practical trials, data creation, and of course, last but not least is the research. Now, having said research, we still have a little more to go. The one thing which I would request humbly to non-urological participants, be radiation oncologist or medical oncologist, to upgrade and update your colleagues to be part of this and help us to gather furthermore, cooperative group, what we can say. With these remarks, I come to the end of my presidency, and I'm indeed thankful to all the committee members, though they are asking me to remain as a past president for a couple of years, which I have wholeheartedly agreed. Thank you for that. And I wish the SOGO, we have already had a tie-up with WOUF, World Uro-Oncology Federation. Next agenda for us is SUO. We will have a memorandum, which all of us will be attending this year's conference, and then take on further. I wish SOGO long life and fruitful, and it will be a guiding force in uro-oncology. Thank you very much.
Thank you, sir, and morning, everyone. I remember my switch over to uro-oncology from urology happened in 1996, July, when I joined Rajiv Gandhi Cancer Institute. I was the first uro-oncologist in private in country, but before that, there 3 were in TMH. And in TMH, only uro-oncologist who was MCH urology was Dr. Kulkarni. The unparalleled, the great Dr. Murli Kamath was a great surgeon, and he was one of the idol for me. And followed by him was he, and he actually, in one of the SOGOCON, I think it happened same time when he was organizing secretary, so he came to know there is a MCH urologist in Rajiv Gandhi who has joined as uro-oncologist. So he asked Dr. Huku, who was radiation oncologist at our center, to ask him to join this USI SOGOCON. But I was very young, and I did not have money to go to Mumbai, so I could not go. What happened later on, that more and more urologists and also medical oncologists and radiation oncologists, even pathologists and molecular oncologists, they started focusing on GU cancer. And that was the time when we had discussion, 4 of us, which Dr. Kulkarni said, that let us make a uro cancer focused society, and I took help of Vedang in deciding the logo and the name and everything. And this is how the things they got incepted in 2020, and we are supposed to do a conference in May or June when the, we invited few international faculty also at that time And later on, because of the lockdown and all, that conference could not happen, and we had to take care of what promise we made to international faculty individually, me, Ginil, and Raghunath. After COVID, we had first conference in Mumbai, first conference in Bangalore, second in Mumbai, and the third is here. So this is a third National Congress of SOGO, which focuses on urocancer having multidisciplinary. It's not that only surgery, you just talk about surgery and go. This is not done in cancer. Cancer, the huge role is of radiation oncologist, medical oncologist, uropathologist, and the molecular oncologist. So this was the actually idea to make this society so that we can evolve and teach the young generation what is happening in the uro-oncology world. You can see there are focused society in abroad also, like SUO, GUSCO, where they talk about urocancer only. Now we are like infant. We are 3 years old. We are like infant. We are struggling to walk. And what we have to see that in future, we make some SOPs so strong as of now that in future we do not have any problem when we are organizing any event or anything. So for that, transparency is very important. And this will be, our focus to our young generation who will take over after me, after Dr. Kulkarni, and then next president and others, so that we have a particular, procedure which is followed in the society, rather than, whenever the local committee or local something is organizing, it doesn't happen, it doesn't change. Another process, our focus will be on the program, which is a continuous process. We will be focusing more and more on new subjects, what is new is coming, and definitely in all the fields of uro-oncology. Then we are working on like affiliation, as Dr. Kulkarni has already said, that other international societies, so that we can make a strong, robust society with a good, reputation, and where you have the name that if you want to learn something, you go to SOGO, you should attend SOGO. We are not doing a lot of conferences like continuing urological cancer events. We are not focusing on that because it's too much. There are a lot of events are happening in the country which are diluting even the attendance and also the learning. Here we have to focus on what the new things are coming, what is standard of care, and where you can change according to your experience. Always the experience, as you grow in the field, according to your experience, you can share the knowledge to the youngsters, where many difficult cases has been treated by the elderly surgeon, which they can guide to the young surgeon. And these are the exchange of ideas which actually happen in this platform, which gives you the new idea to discover, new idea to explore, and the other things, new technique or new treatment to explore. This is the main aim of the SOGO in urocancer. So with that, I say that thanks all of you, thank you for coming here and attending this conference. And I hope then when tomorrow you go, you will be having good learning of urocancer, and in future, I expect that you keep coming and attending, keep sharing your ideas, sending us whatever your ideas is there, you can share with us so that we can improve upon. Thanks a lot.
Good morning. Welcome, all of you. We are thankful to our SOGO committee for giving us the opportunity to host this conference, that is third SOGO conference in Kolkata. Thank you, SOGO committee. And there are a lot of academic events today and tomorrow. Please enjoy the academic feast. Thank you again.
SOGO is going to be different. Those are the words that echo in my
years, those are the words Dr. Rawal and Dr. Kulkarni told me when they wanted me to join as one of the initial members. So have we been different? They had said it is going to be multidisciplinary, this is not going to be a urologist show. I think we've largely been successful in that, and I thank you for that. You can see the program, it is truly multidisciplinary. The membership so far is multidisciplinary. But what is the overarching purpose of us being here? And that, I think, comes from what we noticed in after the lovely talks in the morning session. There were so many people eager to put their point across about their own data, about their own experience. And I think what I feel should be the main purpose would be to collaborate in a way that we produce. After every talk, somebody would stand and say, but we need data from India. We have to produce that, and SOGO has to make a framework to produce that, and the ball has been set rolling in the coming years. That is what at least my endeavor will be, and I hope all of you members' endeavor should be the same thing. Please get involved. This is your society. Please suggest what should be done. Please take responsibility of taking up some of these studies, some of these ideas. SOGO will very happily even fund some of the initial projects. So there's a lot of things that can be done, but I request all the members to get actively involved. Thank you so much.
It's my honor and privilege to express the gratitude to each and every person involved in the successful conduct of this conference. Dear members, seniors, this conference could not have been conducted at this magnitude without naming a few people and expressing the gratitude to them. For the scientific program and organizing this event, we are deeply indebted to two persons. One is Sanjay Adla for having this excellent program. He has taken a lot of pain to organize the scientific activity. And Satyadeep, who is working hard, was more than a year. I know each and every the struggle he had to conduct this conference. So we are deeply indebted to these two figures for being here on this day. And Satyadeep is actually supported by his core team, and each and every person has contributed a lot. Sumanda, who's here from yesterday, then Rajiv Ranchan, Suman Malik, Deepak, and Tarun, Amit Gosar. Each and every person in Calcutta has contributed immensely, and we have to thank them. On behalf of each member and association, let me thank them. Also, Bengal Urological Society has supported the event in all ways, and we are very thankful to Bengal Urological Society for the same. The conference is not successful without contribution of delegates and faculty. You know, they have taken a lot of pain. Each and every faculty has contributed a lot. So let me thank them. Without them, this conference cannot happen. The conference cannot be conducted without financial support from the pharma. Each and every pharma company who has supported us, let me thank them on behalf of SOGO. The hotel, Taj Thal Kutir, has given us an excellent venue and taken all our, taken care us nicely. Let them thank them also. And we can't stop without thanking the audiovisual and event management under Abhishek. They had done an excellent job. Let them thank them. That was actually, we had a lot of worries and concerns, but it was excellent arrangement. Thanks to audiovisual team and each and every person here. Let me thank personally. If I have omitted unknowingly in anybody, please ignore that. Thanks to all. And welcome to the event.
Thank you, sir. So with this, we have come to the end of inaugural session.
Shall we just move on to the SOGO session?
Move on to the SOGO session, yeah,
Yeah,
without wasting time, yeah.
He's
We're
already
going
there.
for SOGO session, and first is SOGO oration. Can Dr. Sudhir Shrestha come online? This time SOGO oration has been given to Dr. Sudhir Shrestha. We give this to the person who has contributed immensely in a particular field of uro-oncology or any other field. Here you see Dr. Sudhir Shrestha, who is a cardiac surgeon, but he has made the robot. You know, interestingly, in robotic world, a robot did not become success unless the urologist took over. But irony is that when the Da Vinci came, only one cardiac surgeon was the one who was using it. He was the only one in the world who was using robot. And he became so much passionate with the robot that he landed up in making robot. Though so many urologists were using robot, not a single urologist became so passionate that he could have made the robot. But then his robot also, by destiny or serendipity, whatever it is, he required a urologist to make it successful, where I came in his contact, and this is a long story. I'm not going to tell about his story and my story because it's a long thing which I can talk about. Probably one can make film on him and me on the mantra robot. But let us listen to him, what he has done. His mission accomplished. It started with mantra 1, mantra 2, and mantra 3 now, and there's so many things are there in the pipeline. So we'd like to hear from Dr. Sudhir Shrestha. Unfortunately, he had red eye and he was having severe pain. He could not come here, but we would have loved to be him. We would have loved if he was here, but he's online, and right now he is with us. So please, sir, go ahead, Dr. Sudhir Shrestha.
Good morning, and I think my namesake, Sudhir, Dr. Rawal, Dr. Kulkarni, I have known you for quite some time, Dr. Raghunath. First of all, thank you very much for a very kind invitation, and truly it's an honor and privilege to be giving this oration. And I know, I think Dr. Kulkarni, when he talked to me about that they want to hear the story, and I think as Sudhir mentioned, the story is long. And so I'm going to try to be very concise. And my very sincere apologies that I really could not be there. It was not until yesterday morning I woke up with a red eye, and it kept getting worse. And my team was asking what has happened. And I kept telling them, oh, it's just a shower, probably became red. But I realized very quickly, subsequently, that probably a viral conjunctivitis is not good for me to be there, as it is contagious. So with that, firstly, thank you all very much for this invitation. Thank you to SOGOCON. And I watched the surgery yesterday, the live surgery done by Dr. Amitabh, and it was phenomenal. So with that, let me start out, and I'm going to share some slides and really talk a lot more about what prompted me, how did we get here, and where are we heading in relation to whatever contributions we can make in relation to the robotic surgery, and not just for India, but truly, really for the world. So, and I'm going to start out by saying this. I hope you can hear me and also see the screen. Let me just turn it to full screen here. So the topic was given to me by Dr. Kulkarni, and I must say I was quite amused when he said, surgeon and robotic mission accomplished. I think it is absolutely true. But I'm still, and thank God for telling that, I'm still a surgeon, a heart surgeon at heart, who is absolutely passionate about robotic surgery because of all the different benefits, I think, that are there in relation to our evolution towards more and more minimally invasive approaches that will ultimately benefit the patients globally. And that is really the mission. And so we are a public company, so I am expected to share this little screen with you. And I show this picture. I've been always passionate about the robotics and our country. And I've been asked numerous times, you had such a wonderful and a successful career in the United States. Why did you come back here? A lot of people want to head that way. And I have got two simple words which I absolutely and very sincerely mean. First, the love for motherland, that we must never forget our roots. And secondly, destiny, I think as Dr. Rawal has pointed out. And sometimes I really wonder how all this has happened. And then one becomes very humble that it is all happening truly as part of a very big picture where we are basically playing our roles. And we should feel lucky that we have been chosen as instruments to contribute back to the society. So I'm going to firstly, start out as to, what led me to my journey from being a cardiac surgeon into the world of technology development. And I was always interested in, trying to find ways to not do the things same way that we learned over the years. And it's just like Tom Fogarty in one of his talks, and in one of the conferences I was listening to him, he's a phenomenal scientist, other than being a doctor, that if you have done the same thing for 30 years, you probably are wrong. And I think if you look at how medicine has evolved and continue to evolve at a very different trajectory today. And I think as end users, and this is one of the pleas that I really make to our colleagues, that no one knows better than us what we need. And unfortunately, we become dependent on the industry. A lot of them, their focus is, making the investors happy, and money is the goal. And I think somewhere we get lost in that exercise. Not only the technology continues to become more and more expensive, and we know that the technology, if it's expensive, it is not going to benefit most. And I think it is high time that the physician community gets involved, because we know what we want. Unfortunately, then we are left at the mercy of the industry or the industry leaders. And depending on their focus, they will decide whether to listen to us as doctors or not. And we say that it really does not happen much. So I think when I got into cardiac surgery in practice, I started out finding ways that we don't have to split the sternum. And we started the bypass surgery through thoracotomy approaches, did up to 6 bypasses, almost 800 or 1,000 cases did that way, trained a lot of people, and even the valve cases doing through small thoracotomy on the right side. So the whole idea, because we recognized very early on, sternotomy was great for the surgeon, but not for the patient. So if we can find ways to reduce the morbidity of these patients, because we had achieved some wonderful results in relation to the mortality risk because of experience and evolution of our procedures. But the morbidity still remained, particularly in the cardiac field, very, very high. And so then robot became available in 2000 in the United States. And the Da Vinci people used to constantly bug me about, Rashtrastra, why don't you use our robot? At that time, there were no approvals, and as Dr. Raval has pointed out, and Fred Moll is a dear friend of mine who is the founder of Intuitive Surgical. And I asked Fred, I say, why did you start out with the cardiac as a first approach, actually? And his comment was that if we could do cardiac, we could do everything else, except that there were no approvals, and cardiac being a very high-risk specialty, no enabling technologies. And so I said, what am I going to do with the robot? There are no approvals for us to put it in the clinical practice. And just to take internal memory down, which I could do very quickly through a thoracotomy approach directly and even bilateral IMS, why do I have to buy $1 million machine? But anyway, so in 2002, we decided as a group of surgeons in a very small town, 1 lakh population in West Texas, a city called Odessa, Texas. And what we were doing, we really were attracting patients from all over.
Sir,
and I
sorry, the slides are not moving, sir.
Yeah, I'm not moving intentionally.
We didn't know, sorry.
We will get to, yeah, it's a stationary slide on purpose. Okay? So I can tell my story a little bit before we go into, some other things. So essentially, I decided to purchase the robot with one condition for the Da Vinci people, that I want to be part of the clinical trial for whereby we can do the entire bypass surgery and cardiac surgery in truly a closed chest setting, because that is really the benefit of the robot. So really we purchased the robot and got involved with that thing, moved very rapidly. In 2003, I had FDA permission to do the bypass surgeries on a beating heart under IDE. We did 20 procedures and really saw huge benefits of robotic. I did while in US over case in the country. And as you can see, President then Abdul Kalam ji was the president, and he was quite intrigued about the technology, so we kept talking. I show this slide also with one thing to point out, that after 22 years, we have only roughly 220 robotic systems in the country today. And that brings me to where are we today with the Indian robotic surgery scene. The journey, I tell you, not easy. And as Dr. Raval mentioned, it will take me a long time. But I can tell you very humbly that the journey of innovation and entrepreneurship is full of ups and downs, more downs than ups, but one has to every single time get up and keep going. And that's really what I did. I went out of completely money, borrowed money, sold my car, sold my furniture, but really there was an absolute determination that we must persist. And this is another thing I think that I want to communicate. When you have ideas that are good, and if you submit with very sincere intentions that will contribute to the society, I don't know how, but help will come. And so when we look at the scene today in India, we have 70,000 hospitals with our population of over 1.4 billion. And this is absolutely dismal because if you look at United States, with 1/4 of our population, they have close to 6,000 systems. And the biggest issue has been cost. And unfortunately, again, when we rely on the industry, and particularly monopoly, then monopolies are never good for the end users actually. And basically this translated into very slow adoption in the country. And it's only in subsequent years, so in 2011, I decided to move back to India with bags and baggages and family and purchase the robot myself. It was very tough actually because of the cost. Just patients couldn't afford it. There were only 7 or 8 systems that time and majority were literally sitting idle. Few centers were trying to do early on. And then what turned my life around, the story that many of you may have heard, and apology for being redundant about it. So I had a 22-year-old patient that had atrial septal defect, perfect candidate for robotic surgery, whereby she will have small little portholes in the right side of her chest. Brother brought saying that if she has a scar in front of the chest, probably she won't get married. And they didn't have money. We offered to do it free. Hospital wanted to charge 4 lakh rupees that they didn't have. And he tried to raise money but didn't succeed. And a month later, I got a call. He was still struggling, and then I never heard from him. And I tell you, that truly was the day that I made a commitment that because of money, it is not right that the patients cannot get the best possible care that is available today. I made a commitment, used $4.5 million of personal funds, and went to Germany, put a team together in India, and just really kept going. Chased this dream for almost 7 years, and really very proud of today of our team in India. It is truly an indigenous developed product, as we say, made in India for the world. So really this was the scene that prompted me that we have got to do something. Even when we look at globally today, over 9,000 systems, majority are of course the Da Vinci systems. And one thing I would say in respect to Da Vinci, we're very grateful to Fred Moll and the group who started this, showing us a very different pathway. My only observation, and not a criticism, is that they did not consider subsequently that world needed it. And they could have done very differently in terms of creating affordability, creating a lot of enabling technologies that will make surgeons' life easy. And of course they did that, but it was somewhere like 18 to 20 years later from the starting point. And so again, when we look at the global side, almost 90% of the world population does not have easy access, again, mainly because of the cost, and also organized training programs, etc. So with that, we created this SS Innovations as a company to really create a system. Hopefully, it will be better. And the only reason it will be better because we are a new company entering at a very mature level of robotic surgery scene, not only in terms of the knowledge of technology, the newer things available today, and a lot of experience that existed. So also with that, create a system that will surpass, and most importantly for me was be cost effective. And that's really what we have done. And as Dr. Kulkarni said, mission accomplished. And we have accomplished that mission by creating a very advanced system today. And I can say that without reservation, that we have created something that has more advanced feature, better features, more specialty at less than half the cost of existing systems, with very, very advantages in relation to not only the patients, but the hospitals and surgeons. So we created this company, which is based in Gurgaon, and many of you have seen. It's a wonderful facility, a very high standard whereby we assemble everything. Manufacturing all occurs in India, and only some electronic parts that are not made in India we import. So truly it is an absolutely indigenous product, and very young, bright team, average age of 26 and 27, all homegrown talent, but very dedicated group of people. And currently, we do have these approvals that are listed here. We are proceeding with the European and US approvals. And we have in several other countries approvals, and there is a tremendous international interest because of the nature of our system, the capabilities, the superiority of the features and technology, and the affordability factor. So here we are. So as Dr. Raval pointed out, we did the first trial with him. And I must say, honestly, if it was not for Dr. Raval and the RGCI team, we would not exist, truly. Because it is not easy for new group of surgeons to try a new technology, recognizing that there was a giant out there. And I must really extend my personal gratitude and thanks to Dr. Rao, Dr. Amitabh, Ashish, and a lot of other people, and the hospital administration of RGCI, who took the first bold step to help us, because without their help, there was no way for us to validate and evolve. And part of the reason we do the clinical trials is to learn from it. It's not that it's the last frontier. So basically, we learned very quickly from that trial that it will not work, the Mantra 1 system, in an average surgical setting. And that was part of the reason that we did the trial. Right there, while in the operating room with Dr. Raval, I made the decision that we are going to create the next generation very differently. So we changed every single thing, and Mantra 2 came in 5 months, literally. We did another trial with Dr. Raval, and then we launched it commercially. Then in January, we had another major conference in Gurgaon, and a lot of you participated. 14 live transmissions were done flawlessly, and in various specialties, including cardiac surgery. And then I was getting a lot of ideas from people about, how to make things better. We are at SSI always open to listen, because that's the only way we can make progress, because one person can only think in one way. More eyes looking at it, more brains thinking about it. And so I told them at that time, I had some very disruptive ideas. So I told them that we're going to create very disruptive system. So literally in the next 5 months, we created Mantra 3, which was demonstrated in June at the Society of Robotic Surgery meeting in Orlando. And system is very different. I'm not going to get into the details of technology. I think enough probably has been presented. And I know Dr. Amitabh did the live case, so a lot of this discussion must have occurred in relation to specifics and differences in relation to our technology. So I'm going to show this another technology here. And this is an animation of an automated coronary anastomotic connector. Literally in 6 seconds, it will join 2 arteries, which will absolutely revolutionize how the bypass surgery is done, or how various different anastomosis can be done. And although it is initially for cardiac, but our goal is to develop larger versions for various kidney transplants, ureteric anastomosis, hepatobiliary anastomosis, and so on. And I think this will again change and make it so efficient and predictable outcomes as the surgeons use this anastomotic technology, that not just for cardiac, but for all specialties across. So where we are heading, what is the future vision? So one is that we have Maya division, and we have elected to use all Sanskrit words being in India. So we have abilities to convert all kinds of DICOM images on the fly into a 3D model that the surgeon can manipulate. We can completely reconstruct the operating room in real time and guide people in relation to simulated in terms of placement of cars, ports, etc. And then teleproctoring. I have already done teleproctoring sitting 2,000 kilometers away from my office. And this is one of the things that will be so helpful as we move forward in relation to launching the programs, where, as a lot of you guys know, it's not easy for surgeons to leave their practices and go somewhere else to guide others. You can do all these things sitting wherever. And we are developing headsets that will give a beautiful magnified vision. We will run some trials on this as well to see in terms of how easy it is for people to have a head mount. It will not be obstructive. You will still have a peripheral view. And then, of course, telesurgery is the final frontier. and we'll talk about that also very briefly. So this is just a little clip here showing video I was proctoring in Bangalore. Now we have sold over 50 systems and 80 plus different types of procedures have been done. I think now it is probably 45 live transmissions that have occurred. Over 1,700 surgeries have been done, and a lot of people have been trained. This is our recent update on our clinical experience of almost 1,800 cases. And as you see, initially urology was the most prominent one. Now general surgery, because of the sheer volume, they have taken over, and we have done 112 cardiac cases. All kinds of various complex operations have been done, including colorectal, thoracic, head and neck, transoral, etc. We are very helpful to share this one, that the mortality is zero. There is zero device-related injury or complication in all of these cases now. Of course, did we have challenges? Yes, we did. Like any other company, there was a learning curve for the teams as well as for ourselves. But I tell you, we respond very promptly, and we are very thankful to all our users who have given their commitment and taken the bold steps to try out a new and a different system. Our training model is again very different, and I think everybody knows about these methodologies, but I think what sets us apart is ability for teleproctoring and telesurgery that we have now done. Dr. Raval has done 7 cases. We went through a very systematic approach. We did animal trials, and then we have done all kinds of very complex operations in relation to telesurgery. So it is like teleproctoring, having an attending in the room, and when you cannot do it, take over and finish the job. In future, we are planning to develop a pediatric robotic system, although our system has been used for pediatric application, but really it is a big population that is missing. We are going to develop various single-arm application, and the goal is to decentralize and democratize access for the patients, so they don't have to travel. And then create these SSI studios whereby proctoring can be done. So very quickly on the telesurgery we have done now. Initially we started out at World Laparoscopy Hospital, which was 5 kilometers away. We did animal trials and the first gallbladder operation there. After that we went on to Rajiv Gandhi, and we did, I think, 6 or 7 procedures there, very complex operation. I think there were 2 cystoprostatectomies, then radical nephrectomy, hysterectomy, etc. And again, it was done with very acceptable latency and the requirement for the bandwidth. The latency was only 40 some milliseconds, and everybody made a comment, it's just like you are in the same operating room. So it is a huge development for launching programs and bringing the care to people wherever. And this is a little clip of Dr. Raval performing a very complex operation, sitting in our office 40 kilometers away. The system was in RGCI.
Rajiv Gandhi Cancer Institute was successfully performed between SS Innovations headquarters and the Cancer Institute, spanning a distance of 40 kilometers, using the SSI Mantra surgical robotic system. A complex case of cystoprostatectomy with bilateral lymph node dissection was done efficiently within 1 hour 45 minutes with imperceptible latency. Dr. Sudhir K. Rawal operated with the technologically advanced magnetic sensor-based novel hand controls were designed by SS Innovations.
I'm operating from the workshop of SSI, and you can see there is no delay or anything in doing this telesurgery. This is first time we are doing in country.
So this is where we are heading. We are modifying a bus as we speak. The Mantra system will be placed inside, and this bus will travel to bring the care wherever required, either by directly operating in rural areas or smaller communities or performing telesurgery. So I think this will be a huge thing as we move forward, because we do know the entire initial robotic development was for telesurgery to operate distance-wise space or battlefields. But I think today, with the technology that is there, it is a real possibility. So with that, I want to really thank the organizers and the conference, SOGOCON, And thank you very much for listening to me. And with that, Jai Hind, and wish you every success in your remaining conference. Thank you, and if there are any questions, I'll be available if the time permits.
Thank you, Dr. Srivastav, for this. You really actually ignited our minds. We have some younger SOGO guys. I saw your photograph with Abdul Kalam, whose book was Ignited Minds. I think you have definitely ignited our minds, and we will certainly do. Thank you very much, and SOGO is indeed grateful to you for this wonderful talk, and you have taken the robotic surgery not only accomplished, but you have taken it to higher level, which of course Da Vinci will of course will be breathing at your neck and trying to be captive, trying to compete with you. Thank you very much, and we all need to give a big round of applause, please. Thank you very much.
Thank you.
Thank you,
Bye-bye.
sir.
Namaskar.
Thank you, sir. So we will move on to the next SOGO keynote lecture by Dr. Indranil Malik. Indranil? So he's going to speak on AI and data science in prostate cancer radiotherapy. Over to you, Dr. Indranil. We are running behind schedule by almost 8-9 minutes.
Sorry, how do I operate it? Good afternoon. I'm deeply honored to be invited for this lecture by SOGO, and my gratitude to the SOGO office bearers, especially Dr. Vedang Murthy, for giving me this opportunity. We are going to talk about artificial intelligence and data science in prostate cancer radiotherapy. Now, what we have now is getting treated by human beings. And what does that mean? It means that a doctor looks at your, firstly reports, gets your radiology, and then pathology, and then makes treatment decisions based on a limited set of parameters. The radiation oncologist then gets a planning CT done. They segment structures that they need to treat and they need to avoid. Medical physicists and radiation oncologists join together to plan the treatment. The treatment plan is evaluated by the doctors, approved or modified, and then approved. And then after the treatment is over, doctors follow up patients for cancer outcomes and toxicities. The question is that can AI disrupt this process for the better? For example, can AI help choose the best treatment, decide between prostatectomy and radiotherapy, for example? Can AI make these processes, the technical processes, better or faster? And can AI predict outcomes and predict toxicities? But before we go further, we first need to clear up some terms. What does data science mean? What does AI mean? Data science is just using data to make decisions, and it doesn't involve always any complex mathematics or methodology. Machine learning is using a limited number of parameters to model, to make decisions, to predict outcomes, for example. That is machine learning, a limited set of parameters using complex mathematics and computing. Deep learning uses many more parameters. And by many more parameters, these are often images, gene profiles, large blocks of text, and these are used to create models using much more complex mathematics and modeling. And we now have generative AI, which is using a huge model, trains not on thousands, but on billions and trillions of parameters to generate a complex output. And this output can be text, it can be images, it can be sound, using relatively simple prompts as inputs. Okay. So this is what data science and AI mean. So machine learning, deep learning, and generative
AI is, under the umbrella of what is termed as artificial intelligence. Now, artificial intelligence has already made deep inroads into all forms of, decision-making and treatment of prostate cancer. For example, AI is very commonly used now and becoming routinely available for example, pathology, radiology, and, many institutions are creating models and using AI for making treatment decisions. Many of these are not yet commercially available, but they're in very, very, advanced stages of development. But the topic is how will data science and AI take radiotherapy for prostate cancer? How will that be useful? Now, let's start with the technical processes, AI in segmentation and treatment planning. And I'm going to talk about, mainly our experience as an example of an institution in India trying to get into this field. Now, we all know that commercially, we have atlas-based auto-segmentation, which is basically when we want to draw out structures, you can take a previous patient's data and, do what is known as deformable registration and create structures. But we know that it's not a very good system. Using AI, using deep learning, using specific methods like UNet or NNUNet, you can make things a lot better. And deep learning-based auto-segmentation has been shown to be better than the usual atlas-based auto-segmentation methods. And already there are several commercially available products which are available and which can be bought, although at a steep price. Now, although auto-segmentation is no more a very technically challenging problem, some work still remains. Firstly, many of these models are made from data from abroad. They may not work in our CT scans. There's an issue of cost and availability, continuous improvements. Guidelines will change, processes will change. Can the model change very quickly to adapt to it? So what we have done in Tata Medical Center is that we have gotten onto this bandwagon and we funded a team from IIT Kharagpur to take them through the process medically and technically. And we now have 3 auto-segmentation models that we do use every day in our clinical practice, including one on prostate cancer. And this is, for example, our first iteration when we first build the model. This is the video of how contours look like. So whenever a patient is scanned for treatment, automatically over a period of half an hour, the images are taken through the system and the CTVs, the organs at risk, and are drawn out automatically. It was not perfect. If you look carefully, these images are not perfect, but they are a very good first iteration, which requires only a few minutes of modification. Now, coming to treatment planning, this is what we have now from commercial vendors. I'm not going to go into the technical specifics because most of you are not radiation oncologists, but we do have some semi-automated methods, some methods which are not deep learning based. Now, you don't need deep learning. When we first tried to get into this, what we did was we just used some simple programming which us doctors did to create a dashboard which allowed us to say that, is this the best plan that I can get for a particular patient based on the anatomy? And this dashboard would tell us that no, you can reduce the rectal dose further, or you can reduce the bladder dose further. And it would give us a target dose to achieve for a specific patient. Now, you can get a dose, but can your physics team, for example, plan this treatment? So we ran a study where we took our old patients, we replanned them according to the target doses predicted by or suggested by the dashboard. And we took them through a process which allowed us to test that can we come close to the target doses that this simple data science-based project would have us do. And we realized that we can, and we can actually clearly reduce, and these are all locally advanced patients with nodal treatment, and we could reduce the OAR doses using very simple techniques, which again, as I said, we doctors coded. But now things have moved on. We have much more complex processes. We have machine learning models which help us derive targeted constraints. We can feed those constraints back into the treatment planning system automatically. And now we have deep learning-based processes that uses more advanced technology to, plan patients of any cancer, for example. And these are slowly coming up into, to being commercially available. Now, we are nowhere close to that. This is an older project that we did where we used certain very simple parameters, the volume of the rectum, the overlap volumes, et cetera, to predict what kind of DVH we would get. And, we found that, using simple just six parameters, we could get pretty close to predicting what kind of DVH we are going to get. And these are, 6 techniques we are using for rectum and bladder. And this is, again, a 1-month project by a radiation oncology fellow. Yeah, so these are things that can be done at a very simple level. But using deep learning, you can go a lot better. The technology is now available which can allow you to use these methods to automate a great part of the planning process and feed the rest of the data back into the system for a few minutes of your own planning system's work. And these are, again, slowly becoming available commercially. And while we think that this always will cost a lot of money, there are, institutions which are working to make these things much more widely available for a very low cost. For example, MD Anderson has created a radiation planning assistant that it plans to make available to countries in less developed countries, to countries with less developed facilities for several cancers. And this is, what are the services they have, and there's a trial going on currently, which I'm going to come to, which is testing that in a formal prospective setting. Now that's for the technology. Now what about making decisions? Can AI help us make better decisions for patients? There are already, studies which are looking at how to use AI, for example, deciding on whether to do, prostatectomy or radiotherapy, for example. And, these are just coming up. They are a much, early stage of development, but there are some early signs of success. And these studies show that, yes, perhaps if you've got the correct parameters, you can make some of these decisions better. This is another paper in preprint right now, which is looking at the use of hormonal therapy. And, we believe that, just as Dr. Vedang was saying, that if we, for example, pull in all our data, we can develop these models. These models are actually easier to develop than some of the planning and segmentation models that we already have in our basket. Now, using statistics, using simple predictive modeling, you can predict outcomes. This is a paper on, outcome prediction from the CHIP trial that many of you know. This is, as you can see on the left, using very, very simple techniques, very, very simple parameters to make a judgment on what the outcomes will be. And we have that data. We have the data, for example, to run a similar model on our patients in India. So, we should pool our resources together and we should, get going and have a model for Indian patients. Another, important issue is toxicity prediction. In radiotherapy, this is very important. And again, these are, using dosimetric parameters, using clinical parameters, and hopefully, if you've got enough patients using genomic parameters, it may be possible, in not so distant future to predict who is at higher risk of getting rectal bladder toxicity. Now, this is our latest project. This is using generative AI. And basically what this hypothesizes is that if you can give in the text of the scans, the pathology, the clinical notes, what the MDT of doctors do is that they look at this result, they refer to the treatment guideline, and they give an opinion with a rationale. Now, it may be possible to replace this, or to a great extent, with a model sitting there using generative AI. And this is a project for which we have approached for funding, and we feel that in a few years, we will get somewhere with this. Now, there are many challenges with clinical implementation. There's a lot of data required, a lot of consistent annotation, uniform acquisition, privacy controls, external validation, and adaptability to changing knowledge and changing guidelines. So how do we obtain multi-institutional annotated de-identified data to train models? The earliest step implemented was multi-institutional open image banks like the TCIA. And at Tata Medical Center, we developed India's first oncology image bank, where we incorporated, it was a radiotherapy-focused image bank, where we have, not only the images, but also annotated clinical data, temporally connected with radiotherapy plans and verification images. More than 5,000 patients' data is in the pipeline. About 1,500 patients are already online. This is a free resource which any researcher can download. How can we test models on a larger scale and validate them? The trial that I was speaking of, the archery trial, is actually testing the MD Anderson model in 6 countries across the world. And I'm not going to go into details, but this is a project that both TMH and our center are involved in. And of course, we can have, things like MedPerf. MedPerf is also another project that I was associated with. It's an international project where you basically on the cloud, you can host your models for various institutions to send their data and test it. So what do we need to do in the future? We need to adapt to a different role. Approximately 70% of our work will get automated as radiation oncologists. Roles and responsibilities will change from doer to supervisor or evaluator. But we have to keep our sights focused on the safety and validity of these models, especially in the context of our patients in India. So I'll leave you with a Chinese proverb on whether to use AI or not. When the winds of change blow, some people build walls while others build windmills. And we have to build these windmills. Thank you very much.
Thank you, Dr. Indranil. So we'll not have any questions with this. Thank you very much for this. Over to you, Sanjay.
We move on to the next session, debates, and I'm going to request the chairperson, Dr. Ganesh Bakshi, Dr. Deepak Dabkara, and Dr. Nilanjan Mitra. And I'm going to request the first debate for high-risk upper tract urothelial carcinoma, conservative treatment versus radical treatment in a fit patient. I'm going to request Dr. Brusbanu Nayak to say that radical treatment is the appropriate option. There won't be any rebuttal, sir. I would request 8 minutes sort of a talk from each one of you, and then we can have about 3-4 minutes of a discussion rather than a rebuttal at the end.
Can you change the slide? This is Dr. Vivek.
Same as.
Slides. No. What is happening here? Yes.
इधर आऊं कि उधर जाऊं? उधर. Good afternoon, everyone, respected chairpersons and all our delegates and faculty. So today I'll be speaking to you about conservative treatment for high-risk upper tract cancer in a healthy patient and what are the pros for it. So I'm sure Dr. Nayak will also know who this person is. This is Dr. William Halstead, addicted to surgery as well as cocaine. And initially, radical mastectomy, super radical mastectomy, everything except the chest wall, maybe even including the chest wall, was removed. And ultimately, things have moved towards a more conservative approach. And even in uro-oncology, we are no different. Partial nephrectomy had been described in the 19th century, but it started gaining in popularity only in the last 20, 30 years. And even doing a small renal mass, a radical nephrectomy about 30 years ago would have been absolutely acceptable. But today we are moving more and more towards organ preservation, even for such complex masses. So the reason for this is because we are aware that removing an organ is associated with morbidity, and decreasing GFR correlates with the risk of death, cardiovascular events, and hospitalization. About 25% of people having localized RCC also have pre-existing CKD, and about 60% of them will reach CKD3 within 5 years of a radical nephrectomy. So if we look at things, we have to manage or balance treating the mass with treating the patient. If we wanted to aim for oncologic perfection, we just take out the whole urothelial system, because it is, after all, a field disease. But we never do that. So it's not so cute to just extirpate everything. So you have to manage the morbidity of the surgery as well as the oncologic efficacy. So with radical nephrouretrectomy, the CKD risk applies to that equally. Studies show a decline in eGFR to less than 60 in about 25 to 50% of patients, and only 9% of patients in one study had an eGFR of more than 60 at 1 year, with a median decline of 25% post-op. So these are often elderly patients, comorbid patients, and there is a significant risk of this happening. Radical nephrouretrectomy is not a benign surgery. There are a risk of complications. There is even a mortality risk of 1.7 to 4.4% in various studies. There are significant components of a radical nephrouretrectomy which need to be performed to call it a proper surgery, and that is often not done in a large proportion of cases. So are we really doing the best job possible? Studies say no. The pentafactor is only achieved in about 49% of patients who are actually so-called having a radical nephrouretrectomy. Bladder cuff excisions are often omitted in about 1 to 33% of cases, depending on the study seen. Lymphadenectomy, which is an essential component, is done in less than 25% of cases. And if you resect transurethral the orifice, that increases the risk of bladder recurrence as opposed to a proper cuff. And survival with all these is still not that great, as we are all aware. So why are we defending such a poor standard of care? Let's look at some other options. And that's what happened in the last 10 or 12 years. There was an increasing trend towards more conservative surgeries, and the paradigm was trying to shift towards more nephron sparing. And even the EAU guideline committee had to then look it up and see where organ preservation could be appropriate. And that's why they changed the guidelines 2 or 3 years ago with the risk stratification strategy, low risk organ preservation and high risk upper tract. So the paradigm moved from never organ preservation to now low risk organ preservation, and now I'll tell you how it may move towards high risk also organ preservation. This risk stratification is not without its problems. We all know the reliability of staging the upper tract is not easy. There is a wall thickness is much less. The size of ureteroscopic specimens is very small. It's difficult to stage them. Even CT and endoluminal ultrasound are inaccurate, and the correlation of grade and stage may be inaccurate in about 15 to 20%. And there was a large study of over 2,000 patients which showed proper risk stratification was not possible in significant proportion of cases. So we can't do anything without having good oncologic outcomes. for organ preservation. So I'll try to show some of those now. Hendricks et al. Showed a propensity match study where there was no difference in oncologic outcomes even when stratified by risk groups. So they confirmed that the guidelines on risk stratification are based on limited evidence, and as UTUC guidelines move towards less strict criteria for NSS, it will take time, but it's going only in one direction. And in their paper, they concluded saying that similar results for groups with evenly distributed risk factors and a large % of high-risk disease suggest that current stratification may not be accurate in discriminating low from high-risk tumors. And the adage that all high-risk tumors are best treated by radical nephro-U may not be correct. This is a nice randomized trial, Pickle et al. It's a small study, radical nephro-U versus chemo and kidney preservation. And that showed 2-year RFS non-inferior in the kidney preservation group. And another study by Liu et al. Also showed good outcomes. So basically, if you study them carefully, the outcomes are not bad. Segmental uretrectomy, there are a number of studies which all show better renal preservation, equivalent cancer-specific survival, and some studies even show a potential for overall survival benefit. And similarly, for distal uretrectomy, multiple studies have shown oncologic efficacy. And that's why it's incorporated in the guidelines, but what needs to be taken care is the bladder cuff and the excision of the intramural ureter are absolutely non-compromisable in those cases. Endoscopic management, we have limited evidence at present, and there are no prospective comparisons, but there was a meta-analysis in 2024 which did show a non-inferiority of endoscopic treatment with respect to cancer-specific survival, RFS, MFS, even for high-risk tumors. So there is data if you actually look for it. And in the future, there are evolving technologies. Our flexible ureteroscopes are getting better and better. The vision is excellent. There are use of newer lasers for ablative therapies. There is a paper on endoscopic cryoablation with similar outcomes at 28 months compared to radical nephro-U in high-risk disease. And with ICG, we can help to do a segmental uretrectomy probably in a little better way with the robotic approach. So newer techniques and therapies will also help. Adjuvant therapies, neoadjuvant therapies also will play their role in combination. So BCG for upper tract CI has excellent long-term responses. Adjuvant BCG in high-grade non-muscle invasive disease also has a good survival. And there's a trial of BCG with IV Pembro for high-risk patients underway who are not willing or unfit for radical surgery. Genomics may help us to select better patients for these kind of more conservative approaches, and newer drug delivery systems with biodegradable stents or drug-eluting stents will also play a role. I'm sure Dr. Nayak will tell me about the cost. So this was a brilliant paper that assuming a worst case scenario of a solitary kidney with recurrences at each follow-up for 5 years, the estimated savings would still be almost $250,000 as compared to dialysis. And that would cover the expense of 5 cadaveric renal transplants. So I think it's probably a no-brainer in terms of cost effectiveness. So to conclude, historic literature suggests that less is more. We shouldn't be over-treating our patients. Radical nephro-U is a major procedure and is rarely carried out well. Risk stratification is difficult, and even high-risk patients may do well with organ preservation. Evolving technologies and adjuvant therapies will hold promise to combine and improve outcomes. So let's move from treating only the mass to treating the patient and achieve more equipoise in both approaches, because failure will come from a failure to imagine failure. Thank you.
Thank you, Vivek. Over to Dr. Bruce Banu Nayak.
Thank you, Shogo, for the invitation. So as Dr. Vivek has already started the discussion, the topic is high-risk upper tract urethral carcinoma, the management in a fit patient. So this risk stratification, before we move on to the debate, this risk stratification he has already discussed. As per the UE guidelines, to be considered under low-risk UTUC, all of the following features has to be there. It has to be unifocal tumor. The tumor size has to be 2 centimeters less. the cytology has to be negative for high grade, the ureteroscopic biopsy has to be low grade, there has to be no invasive component on the CT. If all these 5 factors are there, then this comes under the low risk. On the other hand, if there is any one of the feature from this table on the right side, then that automatically becomes the high risk UTUC. The debate today is for the high risk UTUC in a fit patient. The catchword here is high risk and in a fit patient. So when you talk about the conservative treatment, it is either endoscopic, retrograde or percutaneous resection or ablation, or segmental ureterectomy if it is confined to the ureter. On the other hand, radical surgery is radical nephroureterectomy with bladder cup excision. When you look at the guidelines, the guideline clearly recommends radical nephroureterectomy in a high risk non-metastatic UTUC. It's a strong recommendation. Though the guidelines also recommends kidney sparing management to high risk patients, particularly if the indications are imperative. So if the guidelines are very clear, in a high risk upper tract urethral carcinoma, the management has to be radical surgery, then why are you having this debate today? We're having this debate today because there are people, those who believe by doing a conservative treatment, you can have an equivalent oncological outcome to radical surgery with lesser complications, as Dr. Vivek was telling regarding the chronic kidney disease and its consequences. The issue is whether this chronic kidney disease and its consequences actually it's a hype, it's overstated, or is it actually a fact? So before you go to that, let's discuss regarding first the oncological outcome, which is the major concern. So this is a French multi-center trial. In this, there was a comparison between oncological outcomes for segmental ureterectomy with radical nephroureterectomy. If you look at this particular study, though this trial says the surgery was not a significant prognostic factor in univariate analysis, however, the results were similar only in those groups, in those subgroups when the tumor was unifocal in the distal ureter with a diameter of less than 2 centimeter and low stage. In effect, actually they are saying the oncological outcomes between radical surgery and conservative surgery is equivalent in a low risk disease. And in all other cases, radical nephroureterectomy still represents the gold standard. He also mentioned this EAU non-muscle invasive cancer guideline panel. If you look at their conclusion, the systemic review actually says the survival of kidney sparing surgery versus radical surgery is equivalent only for low grade and non-invasive UTUC using an ureteroscopic resection or percutaneous resection. However, they do say in selected patients with high grade disease, segmental ureterectomy is a feasible alternative. So the survival is similar in low grade and non-invasive UTUC and segmental ureterectomy in selected high grade UTUC. This is a very recent review, again the modern kidney sparing management for upper tract urethral carcinoma. When those patients, those who undergo endoscopic ablation, 20 to 30% of these patients ultimately progress and require radical surgery. And the disease-free survival for those who require salvage radical nephrectomy was 92%, vis-a-vis those who again undergo another conservative surgery was only 77%. And the cancer-related mortality was only 7% in radical surgery, and it was 22% in patients those who undergo conservative treatment. And in this particular review, this has been shown there was no significant difference in the post-op renal function, development of CKD and ESRD in patients those who are undergoing endoscopic ablation versus radical surgery. So this chronic kidney disease actually looks like an overhyped thing. This is again another review, the same conclusion, adequate oncological control equivalent only for low grade and low volume disease for conservative treatment. Similar outcome, again this is another review. And as has been discussed, to decide even these patients are actually low risk or high risk, there is significant understaging and undergrading even to decide whether these patients are actually low risk category. So to decide that low risk, if the patient is particularly falling under high risk, this patient should actually undergo an radical surgery. So the points against the conservative treatment is, it is difficult to actually grade and stage the disease preoperatively, and there is no effective local or topical agent. The only topical agent that is effective is mitogel. There is some data on the mitogel, but there is not enough data, but that mitogel is particularly effective for low-grade disease. And to doing that endoscopic resection in the ureter and in the upper tract, it requires expertise. Technically challenging to resect the disease endoscopically. And again, these patients will require endoscopic follow-up for a longer period of time, its cost, anesthesia and morbidity. So now coming to that development of chronic kidney disease. So this was a paper, actually they analyzed over a period of 10 years, more than 4,000 patients, those who underwent nephrectomy for kidney cancer. These patients were divided into 3 groups. One group, there was no CKD in the pre-op, and also after nephrectomy there was no CKD. So that was group 1. The second group, the preoperative GFR was more than 60, but after nephrectomy they had a GFR less than 60, so they became the second group, CKD-S, surgical CKD. The third group, to start with, they had a GFR of less than 60, they had some medical component, medical CKD, and also obviously after nephrectomy they become CKD again. So medical and surgical CKD. On the long-term follow-up, it has been shown the patients, those who are having medical and surgical CKD, they have a higher rate of progressive decline in renal function, all-cause mortality and no cancer-related mortality. So if you look at this particular graph, the upper two are no CKD and surgical CKD. The red line is actually medical and surgical CKD. So there is no survival difference between patients, those who are having surgical CKD and no CKD. So finally, these are 2 reviews that have already been published in European Urology. This is patients, those who are talking in against the conservative treatment for upper tract urethral carcinoma. And in this review, the editorial has been radical surgery should be recommended for high-risk disease. And the only exception to this rule applies for the distal ureter tumor, where there has to be segmental uretrectomy with or without temporal lymph node dissection, even in high-risk disease. And for the proponents of those who are in favor of conservative treatment, if you look at their conclusion is also kidney sparing treatment is adequate and best option for low-grade non-invasive UTUC. Conservative treatment can also be offered in high-grade disease with an imperative indication. Unless there is an imperative indication, conservative treatment should not be recommended. So the take home is, the results on oncological efficacy, it favors radical surgery than renal preservation. CKD, there is no practical benefit of renal preservation over radical in the long run. Surgical CKD is as good as no CKD. The cost and complication of frequent follow-up with endoscopy. Surgical oncological control remains the #1 priority. No curative systemic therapy to salvage unresectable local recurrences. Recurrent disease is potentially fatal. Thank you.
Thank you, Dr. Brusbanu. So we don't have a rebuttal here. I mean, both have presented data very aptly. What we have is what Brusbanu presented, guidelines say in high risk this is what we should do. But once in a while, you know, we all see a small lesion down which is high risk and the whole kidney is absolutely normal and you feel that I'm removing a normal kidney. Again, we should remember 2 things. UTUC is a very rare cancer, less data, probably I should say evolving data. And the next thing is there is a lot of evolving sideways with immunotherapy and other means which can be added to what Vivek said, and the patient would be comfortable in the long term. I think we should stop here and go for the next one. Thank you.
Thank you very much. Ganesh, invite the next speaker.
So for the next, I invite Dr. Srivatsa. The topic for his is primary RPLND, the emerging back from ashes versus no role in future for RPLND. This is for
Very good afternoon, and many thanks to SOGO for this opportunity. So at the outset, I will probably not be debating for a change against chemotherapy. I think we all who have practiced treating testicular tumors here know that how grateful we are for systemic therapy. This is one particular cancer which has changed the way we believe in cure even in a very advanced setting. So I will be in the next few minutes trying to see if we have a scope for introducing surgery in a niche area where chemotherapy or radiotherapy have done so well. All the discussion in the following presentation is only for clinical stages 1 and 2, especially A and B of both NSGCT and seminoma. When you look at treating a cancer, it is no more oncological efficacy alone. We all know that, even in prostate, even in kidney, we are looking at trifecta, pentafecta outcomes. And I believe every oncological treatment should look at a combination of outcomes to see which is the most optimum way of doing a therapy. So even in testicular germ cell tumors, it's not just the oncological efficacy alone, it's also about mitigation of treatment-related morbidity, especially in this subset because we have now seen patients live for years and years, decades in fact, and therefore long-term morbidity becomes a key factor in evaluation of the treatment efficacy, and also to look at the improvement in quality of long-term survivorship, how well the patient is able to lead a near normal life. These are the EAU guidelines in non-seminoma and seminoma as well. The guidelines are quite emphatic that RP-LND be used only in select indications and not in all. So the accent is on systemic therapy as of now. This is the same EAU guideline for seminoma. And now let's start looking at if all clinical stage 1 and 2 testicular tumors behave the same. Are there differences? Should we be treating them the same or differently? So the incidence of occult nodal metastasis in seminoma with adverse pathological factors is only up to the tune of 23% at most. And in those patients with NSGCT, it can be high, as high as 50%. But mind you, it is not 100%. So probably considering systemic therapy for all patients with adverse pathological features may be kind of an overtreatment. We all know that, the systemic therapy comes with a package, a host, a plethora of complications, and what we actually see and understand as on date is just a tip of an iceberg. So I will not go into the details of these complications. All of us are aware of this. The rate of complications can be as high as 70 to 80% in several patients. So over a period of time, things have changed. We have moved from a very morbid RP-LND, open RP-LND to minimally invasive RP-LND with significantly lesser side effects. And we have also understood the biology of the disease better. What we have understood is that we can probably predict patients with higher risk for nodal recurrence in a better manner using the clinical, pathological, molecular, as well as genetic parameters. So it is probably important to look at these parameters before we decide if systemic therapy is the treatment for all. This is a paper from Johns Hopkins which showed that, the recurrence rates after primary therapy, it was a comparative effectiveness evaluation which showed that the recurrence rates after primary RP-LND in a seminoma was as low as 4%, definitely more than the chemotherapy group, but mere 4%. And in the NSGCT arena, it was around 11.1%. Not bad at all. But what is more important that came out from this paper is that the off-field recurrences after RP-LND were actually very low. In seminoma, it was less than 1%, and in NSGCT, it was around 4%. Again, an indicator that systemic therapy, unlike in other cancers like, say, breast or lung cancer, may not be required to be given to all patients because off-field recurrences are pretty low and can be managed. This is another meta-analysis which was published. We evaluated hundreds of papers, unfortunately all low-volume papers. We do not have much data in this arena, which have also shown that the overall recurrence rate post RP-LND for clinical stage 2 seminoma was around 14%. The in-field recurrence rate was only 4%, and the pooled rate of severe complications were also extremely low, only 4%, especially with the advent of minimally invasive RPLND. The key in this meta-analysis was that, consistently all studies reported a very high preservation of antegrade ejaculation, 98% preservation of antegrade ejaculation, again a good barometer of a better survivorship. This is another paper. This is again a very, I'm sure all of you know that this is a very good registry for the Svenoteca registry for the testicular cancer management. They have looked of a prospectively recruited patient cohort in a retrospective analysis, and what they have found out is that even in seminoma stage 2 disease, RPLND is a viable option for selected patients, especially when done in good volume centers with equivalent oncological efficacy and considerably low morbidity rates. This is another paper from the University of Southern California group. This was actually a paper on, debating for primary RPLND in seminoma, and what they concurred was also on the similar lines of equivalent oncological efficacy, and their accent was on fertility preservation, and more importantly, recurrences could be managed equally well. So I would like to conclude by saying that primary RPLND demonstrates a comparable oncological effectiveness to standard treatments, especially in clinical stage 2 of seminoma and also non-seminoma. There is an acceptable low overall and in-field recurrences rate which align with the outcomes of other standard systemic treatments. There is a low incidence of treatment-related morbidity with primary RPLND, with a pooled rate of severe complications at around 4%, and this is only getting better by the day. There is a high preservation of antegrade ejaculation, which is advantageous over standard treatments because these patients are cured. They are all predominantly young, they are cured, they return back to normal life and eventually probably can lead a fully normal life. Long-term results, unfortunately, are not available, and several randomized phase 3 trials are needed to confirm the survival benefits. But from what we have over the last 10 to 15 years, it seems like RPLND is an equivalent treatment option in selected patients. Minimally invasive RPLND, either laparoscopic or robotic, may become the standard of care given the low complication rates, especially the morbidity. Risk stratification with advanced tools, including the, for instance, the miRNA 367 and other genomic parameters like the deletion of Y chromosome, for instance, can actually help clinicians choose appropriate therapy. Failures with RPLND can be effectively treated with systemic therapy and with equivalent subsequent outcomes. And RPLND can act as a good and a safe triage maneuver for patients nurturing trifecta goals of treatment. Thank you very much.
Thank you. We invite Dr. Chandrakant for his presentation.
Thank you, sir, for the introduction, and thanks, Dr. Satyadeep and the organization for the opportunity. So, well, it was a wonderful presentation that I heard, like where best to place a primary RPLND. So, well, in the coming 8 minutes, it's more dramatic than facts because you anyways know the data where to place it. So, yeah, so these are my disclaimers. All the facts which I quote are the best of my knowledge, and the characters are imaginary, and the information is not intended to harm anyone, like region, religion, political party, or individual's emotions. And there may be a slight bias in the debate when I speak. So as the first slide, what you mean by primary RPLND? Primary RPLND in a non-seminomatous germ cell tumor is stage 1 with high risk features, or a stage 2A disease. If you see the options, for stage 1, it is BEP, active surveillance, RPLND, whereas for stage 2A, it is RPLND versus 3 BEP. for seminoma, stage 2A, only 1 to 2 centimeters. This is what you actually mean as primary RP-LND, right? Okay. So what is the principle? As we know, the problem is not survival, the problem is how well you live after treatment. It is not how much I live, right? So this is the data of how active surveillance became a standard of care, but here the comparator of standard of care was not RP-LND, it was BEP, right? So more or less people have accepted that for a stage 1 NSGCT high risk, the comparator cannot be RP-LND, it has to be a BEP, and it has been well accepted in the previous clinical trials. Well, just to make things simple and not bombard with a lot of clinical trials, let me just start with a real world story which I come across. So the story goes like this. This is a 24-year-old gentleman from Murshidabad, West Bengal. He's newly married and he's a Toto driver. It's an electrical vehicle that you drive here. He has a blue card holder. Blue card is basically a government card that you get in Bengal. He developed a right testicular swelling for 2 months. USG of scrotum revealed a right testicular mass. He underwent right high inguinal orchidectomy. It was a T3 disease with both LVA and embryonal component present, having a nearly 50% chance of relapse. And the stage 1 high risk NSGCT. So the grade 3 options, active surveillance versus 1 cycle BEP versus a primary RP-LND. Of course, orchidectomy was done by the surgeon and he counseled that surgery is an option and why not do a primary RP-LND. So well, the decision was surgery and he was assured that we are going to take out whatever disease is there in your body, and fine, so he's happy. The urologist counseled him that the surgery will be done, but the problem is the approval. Getting a urologist with a government health card is not an easy task in Bengal. So no approval, no wait, the wait list is there is no slot. So he finally decided to get it done from his hometown general surgeon under the so-called government health scheme, but it took nearly 3 months to reach the table. So what happened on the day of the surgery day, finally on the table, high risk consent, arranged donors, NBM, PAC, all done. It's going to take 6 long hours of surgery. So the surgery day, he got both. A general surgeon in a periphery, you would expect all these to happen, and this is what happens. IVC and aortic injury, a blood loss, 6 hours of surgery. And after surgery, he had prolonged duration of stay, with ileus and requiring antibiotics and a TPN. So then he comes back after a month with numbness in the groin, a chylus ascites, and bilateral lower limb swelling and a scrotal edema. And then after 6 weeks of surgery, he has got an increasing tumor markers, a high AFB, beta IC, LDH. However, the lymph nodes are negative for the disease. Well, you did a CT scan to look for, is there a viable disease? Yes, the retroperitoneal lymph nodes are not completely removed. Still, you can see some retroperitoneal lymph nodes in the CT. There is ascites probably, that is chylus, and there are 4 lung nodules. So remember, lung mets in a NSGCT can develop even in the absence of retroperitoneal lymph node involvement, right? So now he is a candidate, he is a stage 3, and he is a candidate for chemotherapy. So we medical oncologists want all the organ functions to be done, and we counseled him for PFT DLCO. He cannot do because of the amount of post-operative trauma he has went through, and sperm banking was not advised for fertility preservation, but he has problems of erectile dysfunction, retrograde, so he cannot give even the sperm sample, and he also has a raised creatinine because of whatever he had. So what all challenges he faced? He faced delayed in surgical dates, could not get into a high volume center where a surgeon has to operate at least 24 RP-LNDs per year. That is the guideline, that is the recommendation. And blood loss and great vessel injuries, large incision, prolonged post-op stay, chylus ascites, lymphedema of scrotum and lower limb, numbness over groin, erectile dysfunction and retrograde ejaculation, incomplete resection of lymph nodes, delayed initiation of chemotherapy resulting in lung metastasis, and is not even fit for any systemic therapy right now. So in the end, he's left with a large scar, the swollen scrotum and lower limbs with impotency and infertility, metastatic disease, not fit for systemic therapy, financial toxicity, and mental and social implications. So imagine a newly married guy landing up with all these problems. So imagine him taking just one cycle of chemo, 99% chance of cure, or even active surveillance and treat when there is relapse. So even then he would have achieved a 99% cure. So this is a evidence of head-to-head comparison of stage 1 NSGCT high risk, and you can read the conclusion. You know, this trial showed BEP to be superior to RPLND in terms of relapse, and this is how the recurrence-free survival with one cycle of BEP is better than retroperitoneal lymph node dissection. And the authors conclude that we should be using BEP preferentially over a RPLND. So well, my conclusions are RPLND is not an easy surgery. It has to be done with very good expertise. It cannot be done in a community level center. And there is significant deterioration of quality of. Here the question is not about living, it is a question about how well you live. And these are usually in the reproductive age with a lot of social, psychological and social implications. So primary RPLND sort of become obsolete. I know in my practice I hardly see a neurosurgeon saying that I want to do RPLND. So early stages, so the chemotherapy toxicities come into play when the cumulative doses are there. For example, bleomycin, etoposide, platinum, only when the cumulative dose is 4 and above, then only you will speak of cumulative chemotoxicities. They're just brief chemotherapies, you know, these have hardly any side effects, they will easily come through. So this is one of the saying, what say that the one that you can easily do with a needle, why you want to have an axe, you know, just one chemo and that's it. So RPLND, primary RPLND should never be recommended for at least a primary RPLND. It should be a desperate attempt, but never a primary RPLND because of all these problems. All urologists can do, but what percentage of patients get operated with a good urologist? I think less than 5% in the country. So that is the thing. Thank you.
There is no rebuttal actually, but Srivatsa has requested for one comment. And Deepak will take over.
Yeah, so like I said, I think, you know, RPLND is not for all. But I must tell you here that chemotherapy is also not for all. You are treating more than 50% of patients unnecessarily, inducing 100% infertility in them, inducing definitely even single dose of chemotherapy. These are patients who are going to live for long. So we are now seeing a lot of patients coming with metabolic syndrome, cardiovascular morbidity, and second malignancy, so on and so forth. Maybe second malignancy is debatable because of lower dose, but still, you know, we are inducing them to a very poor survivorship, and therefore, like I said, RPLND will act as a triage to see who will require chemotherapy and who does not.
One cycle of chemotherapy, BEP is not that toxic as you are mentioning. One cycle of BEP is not that toxic as compared to 4 cycles.
Sir, we can have a polling, you know. How many of them are ready for RPLND in a stage 1?
So let's not have a poll. Primary RPLND is done even at TMH. We used to do in very less patients. Yes, and we'll conclude after Mahendra's comment because I think out of many centers, we are still doing it there.
So, sir, one thing ki primary RPLND in seminoma, it has not recommended in the guidelines in seminoma. NSGCT, again 1A and 2A and state case of 2B is recommended. So I think it should not be taken like that ki seminoma should go with the RPLND. It has a post-chemo setting, but not as a primary RPLND.
No, NSGCT.
Yeah,
stage
just
1.
I wanted to say, that's all.
Thank you. I think we'll rest it here. And I think let's... Yeah, but there are certain conditions like few rare patients you will get sometimes, you know. Somebody who has a contraindication, somebody has something, some other problem. So there, 1 or 2 patients in 2 years you will get for primary RPLND.
Thank you very much. We'll break for lunch and we'll come back for quarter to 2. Quarter to 2.
Thank you.
Thank you.
Thank you.
Is anybody among Dr. Anand Raja, Srinivas Narayanan, Rajendra Ray or Pramod Sharma? Is anyone there? No? Okay, fine. I'll start off. Do we have the speakers, Rakesh Sharma and Amitabh Singh? Okay. Until they join in, we'll start off the session. So these are the continuation of the debates. Dr. Rakesh Sharma, in the management of CN0 penile cancer, we are trying to debate whether dynamic sentinel lymph node biopsy versus modified lymph node, inguinal lymph node dissection. So to defend, Dr. Rakesh Sharma is going to do for dynamic sentinel lymph node biopsy.
Good afternoon, everyone. Good afternoon, Sanjay and all the chairpersons. Thank you, Sogo, for this opportunity. So, I have given the debate topic of in the management of clinically N0 penile cancer. I am going to speak for dynamic sentinel lymph node biopsy. Just to introduce, it's one of the less common cancers, what we have been discussing in the last 2 days. And the highest age-adjusted incidence in India is 0.7 to 3%. The highest is in the Brazil, it's 8.3, and the other parts of Africa. So this is the lymphatic pathway, what we see for the penis or the penile cancers. It's a stepwise spread of the disease via the lymphatics from the superficial to the deep inguinal, and from the deep to the pelvic lymph nodes, and then via the retroperitoneal and the lymphat and the hematogenous system to the solid organs like the liver and lungs. So even the superficial group has been divided into the groups as the superomedial, inferiomedial, superolateral, inferolateral, and the central group of lymph nodes. So this is where we are going to see the TNM staging, and we are going to see the clinically N0 or the visibly enlarged lymph nodes. And these are the stage 2A and 2B patients, which are the patients with clinically N0, where we are going to debate on today's topic. So what is the clinically N0 groin? It is defined as no palpable or enlarged lymph nodes, no suspicious lymph nodes on ultrasound, and palpably enlarged lymph nodes or suspicious nodes that are negative on FNAC. So the incidence in world literature is around 0 to 20%, but in India, what we see is a palpable lymph node around 20 to 96%. And amongst the clinical N0, the micrometastasis can be as high as 25% of cases with micrometastasis in them. So this is what is the EO risk stratification says, the low, intermediate, and the high risk group. These are the primary T stage and the grade of the patients, and almost 25% can have in the intermediate risk micrometastasis, and around 40 to 100% can have in the high grade group. So the lymph node, the most important thing, what is the cancer specific survival in these patients. So for 5 years, if they are treated well and they identified at clinically N0 level, the 5 year cancer specific survival can be as high as 95%. And the routine use of antibiotics and all those things have to be stopped now. It is not recommended in any of the guidelines. You have to have a high level of index of suspicion based on the EO risk stratification. So since there are no other way of handling this patient, because there are no valid nomograms, or there are no other investigations of choice which can identify this micrometastasis, these need a surgical staging by any of these two techniques, whichever is feasible or possible at your center, a dynamic sentinel lymph node biopsy or a modified inguinal. So that's why I'm going to speak on DSLNB. So this is the key events or the evolution what has happened over the dynamic sentinel lymph node biopsy starting at 1977 with Cabanas on penile cancer, and there is a progressive development in with the availability of radiocolloid dye, and then the availability of ultrasound being involved with FNAC by the Netherlands Cancer Group, and the usage of the SPECT-CT, and later on coming in the 2012 is even the ICG has been into the usage. So this is the sentinel lymph node, which is medial to the superficial epigastric vein, which is the first draining lymph node. So what is a false negativity? So the problem here starts with a false negativity. A false negativity means a lymph node recurrence in a groin, which is previously staged negative as on a dynamic sentinel lymph node biopsy, without recurrence in the primary, and is associated with a very, very poor prognosis. So that is the key factor of whether to do DSNB or not. So is it reliable, this procedure? So way back in 2008, we had 2002, we had the first publication on dynamic sentinel, one of the first publications where a dual dye technique was used. The problem here was the sensitivity was around 80%, but the false negativity rate was very high, 22%. So after that, a lot of thought process happened to increase the sensitivity and reduce the false negativity. So these are the key steps which the Netherlands Cancer Group has proposed how to use so that you can reduce your sensitivity, means reduce your false negative and increase the sensitivity and specificity. So this was one of the papers which was published in 2013, where a prospective study was done on the long-term outcomes of 500 inguinal basins. Around 21 months they had the follow-up of this patient, and most of the patients were in the T1 high-grade, T1 moderately differentiated group with or without palpable, non-palpable lymph nodes. And the primary endpoint was no nodal disease recurrence, and the secondary endpoint was the complications. So what they identified was the 73 positive lymph nodes were identified in 59 patients, and there were only 4 inguinal basins which had a false negativity. So it had a very high sensitivity with ultrasound, with or without the FNAC was around 95%, and without only dynamic sentinel lymph node biopsy was 92%. So it was a good sensitivity, and the dynamic sensitivity, the morbidity rate was around 7.6%, which was quite low. So on the Indian articles, what we have, one from the Adyar Cancer Group where Dr. Anand Raja is there. So they published around 20 patients with 40 groins with clinically N0 status. And what they identified, the sensitivity rate was very high, 97.5%, but still they had the false negative rate of around 10%. But there has been a progressive improvement to see the reduction in the false negative rate has come down to less than 10%, and the recent literature says even less than 5%, and the morbidity rate has been in the range of around 4 to 22%. So last article 2020. So we also studied and published our patients for the dynamic sentinel lymph node biopsy by dual dye technique, and we also had good sensitivity, and the very low false negative rate was there in our patients. So another dye which can be used for the triple dye technique is ICG. So one of the paper was published by Brower et al. Where they found that the sentinel lymph node pickup was much better when compared to blue dye when you use ICG. And ICG has better advantages. It's a low cost. Elimination of radioactivity is there. It can be done in any center. You don't need a cyclotron to have a radionuclide to be present to you. But the only problem is poor penetration is there, and you need an incision to identify these nodes, and you need this infrared fluorescence camera, special camera is required to identify these nodes. Why I'm mentioning is because now the world is moving towards a triple dye technique, where a blue dye, a radioactive colloid, and ICG are simultaneously given to this patient. So this was one of the landmark paper 2020. It was published in the European Urology by same Netherlands group, where more than 400 patients with almost 740 groins were evaluated, and they had a lymphoscintigraphy study done on the prior day. So all the lymph nodes which were identified in the lymphoscintigraphy was picked up by these sentinel lymph node technique. So what they found was a positive sentinel lymph node by gamma probe was almost 100%. With the sentinel lymph node, with the fluorescence camera was 100%, but with the blue dye it was around 84%. So blue dye was inferior to the other two techniques, and the false negative rate was very low, as I mentioned, is around 5%. So very good paper. So what the EU also suggests that whenever the surgical staging has to be done, offer dynamic sentinel lymph node biopsy for these patients. Whenever it is not feasible or the technology is not available, then you can offer this patient one of the inguinal lymph node biopsy technique, either open or wheel or whatever is available at your center. And if the dynamic sentinel lymph node biopsy is to be done, you perform a inguinal ultrasound first, get a FNAC, and then find out the abnormal lymph nodes. So these are a strong recommendation for EUA. Even if you see the NCCN guidelines in the intermediate and the high risk group, they also suggest either do a bilateral inguinal lymph node dissection that they meant to say, I believe, is the modified, or you can do a dynamic sentinel lymph node biopsy. To talk about modified inguinal lymph node dissection, there has not been major updates happening in this because the technique is again invasive. There are some oncological issues are also there. If you see the 5-year cancer disease-specific survival is around 93.4% in clinical N0 group, and even the recurrence rate is around 10.5%. So when you talk about the complications also, it has much higher complications compared to dynamic sentinel lymph node biopsy. So to conclude, the dynamic sentinel lymph node biopsy is a very good technique. There are good updates are happening, new technological agents are coming which will help you to do even in centers where the radio colloid is not available, and it has very low falsity rate in a high volume center where it is performed regularly. Thank you.
Now I will call upon Dr. Amitabh Singh, who will be speaking for modified inguinal lymph node dissection.
Good afternoon, everyone. Thanks for opportunity. So my assignment is to speak in favor of modified inguinal lymph node dissection. So the whole issue is, we all know that more than 70% of clinical N0 penile cancer patients, they are getting unnecessarily intervention, henceforth complication. So we are in a search of a very good diagnostic modality or staging modality which has a balance between oncological efficacy and treatment modality. So our previous speaker spoke in favor of dynamic sentinel lymph node biopsy, and he tried to convince us all that it is the only technique which can give you a perfect balance between the efficacy and treatment morbidity. Personally, I am not against dynamic sentinel lymph node biopsy. Definitely, we have got enough data, enough evidences in support of dynamic sentinel lymph node biopsy. But I would like to ask one question. How many of you or centers are doing dynamic sentinel lymph node biopsy? Please raise your hand. Only few. So what is the reason behind why majority of the clinicians are not doing sentinel lymph node biopsy? Because there are certain concerns regarding dynamic sentinel lymph node biopsy. And I am going to discuss all those concerns. So first and foremost, and the most important, is the false negativity. Because in penile cancer patients, false negativity can be a death sentence to the patient, because the systemic therapy and radiation protocol are not very good in treating penile cancer patients. So that means the surgery is the mainstay treatment. If we can cure the patient at early stage of the disease, then we can increase the survival. Otherwise, there is a very dismal prognosis of the patient. So this is a real patient from our clinic, 48-year-old man diagnosed with penile cancer in August 2023. After partial penectomy, his final histopathology was PT2, margin-free, moderately differentiated, LVY was positive, and it was HPV related. On ultrasound, on bilateral groin, his lymph node were subcentrimetric with preserved fatty hilum. So considering it as a high-risk disease, we planned for robot-assisted bilateral veil as a staging procedure. Unfortunately, on the right side, we had a very limited yield. We could just retrieve 4 nodes on the right groin, whereas on the left groin, we could retrieve almost 15 nodes. So because of this fact, considering it as a high-risk disease, unfortunately, after third month of the follow-up, this patient had a 8.6 mm node with inhomogeneous and thickened cortex on the ultrasound, which looked suspicious to the radiologist and us also. Therefore, we asked for the biopsy. It came out positive for the metastatic squamous cell carcinoma. We asked for then PET scan to rule out metastasis. And unfortunately, he had only disease in the inguinal area, he had positive pelvic lymph node. So the point is, unfortunately, because of the low yield of the lymph node on the right groin, considering in a high-risk disease, we decrease the survival of this patient, we compromise the survival of this patient. Because we know, this is a very well-known fact, that if we are doing prophylactic lymph node dissection in clinical N0 patient, then 5-year OS could be around 83%. Whereas if you are putting your patient on surveillance and doing lymph node dissection once it becomes metastatic, then 5-year OS would be 36%, exactly 1/3 of the previous scenario. And this is not observed in our scenario only, this is a worldwide phenomena. This is a paper from a very high volume center from the UK. They published their paper in European Journal of Urology for dynamic sentinel lymph node biopsy. Fortunately, they provided the clinical detail of those patients who had false negativity after dynamic sentinel lymph node biopsy. First patient, 80-year-old male, having stage 2 disease, died within 14 months of the follow-up. Another patient, 63-year-old, despite of having stage 2 disease, died within 8 months of the follow-up after dynamic sentinel lymph node biopsy, considering it as a high-risk disease, and both had LVI positive. So, although there are various studies which shows that the false negativity could vary from 2.5 to 15 or 10%, but this is the paper which has been published in European Journal of Urology from NCI, Netherlands, which you can call as a mecca of dynamic sentinel lymph node biopsy. They reported false negativity up to 10% per patient, and they reported false negativity after dynamic sentinel lymph node biopsy up to 8.7% per groin. So you can understand what is the impact of doing this false negativity in their patient, whereas modified inguinal lymph node dissection has false negativity rate of 0 to 5.5%, which is much lesser than compared to the dynamic sentinel lymph node biopsy. Next thing is complication, which is the most important selling point of dynamic sentinel lymph node biopsy. Same paper from MCI Netherlands, which you can call as a MECA of dynamic sentinel lymph node biopsy, they reported complication incidence of up to 22%. Although majority of them were minor complication, that is 87%, but still 13% of the patient has major complication. And even in 1.8% of the patient, they had to ligate the bleeder because the skin incision is very small. And if the node is very deep, then you need to dissect it. And there is an incidence, there is a possibility that you can leave the bleeder open. This is a paper from this Tata Memorial Institute. So this is a review article. So just focus on the complication rate of dynamic sentinel lymph node biopsy versus modified inguinal lymph node dissection. So most of the complication incidents, they are pretty same except seroma, edema, and major complications, which we agree, definitely. But we need to understand that, is there any willingness to trade off the complication rate to prevent the false negativity? If you explain your patient that, yes, with modified inguinal lymph node dissection, there would be some increase in the complication, but there is a significant decrease in the false positivity rate, which will increase your survival, then definitely patient would agree if it is a 5% or 10%. Although we don't have any study, what I feel. Because our patient, they are willing to trade off their erectile function for the cure for the prostate cancer, whether they are getting radiation or whether they are getting radical prostatectomy. So I think if any patient who is having cancer, in his mind, the mortality is the biggest issue, overall survival is the biggest issue, he can trade off at least for 5% or 10% of the complication. Again, the same paper, see the complication incidence of dynamic sentinel lymph node biopsy and the veil. So if you will compare the complication incidence, then they are much lesser in the minimal invasive technique, even compared to the dynamic sentinel lymph node biopsy. So my proposal is that instead of doing invasive modified inguinal lymph node dissection, if you can minimal invasive lymph node dissection, modified inguinal lymph node dissection, either via lap or robotic, whatever facility you have in your center, then probably you will be having much better complication rate compared to the dynamic sentinel lymph node biopsy. Third is learning curve. Oh my God, this is the flow chart which is even not coming in your single PPT. So you can understand how complicated is this flow chart is. That's why it requires the adoption of dynamic sentinel is associated with substantial learning curve, a structured, validated, and multidisciplinary training program at your institute. And according to the NCCN guidelines, DSNB is currently recommended only for tertiary care referral centers where at least 20 procedures are performed annually. And you can count your centers like in a year, how many carcinoma penis you are operating. I think there are only a handful of the center in the India. Third point, so they have studied the breast cancer program also, and they have found even few surgeons, they required almost 50 cases before getting proficient in doing dynamic sentinel lymph node biopsy as well. Fourth concern with the protocol is still the protocol is getting matured. We started from the only radionucleotide, then they added blue dye, then ICG, then combination of ICG, blue dye. Now the recommendation is saying first do a USG guided FNAC and then start with the dynamic sentinel lymph node biopsy. Coming to the cost, this ICG machine and this radionucleotide gamma probe detector, all together they have the cost of almost 50 lakh. And within 50 lakh, you can get a very good lab system with ICG inbuilt. And that system you can use for your modified inguinal lymph node dissection, whatever. And it can be used for other procedures also. So even economically wise also, the modified inguinal lymph node dissection is more feasible compared to the dynamic sentinel lymph node biopsy. So in conclusion, I would say, so what is good for you may not be good for me. So my answer for the better staging is the minimal invasive modified inguinal lymph node dissection or superficial inguinal lymph node dissection. That's it. Thank you for patience hearing.
I think there's no rebuttal here. I think excellent points said by both Dr. Amitabh and Rakesh here. I only have 2 points to say here. I think the point about standardization and validation is very, very important. At our center, our identification rates are upwards of 99.3%. But then, in about 320 groins. But having said that, that identification rate and that false negative rate that we have at our center of 3.5%, 3.2% is our false negative rate, 99.3% is our identification rate. But all these 320 groins that have been done by a total of 3 surgeons. So any dynamic sentinel node biopsy have only been operated by 3 surgeons. We tried to do a pilot a couple of years back when juniors have operated. I mean, the seniors stepped in after they finished the surgery. Most of the time, the sentinel node was missed. So the standardization and learning curve is very, very huge. It's not for all. It's only in centers that have been trained very well. And for what Rakesh said, I think the trend is at what our data tells us is that the identification rate when we used only, we use a methylene blue, we don't have patent or isosulfan blue. When we used only methylene blue, the identification rate was 78%. When we used only isotope, it was 82%. The combined was 99.3%. The challenge is that in the Western world, I think they are trying to replace the blue dye with the ICG. So it's the ICG with the radiocolloid is what is now becoming the current standard of care in the West. I think in our country, I think because you have not every center, if dynamic sentinel node kind of, takes up, the challenge would be that not every center has a gamma probe, not every center has access to nuclear medicine facilities. The way that in our country we should probably be looking at is whether we can replace the isotope with the green dye. So a combination of blue and green, whether that replaces the isotope, would be something that we should look forward in our country. Thank you so much.
Something. Yeah.
Regarding the talk which like Rakesh made, why it is not being like adapted so much, dynamic sentinel. One thing with Dr. Anand told that it is the standardization of the technique, because we don't know what is the right dose, how much is to be injected, where it is to injected. There is no standard in any paper. So every paper to paper it differs. So there is no technique standardized. Secondly, there are very small logistic issues like suppose you are doing dynamic sentinel lymph node biopsy and the lymphatics they cut, then the blue dye spills throughout so you are not able to identify the lymph node. Even in green dye, once it spills, you are not able to identify where is the lymphatic, where is the lymphoid tissue. This is the issue. Lastly, for localization of the sentinel node, again that is very difficult because with skin in situ, it's very difficult for some of the probes to detect the sentinel lymph nodes. So maybe you have to combine it with some radiological imaging like SPECT technique. Again, the SPECT is done in radiology, and then the way they mark it, and then we find that same level, the lymph node, that is also challenging. So these are the points which is not letting sentinel lymph node biopsy to be adopted. One thing which I wanted to also comment on Dr. Amitabh's thing is that if sentinel lymph node biopsy has a learning curve, like, it fills the slide, the same thing is for whale. Because when doing whale is not, it also requires some sort of learning curve in some cases. And so both techniques have equal merits and demerits.
I think central lymph node biopsy has a learning curve, but it is still an evolving procedure. It hasn't been standardized till date. Whale also, robotic or laparoscopy, whichever you are comfortable with, has got a standardized approach. And the answer to this debate is if you can adapt this whale technique, that will be much better.
Thank you. Next one. Thank you, Rakesh and Amita. Anand, sit there.
So
you can invite
we
them.
are having a next debate in MIBC, neoadjuvant chemotherapy with clinical complete response. Are we doing radical cystectomy to all? Yes versus no. For yes, there is Dr. Kinju Adhikari.
Good afternoon, and I'd like to thank SOGO for the platform. I agree to by our previous speaker, Dr. Amitabh, in terms of what patient would want when they have cancer. Survival is what they want, and we can trade off with a little bit of a morbidity that we can give with radical cystectomy. So I will be defending radical cystectomy here. First, I'll divide my topics into, should we really rely on the clinical complete response? The topic is clinical complete response post neoadjuvant chemotherapy, oncological control, and long-term survival between radical cystectomy versus doing nothing. So yes, radical cystectomy, we all know, and we all have a level of evidence on why we should be doing radical cystectomy post neoadjuvant chemotherapy, absolute survival advantage. So let us dwell on the clinical complete response, because that is the parameter where we should understand and where we decide whether the patient actually goes for active surveillance or probably is cystectomy or probably radiation. So does T0 clinical means pathological T0? No. clinical is not pathological complete response, and pathological complete response can only be determined by when the bladder has been surgically removed. So what do we have in our armamentarium that can accurately detect the clinical complete response? CT scans, MRIs, we all know the average accuracy of it in detecting falls between 80-85%, both for CT, MRI, virus also, and CT scan we generally don't use to understand the residual disease. PET scan for the completion's sake, but this is just for the nodal and the distant mets. This is what I came across when I was reading about neoadjuvant chemotherapy and the predictability of the MRI. So this paper is very important where it can analyze the role of MRI post neoadjuvant chemotherapy, immunotherapy setting to understand whether the patient will actually have a pathological T0. So they took all the cohort from Pure 1 trial, and this is very unfortunate that the area under curve for MRI post neoadjuvant to identify pathological T0 is 0.7. The curve more towards the lateral, more upper is the better investigation. So this is unfortunate here. And the opponent might argue upon saying that there is radiomics and why are we relying just on the CT scan and MRI. Right now we are still in the earlier era for the artificial intelligence, and the meta-analysis has shown that the specificity ranges between 80-81% only. So not always clinical T0 is pathological T0. So are we under-treating our patients? Are we ready to take that risk? Because we absolutely know the advantage of treating the patient with a radical cystectomy. The patient has an advantage of getting cured here. 51% absolute lower risk of recurrence. So if we leave the disease, if there is residual disease, overall survival drastically goes down. 3.4% versus 11 years versus 11 years for white T0. Biomarkers, perhaps there will be some emergence in molecular signature or ctDNA. We are very early in discussing that, but this I think would be the trial which my opponent will also be discussing upon the RETAIN trial, where it's a risk-based trial trying to analyze whether once the patient has clinical complete response based upon the factors and the mutations present in these genes, whether to go for active surveillance, whether to do surgery or not. We can see the data clearly here. 38% of active surveillance patients develop metastasis disease. This is within 2 years. 2 years. So this could be disastrous if we forget and if we don't see the patient and leave those patients for active surveillance. And even in those active surveillance which did not have metastatic disease, 69% had urothelial recurrence, 8 underwent radical cystectomy, 2 underwent chemoradiation. Overall, this trial did not meet the predefined cutoff for significance, and it could not declare the risk-adapted approach also. So now we cannot rely upon imaging, we cannot rely upon risk-based approach as well. So should we rely on the endoscopic measures now? So cystoscopic evaluation, this data, it was published in Journal of Urology. Visibly zero tumor, visibly biopsy-based, no evidence of tumor, will also 51% of those will have residual disease, and 25% of them could have PT0 disease, PT2 disease. So negative predictive value here is very less. So again, in favor of radical cystectomy, let's say the patient underwent active surveillance and later the disease came back. If we undergo salvage cystectomy or if we do a delayed cystectomy, what is the outcome of it? These are the data. We can see one peculiar data seeing that 30% increase in the disease mortality. Outcome is not good. It's a meta-analysis here. Non-response for bladder surveillance and local bladder preservation and local recurrence ranges between 15 to 28%. Complication is high, mortality is high, survival is less. But we can do a good radical cystectomy with lesser morbidity in a very minimally invasive way that we are doing right now. So better hospital stay, quicker recovery, we can adopt ERAS protocol, which we are doing, and better improvement in terms of psychological aspect of the patient to retain the bladder, creating a new bladder nerve sparing procedure for better functional outcome. I will not be discussing much on radiation here because my opponent would be doing that, but we can see the list here, list of complication that is there. It is not free of complication. Survival could be there with the radiation in terms of TMTs, but just for the radiation it is not there. Significant toxicity, short-term, long-term toxicity, guarded oncological control in MIBC, risk of residual disease, and variable response amongst the patients, amongst the histology is there. We've already discussed about the complication post-salvage therapy, so that is what we should consider about. The most important aspect for the patient is the financial and emotional stress or toxicity that can be there on ongoing need for cystoscopic surveillance, looming threat of salvage therapy. The patient would be thinking when the recurrence could happen and the bladder toxicity that could be there with multiple intravesical therapy. So it could be going towards the surveillance or doing nothing or probably just giving other form of treatment could be more expensive to the patient, as now we are potentially stacking on the cost of muscle invasive bladder cancer and other therapies. So to conclude, radical cystectomy will give us accurate staging and it is the standard of care. There's no debate on that. But we should have a balanced perspective as a treating physician where the decision should be individualized, taking into account the patient preference, tumor biology, latest evidence, and we should always be careful that the patient should have actual T0. So we should not be missing that. So preserving bladder sounds an appealing goal, but it should not come at the expense of the overall survival of the patient. Thank you.
Thank you. I will call upon Dr. Kaushik Bhattacharya, who will be speaking for either doing nothing or doing radiotherapy.
Good afternoon. Okay, so I was just thinking that as I grow old, I should be toning down in debates. I actually don't like debates. That's because you tend to take a very strong and radical stand. Your whole idea is to shoot your opponent down. But that's not how science works. Most of the times, none of us know what's the right answer. And in this context, neither she knows what's the right answer, nor do I know what's the right answer. So I will try to strike a balance here. And we're all talking about this for ages. This has been the standard of care. There's no denying that you do an MIBC, address them with surgery in some form or the other, and it has never been a free ride. RC is no fun, If you look at long-term data, and I know that she will argue with the fact that there are newer data which supports that things have gotten better. But once we're taking, say, T2 disease, T3 disease, early T3 disease, where patients live as long as 15 years, you simply cannot escape the toxicities of, RC. So RC is not a free lunch. And when you talk about RC being better in MIBC, all of us know that there is no randomized data. Now, typically people pull out these kind of publications where they show that, where is the mouse? Where they show that there's a significant improvement of death from any cause and death from bladder cancer. But the moment you are talking about non-randomized data retrospectively, everything becomes a statistical construct. And it is absolutely important that you try to look at the quality of the data. And when you go deeper, there are plenty of publications to show that if you actually do a balancing out of the comorbids, and look at misclassifications, because many of the patients who have not undergone a TURBT have been misclassified. Sorry, who have not undergone a RC has been misclassified. And if you adjust them for the age, the hazards of death for bladder, RC versus preservation is practically equal. There is no real advantage when you look at it in a proper statistics manner. And the bias continues till today. There are more recent studies that show that there is a significant selection bias among MIBC patients who receive TMT. They don't actually. And if you adjust your data for patients who receive TMT, if they're also having the criteria to undergo RC, it's likely that they will be having absolutely the similar outcomes. The question is that what happens when you have looking at the long-term outcome of bladder preservation protocol? Now, again, there are no great data as long as you can, willing to put them together and analyze. You see that the patients who have completely responded, and this is a clinical response, obviously, they do far, far better. And I'm talking about people who are living into 5 years of more than 80%, close to 90% people who have got complete clinical response, they live. And this is fairly in line with what you see in the surgical series. Now, this is what you have to keep in mind, because fundamentally you're talking about patients who are going to respond well. Which is why, keeping this in cognition, the AUA guidelines, they tell you that definitely neoadjuvant chemotherapy followed by surgery is your option, but they should also be offered the alternative option because the TMT is equally valid. Both are having the highest level of recommendation, equal level of recommendation, and the same thing is also repeated in the NCCN, that both of them are equal guidelines. Now, we all know that PT0 saves lives. if you look back at data who have undergone RC, the ones who have achieved PT0, they live far, far better. And you have data typically where you have 30%, 38% patients who achieve PT0 in chemotherapy, and 70% of them alive at 70 years. You have other studies that show that 22%, 23% will undergo, clinical complete response, pathological complete response, and 80% of them are alive at 80 years. So the challenge, as she has pointed out just before me, is knowing what is a clinical response. And at this point of time, the traditional methods of knowing it does not exist. There is no denying that, which is why my presentation is more focused on the future days to come rather than what's happening now. We all know that cystoscopy plus TURBT can give you some idea. CT-MR has got their own difficulties. MR has got use of DWI. You have NSE VIRADS, which looks at the response rates on the basis of specific criteria that you see, which is different from the standard VIRADS. PET-CT is of limited value. But we are moving to the days of CTC and ctDNA. Some of the trials have borne results, some of the trials have not. But this is the key thing. Now, as the science of diagnosis develops, I don't think this is going to be the obstacle that will remain over time, and very soon we will cross this. So at this point of time, the patients who have got clinical pathological response, we have the option of either immunomodel in the form of radiotherapy, chemotherapy, maximal TURBT, etc. None of them, including active surveillance, in my opinion, is a right option. In that, I agree with my previous speaker. There should be always an option of offering them a complete treatment, either in the form of TNT as it stands now, or even tetramodal. It may be over treatment in case of patients who have got CCR, but that is one of the options. The question is, what happens, the clinical data of what happens if you do not treat these patients after they have clinical response. Now, this is a multi-centric study where 148 patients, one of the center was MD Anderson, other was, I don't remember quite, when they had clinical complete response and they were observed, they found that 73% of the patients ultimately did not have any recurrence. And that results in the patients who have got no recurrence, they have far, far better outcome, because even if they have a recurrence, there is an active salvage process and you can salvage them. So it is not like if you have a recurrence, you are dead. Even some of the recurrences can be salvaged, and therefore it's a risk worth taken if it is done judiciously. And these patients actually continue to do very well for over 10 years. And you have to understand that bladder cancer is a disease of the old people. And if you look at patients who have lived whose age is more than 76 years, this is a study from China, retrospective, that showed that at that age group, there is absolutely no difference between what modalities you use, whether you use surgery, whether you use radiation, whether you even keep them on observation. Patients who have undergone systemic therapy and observation, they just do the same as any other treatment. So if age is one of the criteria to adjust, then you must take a second look at it. And as she pointed out, one should look at risk-adapted organ preservation. It's not one size fits all. Some of the patients will be possible candidates for organ preservation, either in the form of radiation or in the form of observation, though my support is for radiation. Retained bladder, the full data has not come yet. She has mentioned the interim. Then there is Alliance trial and then SCR and GUC 167 trial. They are essentially looking at a combination of chemotherapy and immunotherapy and trying to assess the response with the help of FNSCC, ATA, MERCC2, BRCA1, 2, and many of these molecular markers and genes, and then considering them whether they can be kept on surveillance. Now, these are early data, and at some point of time, they will be throwing up answers. Therefore, I come in peace. I'm not in fight with anybody. Having said that, with the advent of more use of MDT, informed decision-making, properly conducted randomized trials, which sorely lack today, and assessment of the way we assess the CCR, once it changes, you do a proper case selection on the basis of these above parameters. You use liquid biopsy, molecular markers, and the advent of immunochemotherapy. The day of indiscriminate surgery is limited. Thank you.
I think, again, excellent points spoken by both the speakers. The real challenge here, if you can have a corollary to illustrate this point, would be rectal cancer, where, from the era of APR, now they've moved to TNT and, non-operative. Even for locally advanced rectal cancers, what they do is, if they have a complete response, They just observe these patients. So can that be replicated in the bladder really is the question. The data as of date tells us that around 20 to 30% of patients who have a complete radiological response will have residual disease left behind. 70% of those patients or 80% of those patients might not need a cystectomy, but the crux is there a modality that you can identify those 20 or 30% of the patients who have a residual disease or a microscopic residual disease left behind in the bladder? So that's one. And the second, and based on the existing techniques that we have, either imaging based or molecular based or assay based, I don't think there's anything that exists right now reliably, unlike rectal cancers, where the MRI and the standardization and reporting is extremely standardized and very uniform throughout the world. I don't think we have that in even MRI for bladder cancers. That's one. And the second challenge, I mean, we really have to look at other malignancies to see what progress we can make. Even if there's a local recurrence in rectal cancers, what they do is they just, for a large number of patients, they only remove local resections. If there's a small residue left behind in the scar, they resect that scar alone and still preserve the rectum there. So is something like that possible in the bladder, where you look for recurrence, and if there's a recurrence there, only do local resections there, a TUR there, and an effort to preserve the bladder? I think these are all long unanswered questions. I think it's a brilliant topic for a debate, but a lot of unanswered questions, and maybe we should look at other cancers to see where is it that we can make progress from. That's my take.
I think I perfectly, and also agree with most of the points made by my opponent. The thing is that we don't know the answer at this point. And the fundamental issue is that there is no perfect radiological way of telling where there is a patient who has completely responded. We totally depend on, unlike in MRI, in rectum, as you mentioned, there's a very good way of knowing who has got a response. But in this, we don't have a way of knowing. Therefore, selection is the key. All patients, if you select, 30% of them will fail. So which patient you select, that we should wait for some more time for that data to develop. Informed decision is a part of any treatment process, but once you can sort out the process of which patient is selected for a preservation, you can look at this question. At this point of time, there is no data on either side of the boundary to strongly put your case forward.
So currently, if I was going to do active surveillance post-neoadjuvant chemotherapy, unless it is done as a part of a study, the answer is no. Am I right in saying that? Currently. Future might be bright.
I will tend to agree with you, except in an exceptional situation where the patient is extremely old and therefore not a candidate for any form of aggressive treatment. But in that case, possibly I'll be giving radiation and leaving it. Yeah. So now you don't give radiation as high dose as 60 gray as you used to give in the past. You give only 45 to 50 gray, and that leaves you a scope for a good salvage surgery should the patient recur. Earlier, the biggest fear was that if you have given radiation, the patient relapses, surgery used to be a nightmare. That is not the case anymore.
So I think my take on this is that you need, as of date, most patients will need some form of local therapy, whether it's TNT or radiation or surgery. I think the debate will keep carrying on. That is not the question. The question is, can you avoid local therapy in patients who have a complete clinical response? I think that's what we are looking for at the answer. We have a lot of evidence and a lot of promises, but I don't think that we have an answer on that yet.
Thank you. Rahul.
It's also important to consider the quality of life that you will have versus radical cystectomy versus having an irradiated bladder. For example, if you have a 40-year-old guy who's got a muscle invasive bladder cancer and you've removed his bladder and you assume that he's going to be cancer free. So if you irradiate a 40-year-old person...
I don't think we are discussing a 40-year-old. We are talking of
I'm saying if somebody has a complete response and he lives for a long time...
I will answer that offline. It has been answered in her slides and my slides both. I will answer that offline.
Okay.
Yes. Yes. No, those are ad hoc sort of a situation, but I just wanted to know currently whether post-complete response, what do we do?
Just to answer that, it was there in the retained trial, I just mentioned about the active surveillance part. There is a cohort of patients which evaluated for the radical cystectomy patients also. Yes. And those cystectomy patients also had metastasis. It doesn't mean that patient with bladder cancer after doing a cystectomy don't develop metastasis. There was 8% difference there. Only thing is that how do we select the patient, and to identify that PT0 patient, do we have any imaging?
Thank you. Thank you very much. Thank you, chairpersons, for an excellent discussion. We are going to go on to the next one, a bit more of a confusion that we need a bit clearance. I'm going to request Dr. N.P. Gupta, sir, Dr. Sudeep Das, and Dr. P.K. Mishra. And these are all a bit of evolving topics, and we have chosen the people who can enlighten us on this. We are going to start off with Dr. Chilkuri, talking about addressing the oligometastatic. Is more always the better? Because we started off with one, which was orchidectomy, then orchidectomy. Now we just keep on adding more and more. So is more always the better?
Thank you, organizers, for the opportunity. So since the session is in clearing the confusion, let's create the context. Why confusion? This is across only randomized clinical trials that patients have been considered for observation, metastatic directed therapy, ADT alone, ADT plus docetaxel, ADT plus ARPI, which is androgen receptor pathway inhibitors, all three put together, all three with MDT, surgery, etc., etc. So there is clearly a confusion because among randomized control trials itself, there is so much variation at least. Of course, these are evolving clinical trials as mentioned. So just to do some terminology definitions, there is absolutely no doubt that we are increasingly recognizing these patients because of ultrasensitive imaging. And the definition varies among institutions, among individuals, among physicians, etc. But there is largely a consensus that somewhere between 4 to 6 bone metastases, nodal oligometastases, and no visceral mets seems to be a reasonable definition for an oligometastatic prostate cancer. But more importantly, we are increasingly recognizing the value of seeing the metastatic burden. And therefore, patients have been classified into low volume disease and high volume disease. And in general, when we are talking about oligometastatic disease, we are generally referring to low volume metastatic high hormone sensitive prostate cancers. And ideally, they should be subclassified into synchronous and metachronous. I'll come to that. But most of these patients in the clinical trials, which I'm going to show, have been identified or defined using conventional imaging. And that is a very important caveat which we all need to remember, which because we are not using conventional imaging anymore, I don't know how much we can extrapolate the results of those trials to our clinical practice. So with that caution, let me jump into how do we manage. As I said, we need to divide them into synchronous low volume and metachronous low volume. Why this distinction is important? Because the prognosis is entirely different. You can see that approximately the median OS for a synchronous low volume disease around say around 4.5 years, whereas metachronous is much, much more, nearly double. And 5-year survival is almost 75%. 3/4 of them would make it for more than 5 years. So that is a big, big distinction. And let me focus for first few slides on synchronous low volume, which is the poor prognostic subgroup among them. And we know that multiple trials have addressed multiple questions. And ADT plus docetaxel seem to be better than ADT. ADT plus ARP seem to be better than ADT alone, or ADT with or without docetaxel, because once ADT plus docetaxel was found to be better than ADT, all the standard of care arms included docetaxel as well, but some did not. So standard of care, when we mention, it is probably ADT with or without docetaxel. So when we add ARP inhibitors, seem to be better. Now, should we add all three in a low volume setting? This is, again, there are multiple trials addressing this. Again, multiple subgroup analysis from clinical trials. It seems that there is possibly, with pooling of a lot of data, PFS, there could be some advantage, but overall survival, there is no advantage of combining all three modalities of treatment. And even if there are a small group of patients who could benefit from triple therapy, all of them will have major dip in the quality of life. And this is, and not just for, even if you give 6 cycles or even 3 weekly or even 2 weekly, sometimes medical oncologists prefer 2 weekly. And despite that, for a lengthy duration of time, the quality of life doesn't return back to the comparable to ARP inhibitors, you can see on that, on the right side. So role of radiation in these patients also has been defined by few clinical trials. directly answered by a STAMPEDE subgroup analysis. Again, overall survival, there seems to be a benefit. You can see the hazard ratio is 0.68, which is not reaching up to 1. So clearly there is a statistically significant advantage, which was not seen in high burden disease. But mind you, this was a clinical trial having about 900 patients. But if you look at PEACE-1 trial, of course it has 2x2 factorial design, and one of the questions asked was, is there a role of radiotherapy in addition to standard of care versus when we give standard of care plus abiraterone? And there seems to be an advantage, at least the best arm among all these patients, all the arms was standard of care plus abiraterone plus radiation. So radiation seems to be adding a benefit, but the hazard ratio is 0.77 and the confidence intervals are straddling 1, so clearly not statistically significant. PFS, again, there seems to be straddling, so not statistically significant, but seems to be the best approach among all the other modalities. Now, there are other endpoints also studied in as part of the PEACE-1 trial, and there seems to be an advantage of delaying the castration resistance, which I think it is an important endpoint. And a smaller point, but an important point, is time to serious GU events, which was also presented as part of the PEACE-1 trial, which showed that with radiation, there seems to be benefit in terms of time to serious GU events. So what are these GU events? I'll come to in a bit, but role of radiation, because there are other trials as well, which have compared ADT docetaxel with ADT plus ARPI plus docetaxel and others. So a network meta-analysis also shows a similar outcomes, that when you combine ADT, ARP and radiation, they seem to have the best hazard ratios, although not statistically significant. So this question remains still unanswered. The toxicity with radiation seemed to be minimal. This is across the trials. Both the PEACE-1 trial as well as the STAMPEDE trial have actually shown very low rates of toxicity. So radiation seems to be safe in the setting of ADT plus androgen receptor pathway inhibitors. Now, what comes if, when it comes to metachronous state, there have been options of surveillance if the PSA doubling time is very, very long, metastatic directed therapies to avoid or delay the ADTs, ADT with ARP inhibitors, androgen receptor pathway inhibitors, or combination of metastatic directed therapy along with systemic therapy. All have been options in this setting, and there have been few trials which have addressed this, one of them being STORM trial, which actually showed that compared to surveillance, metastatic directed therapy seems to delay ADT, delay castration resistance. Similarly, another trial, Oriole trial, also showed a similar finding, but it also showed that in patients who have high risk mutations, which are TP53, ATM, BRCA2, BRCA1, RB1, there seems to be not much benefit of using MDT alone. So probably we need to give MDT plus systemic therapy. So is there a trial in MDT plus systemic therapy? I think the best trial comes from Extend-RT. I like the design because at least it's a small trial, small phase 2 trial, but at least it uses intermittent ADT along with MDT and with or without ARP inhibitors. There seems to be a benefit in terms of progression-free survival. So in patients who have rapid PSA doubling time and maybe even high-risk mutational signature, probably they could benefit from both systemic therapy and metastatic directed therapies. So to conclude, I would say for synchronous low-volume disease, ADT, ARP inhibitors plus radiation seems to be the best. ADT plus RT or ADT plus AR inhibitors seem to be the next best alternatives. No role for systemic therapy, triple systemic therapy. For metachronous, we could use metastatic directed therapy. It seems to be better than surveillance for sure, especially in patients with PSA doubling time of more than a year, low PSA to begin with, low Gleason score, Gleason group grade, more than 18 months ADT-free DFI. And for a majority, I think both systemic therapy and radiation metastatic directed seems to be the best. What we do not know is the same definitions do we apply for PSMA defined low volume disease? We don't know the answer. Which patients can there be a de-intensification or intensification? I think those are the unanswered questions as of now. Thank you very much.
Thank you. Before Gupta sir start, I just wanted to ask in de novo or synchronous low volume metastatic cancer, you didn't discuss the role of MDT in that one. You only discussed in the metachronous one. Is there any role? Because you would give it when it is convenient, but generally we tend to miss that.
Yeah. So metastatic directed therapy is again a controversial topic because we begin at least with the systemic therapy first in patients who have synchronous disease. And therefore, MDT could be an option in patients who have oligoprogression or oligopersistent disease rather than for all the sites which were previously seen.
Sorry, I was so for a low volume synchronous, we would be giving them ADT, we would be giving them abiraterone acetate and local prostate radiotherapy.
Yeah.
I'm just saying.
Yeah, with MDT. Yeah, you're right.
Yes,
I didn't discuss it. That is a controversial topic. Whether to treat only the prostate or to prostate plus pelvic nodes or to add the metastatic directed therapy. Yes. That is, again, is a controversial subject, but I would do it. As of now, it's called total therapy, but again, it's controversial.
And the two aspects of prostate only radiotherapy or prostate and
Plus
pelvis
nodes.
radiotherapy in a low volume metastatic.
There is a clinical trial ongoing for that right now. In fact, the trombone also addresses the surgical question whether surgery has a role with or without nodal dissections.
The comment I want to make is that all these studies and this definition of oligo, low volume and this multiple metastasis has high volume is based on the CT scan and bone scan.
Conventionally.
That PSMA PET CT was not recognized at that time. Yes. Now FDA has approved PSMA PET CT. Correct. So now in future, within next 1 year or 2 years, you will see a lot of new classification will come.
Yes.
So I think so we have to wait, number one. Second thing is all these trials, which especially on the drug side, they are all sponsored by the companies. So the companies always look forward to find out another indication for their drugs actually. And 5%, 10%, 2% difference, and they will say like doublet and triplet therapy. I think so we have to select out our patients which are suitable for a particular therapy.
Yes, sir, absolutely right. I mean, but that's opening Pandora's box, whether clinical trials run by biased institutions versus cooperative groups.
In fact, early trombone results are encouraging in favor of
MDT.
Yeah, local therapy with respect to in trombone surgery was the local therapy versus systemic therapy.
Yeah.
They have not used the this one ARIs, and ideally it's better to compare with local radiotherapy versus surgery plus systemic standard of care therapy.
So one last question here, Dr. Srinivasan. This is something that I was discussing with Dr. Sanjay a couple of days back. Suppose you have oligocytes, 1 or 2 sites of metastatic disease, you treat the primary nodes, the total therapy that you said, the prostate, the nodes and the metastatic site, and you go on to give ADT with abiraterone, which most people do give. What do you do with the abiraterone? Do you stop it at 2 years or do you continue it till biochemical progression?
As of now, the evidence is for 2 years.
Even in the oligometastatic?
Yes.
Yeah, please, last
ADT
question.
would continue, but abiraterone would stop at 2 years.
So
last question.
You would continue the ADT beyond 2 years also?
Yeah, unless
Would
you choose
stop
intermittent
everything?
ADT. Unless you choose intermittent ADT, which is also an option, as shown by extent trial.
So the discussing Dr. Adna's point, metastatic directed therapy in a primary setting, the number of trials going on is not as much as it is in the oligoprogressive or in the oligopersistent disease. So that's why there's a lot more interest in the oligoprogressive disease. You have PopStar trial, you have Oriole trial, and all that you have mentioned. So in total therapy, I know you are using total therapy. I am not a great fan of total therapy upfront. Of course, in oligoprogression, oligopersistent disease, there is a lot of interest, and I think we will have answers soon on that in that setting than in the primary setting.
Okay, thank you. We invite Dr. Chirag Desai to give his talk on management options in non-clear cell metastatic renal cell carcinoma.
So good afternoon, everyone, and thanks organizer for giving me this opportunity. In next about 8 to 9 minutes, I will be talking about the management of non-clear cell metastatic RCC. In practically every conferences, every oncology and uro-oncology events, we have been discussing clear cell renal cell carcinoma very avidly, very fondly, but nobody is discussing about this poor subset of the patient who are non-clear renal cell carcinoma. So treatment of metastatic RCC has evolved from what we call dark era, and now it is going to golden and diamond era in the coming years, with cytokines followed by TKIs, followed by ICIs, and combinations and newer drugs like belzutifan and others. And most of these developments are in clear cell renal cell carcinoma, and there is lack of clarity in the management of non-CC RCC. And next few minutes I will try to show some clarity on how to manage these metastatic, difficult to treat patients. So what is non-CC-RCC, how common it is, and how does it differ from clear cell RCC, and what are the treatment implications. So first 2 slides about the first 3 points, and then rest of the presentation I will be talking about what are the treatment implications. So as we can see, clear cell carcinoma is by far the most common. Almost 75% of renal cell carcinoma are clear cell carcinoma. 15 to 20% are papillary, then there are few chromophobe, and then there are other like colorectal carcinoma, translocation RCC, and few others. And mind well, there is nothing like sarcomatoid carcinoma as a standalone entity. It is always a component in some background of either clear cell or any of the other non-clear cell renal cell carcinoma. So same thing in the other way, as I just said, clear cell is the commonest, and then papillary, chromophobe, and so on and so forth. Look at the right column, right extreme column, where we find out that which are the frequently altered gene, and this has some treatment implication that I will show in the next few slides. So first talking about papillary RCC, then chromophobe, then sarcomatoid, and then a couple of slides on the standard recommendations. So you saw in the previous slide that papillary RCC are type 1 and type 2, but according to current WHO classification, this distinction has been lost, and we are merging the both in single entity only. Now we are looking at 2 types of tumor, renal papillary adenoma and papillary RCC, and molecular characterization shows that whether the molecular assessment shows TFE3 arrangement, TFE-B arrangement, FH deficient RCC, or ALK rearranged RCC, and the treatment differs in all these varieties. So treatment of metastatic papillary RCC, traditionally TKIs, then immune checkpoint inhibitors, combinations, and then future. This is how I will be discussing papillary RCC. So there have been few trials enrolling small number of patients, because we never have large number of patients like in some of the other cancers. REPTO trial is a single arm everolimus first line study, 88 patients. Median PFS was 4.1 months and median overall survival was 21.4 months. So papillary carcinoma is not a bad disease like other non-clear cell RCC. SUPEP was sunitinib as first line. Median PFS and OS were 6.7 and 17.8 months for type 1 and 5.5 and 12.4 months in type 2. So it means that type 1 is a little better as compared to type 2. ESPN and SPN were randomized trials comparing sunitinib with everolimus, and PFS was 6.1 versus 4.1 in ESPN and 8.3 versus 5.6 months in SPN trial. And there was exitinib trial as well. But then we realized after doing all these trials, when we did the molecular analysis, that most of these patients do have MET modification, MET alteration, and then MET-directed therapy started coming in. And there are mainly 4 drugs, cabozantinib, crizotinib, stavotinib, and then there are a few other drugs. SAVIOR was a trial which compared savolitinib versus sunitinib. It was a biomarker-driven trial, but still it was close because of lack of efficacy. PEPMET was randomized phase 2 clinical trial comparing 4 different arms, cabozantinib, crizotinib, and savolitinib targeting MET. And sunitinib at one time was a standard of care for any RCC. So this trial showed that savolitinib and crizotinib didn't do as well as the other 2 drugs, sunitinib and cabozantinib. And it showed that cabozantinib, it was best of all in terms of overall response rate, PFS as well as overall survival. So this was a landmark trial in established cabozantinib as the treatment of choice. And so cabozantinib is treatment of choice for MET-directed therapy. And now we are building on the efficacy of cabozantinib by adding immune checkpoint inhibitors. But before we talk about the combinations, the slide about ICI single agent, Nivo, after up to 3 lines of treatment, PFS of 2.2 and OS of 16.3 months. Keynote 427 cohort B, first line pembrolizumab, 118 patients, good number of patients, response rate of 28.8%, PFS of 4.2 months and survival of 28.9 months, and checkmate 920 Nivo EP as first line, PFS of 3.7 months and OS of 21.2 months. Now, mind well that in immunotherapy, we don't look at increase in PFS. We look at the increase in the survival, and that's what occurred in all these three trials. So we realized that why not to combine one of the TKI with one of the immune checkpoint inhibitors, and there are several trials. The first and the best is nivolumab cabozantinib trial, showing 47% response rate, 12.5 months of PFS and 28 months of overall survival. And then there are other two smaller trials, Cosmic and Calypso trials, having different combinations. And three trials are ongoing that will give the answer about the best possible treatment for these patients. PEPMAT is atizo cabozantinib combination versus cabozantinib. Sameta is durva savolitinib versus durva versus sunitinib. And Stellar is nivolumab plus odd tinib versus sunitinib. And all these three trials are planning 200 plus patients. So good trials will give us good answers. So till then, for metastatic papillary renal cell carcinoma, the treatment of choice is nivolumab and cabozantinib. So that's clear. About sarcomatoid, we knew that this subset of the patients across clear cell as well as other non-clear cell carcinomas had a poor prognosis, and we treated with chemotherapy, and targeted therapy like sorafenib or bevacizumab and few other drugs. But there were poor outcome across all the different treatments. ICI, now all these 5 trials, we have been discussing about clear cell renal cell carcinoma with sarcomatoid component. So these are sarcomatoid component, and the patients with sarcomatoid component are anywhere between 49 and 150, good number of patients. But look at the first line, checkmate 214. This is a dual ICI combination having 60% response rate, 23% CR rate, 26.5 months of PFS and 48.6 months of overall survival. So that is best of all. So what does it mean? When there is sarcomatoid component, try to give immune checkpoint inhibitor combination with nivolumab and ipilimumab. But if that is not to be given for whatever reason, at least give immunotherapy in a combination of whatever TKI that you want to give. But the preferred is ICI combination, Nivo and Ipi. For chromophobe, metastasis is rare. Outcome with TKI is poor. Immune checkpoint inhibitor to be given if there is sarcomatoid component. On molecular analysis, P10 loss and tuberous sclerosis alteration are common. So mTOR inhibitor like everolimus is to be given. Thank you. So this is the algorithm for chromophobe renal cell carcinoma. On the left side, the algorithm for localized disease. On the right side, for metastatic disease. Saturated with nephrectomy for symptomatic patient, but otherwise sunitinib or everolimus, my preference is everolimus, and also consider genomic testing, clinical trials, and a few other treatment for these patients. For collecting duct and medullary carcinoma, it is chemotherapy. It is not a type of RCC. It's something extension of urothelial cancer. So cisplatin, gemcitabine, doxorubicin, whatever you want to give, but give chemotherapy. No TKI for these patients. And finally, this is my last slide. Second last slide, NCCN guidelines, bit confusing. In first line, clinical trial is preferred, or Cabo, or Cabo-Nivo, or Lenva-Pembro, and then other recommended and useful in certain circumstances. There are several things. So it is confusing. So I hope I have been able to clarify and not complicate on the understanding. Thank you very much.
Thank you very much, Chirag sir.
Dr. Desai has nicely elucidated the very complex situation which most of the urologists is. Anybody to comment, any comment or?
What happens with this TFA3 translocation? Any of, if they come with metastasis?
So TFA3 should be considered as a papillary carcinoma and treated like a papillary carcinoma with cabozantinib and nivolumab.
Okay.
We don't have large numbers to substantiate this statement, but that's what how I am doing.
Okay. And the second one, is there any role for any adjuvant treatments? I know I'm overstating when there is lack of evidence. So when we know that it's an R0 resection in a non-clear cell RCC, is there any role for any adjuvant anywhere?
So whether there is any space, whether there is a requirement, the answer is yes. Whether there is any evidence, the answer is no. We all should come together to do the clinical trial and share our experience. So that's the answer.
Thank you.
Thank you very much.
We move on to the next topic. There are the next confusions. That's on the histologies reportings of CA prostate. I will invite Dr. Dibya Mirdha. Is he not there?
Good afternoon, everyone. Thank you, organizers, for this opportunity. This isn't my topic. Excuse me, this isn't my topic. I get 2 minutes extra, Dr. Sanjay. No, sir, I'm fine. Can you readjust my time, please? Thank you. Good afternoon, everyone, and thank you for this opportunity. My topic is changing terminology in prostate histology reporting, what the urologist/clinician needs to know. Now, with the new WHO classification, the 5th edition, it is based on cutting-edge advances, and therefore delving into controversial issues, delving into evolving nomenclature is unavoidable. So 8 terminologies and concepts in prostate cancer reporting in 8 minutes. I'm going to start with prostate ductal adenocarcinoma. It is a specific subtype of prostatic carcinoma. It is characterized by large glands which are lined by tall pseudostratified columnar cells. They have a papillary and large cribriform growth pattern. It is a little different morphologically for sure from the typical usual asana prostatic carcinomas, which are composed of small glands. Even you, the audience over there, mostly clinicians, can see the difference between the large glands and the small glands. The ductal carcinomas are usually admixed with the asana carcinomas. You can see that large glands admixed with the small glands. And by definition, the basal cell layer is absent. Therefore, this is an invasive carcinoma. Now, due to mounting molecular evidence, there have been discussions to reclassify ductal prostatic carcinoma as a subtype of asana rather than retaining it as a separate tumor type. Most studies suggest that the ductal prostatic carcinoma is clonally related to the mixed acinar adenocarcinoma component because it shares the ERG rearrangements. But it is also found that there is discordant molecular origin, lower rate of ERG fusions, enrichment of germline somatic alterations of the DNA repair genes, and a higher frequency of mutations in the Wnt signaling pathway. In addition, prostatic ductal carcinoma is aggressive. It causes significant risk of biochemical failure and metastatic disease after definitive treatment. Less responsive to ADT, a small subset, also arises from the transitional zone around the prostatic urethra. The level of PSA is elevated but lower than asana prostatic carcinoma. It has an unusual pattern of metastasis to lung, liver, brain, skin, sometimes even the penis and the testis. Therefore, ductal adenocarcinoma is still maintained as a separate type from the asana adenocarcinoma in the 5th edition of the WHO. How do we report them? In the radical prostatectomies, we report them as ductal adenocarcinoma only when we see more than 50% ductal morphology of those large glands. In the biopsy, we use a term adenocarcinoma with ductal features. Irrespective, even if it shows a pure ductal pattern, we call it with ductal features. All ductal adenocarcinomas are Gleason grade 4, and ductal adenocarcinoma with comedonecrosis is a grade 5. Now, coming to pin-like adenocarcinomas, they look like pin, but they are actually invasive tumors. They are large glands with a flat or tufted architecture, as opposed to the papillary or the cribriform architecture of ductal prostatic carcinoma. This is not pin. This is an adenocarcinoma because there's a loss of the basal layer which is highlighted by P63. Each individual gland looks like high-grade pin, but it is not pin. Now, pin-like adenocarcinoma was earlier thought to be ductal, but now it comes under the Asana prostatic carcinomas. They are a Gleason score 3+3, and their behavior and recently described genetic changes are different from those of ductal prostatic carcinoma. It has a favorable prognosis, just like the Asana prostatic carcinomas. And 60% harbor mutations in the RAS-RAF pathway, distinct from the molecular profile of both ductal and Asana prostatic carcinomas. Now, coming to PIN, let's put a pin on that. Low-grade PIN is removed as a reportable entity because there is no increased risk of cancer detection. It's not possible to reliably differentiate this from benign glandular hyperplasia. High-grade PIN, what we speak about is 3 patterns: tufting, micropapillary, and flat. They don't have any clinical significance, and we should not be reporting it in our reports. Now, this is a typical PIN with crowded, stratified, atypical secretory cells in pre-existing normal size expanded glands lined by pleomorphic cells with pleomorphic nucleoli. Please note the basal layer is present, but often discontinuous, so this is a high-grade PIN. The intraductal proliferations, let's come to AIP and IDCP, some more terms to confuse you. High-grade PIN cribriform subtype is no longer regarded as a distinct entity. It has an architectural and cytological atypia which exceeds high-grade PIN but is short of intraductal carcinoma. It is now given a fancy term, atypical intraductal proliferation. The clinical implication is that AIP is associated with 50% risk of prostatic cancer and IDCP on a repeat biopsy. Now, while isolated high-grade PIN can be conservatively followed, AIP warrants an immediate repeat biopsy if there is no invasive carcinoma. So this is an AIP which has an architectural and cytological atypia exceeding high-grade PIN but falling short of IDCP with the basal layer present. Now, coming to the interesting IDCP, or the intraductal carcinoma of the prostate, they represent 2 entities. Majority are said to be late events in which there is a high-grade carcinoma which is spreading into the ducts and acini in a retrograde fashion, and a minority arises from the high-grade precursor and may represent a carcinoma in situ, just like the breast lesions. So the current concept is that IDCP is actually a high-grade cancer which is retrograde spreading into the ducts. Very rarely they can arise from precancerous cells with transformation and intraductal proliferation, just like breast cancers. So this is a typical IDCP with expansile epithelial proliferation of the pre-existing duct acina system, solid cribriform comedo patterns, enlarged pleomorphic nuclei. The basal layer is present. P63 is marking it, therefore it is intraductal. Now, there is consensus that IDCP without invasive cancer on biopsy should not be graded. This the pathologists agree upon. But what is controversial is, what if there is IDCP with invasive cancer on biopsy? There are 2 strong dadas, GUPS and ISUP. GUPS says IDCP should not be included in the Gleason score. ISUP says IDCP can be included in the Gleason score. The 5th edition WHO does not endorse either recommendation because of insufficient data. Buddha chose the middle path. There is a middle path. You can follow this. Isolated IDCP do not include it in the Gleason score, but you need to perform IHC. IDCP with prostate cancer, Gleason score 6, do not include it in the Gleason score. Perform the IHC for a basal stain. IDCP Gleason score 7 and more than 7, included in the score, and you need not do an IHC. Coming to the cribriform growth pattern, this includes the invasive cribriform cancer and the IDCP, and this should be reported in biopsy and RP specimens in Gleason 7 tumors. Though the distinction of the 2 requires a basal stain marker, this distinction is not crucial because both lesions negatively influence the outcome. We pathologists report it as cribriform growth pattern present. This is the typical cribriform, looks like a sieve, a tumor with holes, and this is how it looks like. Confluent sheets of malignant epithelial cells, glandular lumina, no intervening stroma. Coming to reporting of tertiary Gleason pattern, the grading guidelines of GUPS and ISUP are in agreement for biopsy specimens. You use the most common pattern, the primary pattern, and the highest grade pattern. So if you have 75% pattern 3, 20 to 25% pattern 4, and less than 5% pattern 5, it's a 3 plus 5, 8. The confusion again occurs between the two dadas, GUPS and ISUP. If you have more than 95% Gleason pattern 3 with less than Gleason pattern 5, with less than 5% Gleason pattern 4, it's a 3 plus 4 equals 7 as per GUPS, and as per ISUP, it is 3 plus 3, 6 with a minor tertiary 4. I repeat, the same happens with 95% Gleason's pattern 3 with less than 5% Gleason pattern 5. GUPS says call it 3 plus 5, 8. ISUP says call it 3 plus 3, 6 with a tertiary pattern 5. However, they are in agreement when you have 3 more than 5%, 4 and 5, and they say call it 3 plus 4 or 4 plus 3, 7 with a minor tertiary 5. Now, the treatment-related neuroendocrine carcinomas is a new entity following treatment present in 10 to 15% cases of castration-resistant prostate cancers. They look like small cell carcinomas and they express neuroendocrine markers. A quick word on molecular genetics. There are different genes for initial development, cancer progression, and androgen receptor resistance. There are genomic classifiers for localized prostate cancer, and the main therapeutic actionable alterations for metastatic carcinomas is the homologous recombination, microsatellite high, and CDK12 deficiencies. So I covered 8 terminologies in 8 minutes. I have a 9th terminology. Cannot rule out anything. Kindly quote.
Thank you, Divya. And last, you mentioned the ball was in the court of the clinician only, you know.
Hanji.
Okay, anyone like to make any comment? Dr. Santosh, you like to make any comment? Because you can only comment in this topic.
Others also. The main thing is that for clinical people, the understanding is that once you have a 3 plus 3, 6 Gleason on core, with an IDCP, the patient is out of active surveillance, because IDCP is almost always associated with a high stage and a high grade Gleason invasive cancer. So when we are considering active surveillance, if the pathology report mentions IDCP in any core, the patient should not be kept on surveillance. That's.
Thank you. I think so. That is the new message I also got.
Do you?
Yeah, most welcome. Yeah, you can finish by that time.
Do you quantify the cribriform pattern? And there are like sometimes large cribriform, small cribriform. What is the difference, and is there a prognostic implication for that?
Cribriform pattern includes 2. It includes IDCP, as I mentioned, the one with the basal layer intact, and it includes the invasive cribriform growth pattern. You don't really need IHC to differentiate the two because they both connote a bad prognosis. So in our reports, we don't quantify. We give, like, if it's for a Gleason 7, we do say cribriform pattern growth present or not present. I don't quantify. Do you quantify cribriform pattern? You don't.
Yeah.
What is, you did mention about ERG in one of your slides.
Sorry, sir?
ERG
Yes,
expression?
yes.
So the real hot thing came in early 2000, I think, the Tempress to ERG fusion.
Yes.
What is the status of that thing? Because Arul Shenoyan was, very popular at one point of time. Yeah. And we don't see that thing now. What is happening there?
So TMPRSS2 ERG genes fusion is responsible for the initial development of prostate cancer. And as cancer progresses, it takes in more mutations like loss of P10, inactivation of P53, gains, etc. So ERG fusions have been seen both in acinar as well as in ductal. That's why they're saying that they should be like, you should classify them together. But ERG fusions are seen less frequently in ductal than in acinar. That's why they're still keeping it separate. In fact, even the small cell carcinomas, some of them show the ERG fusions, and we have used ERG IHC to identify a small cell carcinoma by using ERG IHC if it's coming from the prostate, in addition to TTF1. So.
Okay, thank you. Divya, excellent talk.
Thank you,
enjoyed.
Thank you.
May I request Dr. Bhalchand Kashyapi to give his talk on rehabilitation post-radical treatment of
The well-known triangle of rehabilitation, but more specifically in prostate cancer, we should assess the baseline erectile function with one of the scores like IIEF, or assess the LUTS and the urgency, sphincteric strength, and also the risk stratification. This helps in deciding the nerve sparing or non-nerve sparing surgeries. The focus of today's talk is how better can we rehabilitate our patients post radical treatment, what is the importance of rehabilitation, and why should the uro-oncologist be a team leader of this rehabilitation process. Radical treatments could happen after surgery, radiation, or other emerging therapies. Also important is the diagnosis of a cancer, and its impact-related morbidity is also important, and we should also be dispelling the various myths about the treatment. We all know the standard side effects of a radical prostatectomy, which are mainly the patient concerned, that is continence, erectile dysfunction, rarely bowel dysfunction. Similarly about the radiation therapy. So for a prehabilitation, for any recovery, we should explain the pathophysiology in simple terms of the continence and the erectile function and both dysfunctions, assess baseline erectile dysfunctions and the other comorbidities. We should set up realistic treatment goals with regard to cancer control, continence, as well as the erectile function recovery. Start pelvic floor training exercises right from the beginning, teach the patient how well to do it. Now coming to the morbidity specific rehabilitation measures, if you look at it, for incontinence, we should continue the pelvic floor muscle strengthening exercises with or without electrical stimulation. Important to ensure that the exercises are done correctly. Many times the patients don't identify which muscle to contract. Pay personal attention, help them identify those muscle groups. Ancillary advices like fluid consumption, beverages, avoiding constipation. Consider early surgical options like male slings, either fixed or adjustable slings, or artificial sphincters for refractory and severe incontinence. Pelvic floor exercises are definitely useful in early recovery of the incontinence. It's been shown in many studies. Now, whether you choose a adjustable sling or a fixed sling or the sphincter, there are various options available for urinary incontinence. But what is perhaps more important is we also have some nomograms which can assess and predict the risk of incontinence both preoperatively and postoperatively based on the use of adjuvant therapies, the age, and the pre-existing function. So, important is how early to offer the surgical solution. There is a controversy in this. I think based on the severity and nomogram scores, early surgical solutions can be offered. We used to say wait till 6 months, wait till 1 year, allow the conservative measures to improve, but I think it does affect their quality of life, and in selected patients we should offer early surgical solutions. Coming to erectile dysfunction, again, offer nerve-sparing surgery whenever feasible. Though pills, injections, and the process are the mainstay of the therapies, also offer early PDE5 inhibitors to reduce the penile fibrosis. There is an interesting paper from Germany, a randomized study where they used masturbation to prevent the corporal blood flow, and they found those who masturbated frequently, their return to erectile functions were better. Now, again, this is a controversy. When should we offer a penile prosthesis? Either there are papers of simultaneous or early prosthesis option. So, simultaneous penile prosthesis with or without even artificial sphincter, there are studies on that. So, we have to be very careful in this. Coming to radiation therapy, cystitis, proctitis are important, but they are now less with improved technology, refined treatment fields, and hypofractionation. So, we need to ensure that the lower urinary tract symptoms are minimal or improved before you start radiation. Don't rush into starting a radiation. Better to give a hormone blockade or treat with whatever the therapies are required for improving the LUTS and then offer a radiation. It's better tolerated. I want to make you aware about the recent data from studies by Vedang and Gagan from Tata Memorial Hospital. They used a sodium copper chlorophylline molecule for reducing the side effects of radiation, especially hemorrhagic cystitis. These tablets are now available, and they are also being studied for a prevention of radiation-induced cystitis and proctitis. Hyperbaric oxygen chamber therapy is required in more severe or refractory cases. This is again cancer-related diagnosis, anxiety and depression, often under-evaluated and under-treated. Important is a good counseling, guidance, take help of specialized psycho-oncologists. We need to address the job-related anxieties as well as financial toxicities. So an ideal rehabilitation team should have, apart from a clinician, there should be a pelvic floor therapist, a prosthetic urological surgeon, a psychotherapist, sexual therapist, and a patient support group. So how can we make a difference? Yes, we should be the team leader of healthcare professionals. We should also assume the role of a neuropsychiatrist. We should get more involved in the patient care beyond surgery or radiation therapy, start a rehabilitation pathway and be a constant partner with the patient. Perhaps most important is we should give time to the patient. So can we make a difference in prostate cancer rehabilitation? Yes, we can and we all should. So rehabilitation is about rebuilding lives and restoring hope, and we should do that. Thank you very much.
Thank you, Dr. Kashyapi, for excellent presentation. And I agree with you because of the long-term survival of these patients after the definitive therapy. That is our aim, 10 years, 15 years, 20 years. So we should think of the quality of life. That is more important. And we should be honest with the patient, do a proper counseling, tell him the outcomes and complications of all the therapy which is available. And he should be make a party to select the treatment option. Because later on, he should not start blaming. If I would have gone to A, my thing would have been better, or B.
It should be a combined journey, and there should be realistic goals of the treatment. And the side
Anyone like to make any comments?
Sir, one thing about the need for a cardiovascular monitoring for these patients, that is very important.
Yes.
So at least those patients who are receiving ADT for a locally advanced with radiation, and we have observed that we do not follow these patients, and then suddenly patient relative will come, that patient died because of scar. So over the period we have realized that the cardiovascular, and it is reversible. The good thing is that you monitor the lipid level, you monitor them, exercise, that is also very important. So that comes, that is still not in our book to tell them to go for that.
The side effects of hormonal therapy are
Yes.
often overlooked.
Yes, sir.
But now with a younger population and who are likely to live longer, they
yes.
become more important.
In fact, the second cause of mortality in a metastatic
Is the
CF is the cardiovascular mortality.
Yes.
No, before starting ADT on any patient, I think so a proper cardiac evaluation should be done.
Yes.
And this now we have got other options like antagonist and all that. So why not to choose a proper drug?
There is a newer specialty called cardiac oncologist, cardio-oncologist.
Thank you.
Thank you, sir.
We invite the next speaker, Dr. Ravi Chandran. He is going to talk on sequencing pathways in multi-modality treatment for locally advanced prostate cancer. Surgery included. Dr. Ravi Chandran?
Yes, sir.
Yeah, please.
Good afternoon, everyone. I'll be talking on sequencing pathways in multimodality treatment of locally advanced prostate cancer. Well, I have a conflict of interest. I'm a uro-oncologist. I'll try my best not to be biased, but please cut me some slack if there's any. Well, coming to the definition of locally advanced prostate cancer, it is an evolving definition, but the broader consensus is any clinical T3 or T4 with any PSA, any ISUP grade would be defined as locally advanced prostate cancer. But as we all know, T3 was probably locally advanced prostate cancer a decade back, but definitely not now. And in few papers, there is an overlapping definition of high-risk prostate cancer, very high-risk locally advanced prostate cancer as well. And in few landmark trials, even a node positive status was taken up as locally advanced prostate cancer. Well, coming to why is it important for us to have a clear clarity on management of locally advanced prostate cancer? This was the paper which was published in 2020. We looked at 273 cases of radical prostatectomy. And as you can see, about 50% of our patients have pathological T3 and above, and nearly 20% of them are node positive. So with this magnitude of prevalence, it's important that we have a clarity and consensus on how to manage these set of patients. Well, what does 2024 EAU guidelines say about locally advanced prostate cancer? So we have two important modalities. One is radical prostatectomy and a radiotherapy. The gist of the summary is, if we are doing radical prostatectomy, add an extended PLND as a part of multimodal therapy. And when it comes to radiotherapy, it's a whole pelvis radiotherapy with about 2 years of ADT, with or without 2 years of abiraterone in selected cases with high-risk features and in ones with clinically node-positive status. Well, comparing an RT and RP debate is eternal. Radiotherapy is something like our Rohit Sharma, a phenomenal batsman with lot of trophies to his credit, with lot of data, prospective and phase 3 trials to his credit. But then RP is like our Kohli. May not be much trophies and data and trials to his credit, but certainly one of the GOATs. Why do I say so? This is this one paper, RTOG 9202, wherein a long-term ADT with RT was established as standard of care. When we look at it, the overall survival at 15 years in this group was 30%. Please make a note of it. And then another trial from the same group, RTOG 9601, wherein they looked at a post-RP setting, giving an adjuvant or a salvage RT with ADT. And in this subset of patients, OS at 12 years was 76.3%, almost double that of the overall survival. The only key thing added in RTOG 9601 is having a surgery first and then subsequently going for a multimodality with twice of that of overall survival benefit in these patients. And this is another population-based analysis wherein nearly 39,000 patients were studied between 2004 to 2016. And based on propensity score matching, both cancer-free survival as well as overall survival was better with radical prostatectomy as compared to radiotherapy. Well, I would take it with a pinch of salt though. And how do we really say RT or RP which is better? We have a tiebreaker coming up in few years down the line, that is SPCG 15 trial. It's a phase 3 prospective randomized study where they're comparing the current standard of care, that is RT plus ADT, versus RP with EPLND plus adjuvant or salvage RT with or without ADT. Their goal is to have around 1,200 patients followed by a minimum of 10 years of follow-up. And as of 2022, the patient accrual has been slow and steady. Around 856 patients have been accrued. Probably they may complete accrual by around 2025 or 2026. Another 10 years of minimum follow-up. Probably we'll have some data comparing head-to-head between these guys. So, well, the debate is not whether Virat is best or Rohit is best. It's about having a teamwork, play together so that we make our patients treat better. Coming to evolving strategies in sequencing with radiotherapy as core of locally advanced prostate cancer, it was this EORTC trial wherein they looked at not just radiotherapy with a short-term ADT, but a radiotherapy with long-term ADT is superior. As we can see in these graphs, both CSS and overall survival is beneficial with RT with long-term ADT. Not just that, subsequently we got a POP-RT trial from our Tata team in Mumbai, wherein they looked not just prostate, but a whole pelvis RT along with ADT is better. Except for overall survival, rest all parameters were superior with a whole pelvis RT, and since then it has become a standard of care. Following that, we had a Stampede platform protocol where they saw not just RT and ADT, probably throwing in abiraterone and enzalutamide, will it make any difference? And the conclusion was, yes, combination of these ARSI along with ADT and RT is beneficial. Probably no extra benefit with adding enzalutamide to the abiraterone. As we can see here, both metastasis-free survival and overall survival, the combination therapy was more favor. So as we look at here, the management of locally advanced prostate cancer has been continuously evolving, either as RT or RP with a core of it. To begin with, it was only RT. Then we realized adding ADT is beneficial, not just short-term ADT, a long-term ADT would do better. Along with that, adding an ARSI is even more better. Well, coming to strategies with the core of RP in the multimodal therapy, we did know probably in last decade, following RP, we were looking at adjuvant RT without ADT based on SWOG, EORTC, ARO, and FIN prostate study group. But now we have a good clarity that salvage RT with ADT is better based on RAVES, Radical, GITUG, and with artistic meta-analysis. And this currently forms standard of care for LAPC with RP in multimodality as a planning. But then off late, we've got a good number of papers, a wave of papers, looking at why don't we have a neoadjuvant setting in RP as a background. And this is one paper, a systematic review and meta-analysis, where it has nicely clubbed up all the articles wherein short or long-term neoadjuvant hormone therapies were affected before RP. And they concluded that a long-term neoadjuvant ADT was certainly associated with a more favorable pathological outcomes, but whether these pathological outcomes will translate into a survival outcome is to be seen. And then we had another paper from Raghavan sir's team in Apollo Chennai, where they looked at efficacy of digarelix in neoadjuvant setting in managing locally advanced prostate cancer. They did give a median of around 3 months of digarelix for these patients. And they went on to conclude that the benefit includes improved symptom control for the patient, a significant reduction in margin positivity, facilitated surgical procedures. And there is even more data coming out. This is an interesting study where they looked at survival impact of neoadjuvant hormonal therapy before radical prostatectomy, and they saw whether adding an adjuvant RT will it make any difference or not. In the first graph, we see a prostate cancer-related death was more favorable when a neoadjuvant hormone therapy was added along with radical prostatectomy. And in the other graph, we see followed by neoadjuvant hormone therapy, RP, and then adding an adjuvant RT was even more better. And they went on to conclude that in propensity score adjusted analysis for this large high-risk prostate cancer, neoadjuvant hormone therapy before surgery significantly decreased prostate cancer-related death. And this effect appeared to be mainly driven by early addition of RT post-surgery. And the specific sequence of neoadjuvant hormone therapy plus prostatectomy and adjuvant RT merits further study in high-risk prostate cancer. And then we had another set of new data where they looked at, along with ADT, if adding ARSI is beneficial or not, and it's certainly showing positive results. And we also have a data from Raghunath sir team in HCG Bangalore, where they looked at adding abiraterone and digarelix as a neoadjuvant setting and see if it is beneficial or not. And data is certainly positive. And we also have a Proteus trial wherein apalutamide is being explored. Well, my take-home message is, definition of locally advanced prostate cancer is certainly evolving with better understanding of anatomy, technology, and experience. And the multimodality treatment is the crux. Neoadjuvant ADT with EBRT plus long-term ADT plus or minus abiraterone is the treatment of care as far as guidelines are concerned. And RP with early salvage RT plus ADT is an alternative. With new wave of data, do we have a role for neoadjuvant ADT with or without abiraterone, apalutamide is to be seen, and I'm cautiously optimistic on this option. And well, be gentle with your ideas, but harsh on facts, as said by Dr. Donald Coffey, one of the pioneers in prostate cancer. We certainly all have options in hand, and as data evolves, we have to be even more flexible with adapting these ideas. Thank you.
Thank you very much.
Nice talk indeed. Any comment from the audience? Anybody wants to make any comment or a question? The confusion seems to have increased or decreased, I don't know, but it's definitely...
I think I've given an unbiased
No, I think so confusion is still there, but we are waiting for that result of that long-term trial.
SPCD 50.
SPC.
Yes.
And then we will see where we go.
Yes.
Thank you.
Thank you, sir.
Now we are going to have a virtual talk from Dr. Professor Hashim Ahmed. He is a professor and chair of urology, consultant urologic surgeon, Imperial College from London. So he is going to give 2 talks, transforming screening, diagnosis and treatment of prostate cancer. And then also he have another talk, that is role of HIFU revisited or version 2, concentrating on salvage HIFU. So we will have both these talks one after the other. So let us start the first one, primary focal treatment option for prostate cancer. Dr. Hamid, can you connect to him? Hashim, yeah.
Thank you very much. Can everybody hear me okay?
Yeah, we can hear you.
Wonderful. Thank you very much, chairs, and to the organizers and to the audience for listening to me today and having me present. I'm sorry I can't be there in person. It's the second time I couldn't make it. August is school holidays in the UK, and so my family has made other arrangements, but I'm glad I can call in and participate. Fantastic talks preceding me, so I'll try and do this topic justice. I'm going to focus on treatment, mainly focal therapy of prostate cancer, and try and contextualize it within the screening and diagnosis paradigm. So just to declare my conflicts, I am a urologist and I make money from working in this area, as a lot of us do. And I also get commercial funding from various groups and academic funds as well. So my career depends on prostate cancer being a really important topic going forward. Before I start, there was something on trombone in the earlier session. And trombone is a randomized trial looking at surgery versus standard of care in men with metastatic, oligometastatic prostate cancer. It was actually a pilot looking at whether randomization was feasible, and it did struggle to recruit. The pilot did finish, but the main study has, I'm afraid, never been funded. The team have been looking for funding for the last 3 or 4 years, but the main trial has not been funded, and I don't think it will be going forward. There are other trials which are asking that question, but in a very different way. Atlanta is one of them. I'm the chief for that, and Avidity is a new study which will also be looking at that question, but from the PSMA PET screening era. So just wanted to clarify that for those of you who may not know. So for focal therapy, we all know that the concept is targeting the lesion, not the whole prostate, because although prostate cancer is multifocal, in a lot of patients, there is one index lesion which drives the progression of disease. And I think that evidence, that biological evidence, despite some rare exceptions that the literature has reported, it is really irrefutable now. If any in the audience felt that every single prostate cancer that we find should be treated regardless, then I think you're on the wrong side of history. Prostate cancer, despite being multifocal, there is one, sometimes two areas that are driving the progression of the disease. And tissue preservation is really the mainstay of surgical oncology. We are, in prostate cancer, late to the table because it's a concept that is actually certainly not new, but it should be part and parcel of surgical oncology. There's no way we can constantly treat the whole organ throughout the body. It's unacceptable in terms of its harms, and it is certainly unacceptable in terms of its therapeutic ratio for prostate cancer in a significant proportion of patients. And just to reinforce that index lesion hypothesis and index lesion paradigm, there have been studies showing that when cancer is metastatic, it is linked back to a single clone in the prostate. To the point now where you've heard, I'm sure, lots of people talk about and write about the fact that tiny, small grade group 1 cancers just don't behave like cancers, and therefore we should be calling them something else. And I know the pathologists and many urologists and oncologists are resistant to that paradigm, but it is gathering momentum. I think in the future we will probably just diagnose very few of these as to make it irrelevant in terms of that switch. But I think it reinforces the fact that despite multifocality, tiny areas of cancer which half of the men in this room listening to this talk have in their prostates, you wouldn't dare let any prostatectomy surgeon near your prostate for 1 or 2 millimeters of Gleason 6 in your prostate. So I think that paradigm holds. And with pre-biopsy MRI and targeted biopsy and transperineal biopsy, we expend so much energy, time and effort and resources to finding that one lesion often. I know that sometimes we find more than one lesion, but in a vast majority of men, we find one lesion, we expend so much effort trying to find that, and then we throw all of that effort away by treating the whole prostate. It doesn't make sense. And it doesn't make sense because what can patients expect when they have radical and focal therapy? And I've shown this table in many talks, and I don't think I've had a single person stand up and say, you're wrong with any of these percentages. This is the reality of what men go through after radical treatment compared to focal. And the focal data in terms of toxicity and side effects is 5 to 10-fold at least lower than the genitourinary and rectal toxicity that men can expect from the best radiotherapists, the best surgeons. In fact, in the UK, there are 2 studies that have come out in the last year. The True North Movember study, which was a prospective study, patient-reported outcome measures sent out directly to the patients from the research team. And they followed patients up to 18 months and these included all of the big robotic prostatectomy centers in the UK. So nobody was excluded, everybody was involved, and that showed at least 1 pad a day in 35%, at least 2 pads a day in 25%, and at least 1 pad a day in at least 3 pads a day in about 5 to 10%. So significant underreporting in terms of urinary incontinence, and the same study has shown that erectile dysfunction is 50 to 80%. Again, men are not being told this when we counsel them about prostatectomy. The PACE-A randomized trial, SABRE versus radical prostatectomy, 47% pad use after 18 months in the robotic arm and 5% in the SABRE arm, but more rectal toxicity in the SABRE arm and certainly urinary toxicity in the SABRE arm. So everything has harms, and so this table has been updated to reflect those higher toxicity rates. And these tables we show to our patients and they then decide. Comparative data just reinforcing that. So this is the part randomized control trial of focal HIFU versus prostatectomy. Randomized control trial. It certainly wasn't powered to look at these outcomes, but nonetheless, the signal, the difference, the delta between radical prostatectomy versus focal HIFU is extraordinary and reinforces that table. So I don't think there's any doubt about the toxicity differences. Which patients are suitable for focal therapy? This slide sort of summarizes what we do in the UK. There's a few outliers, but most of the time we stick to this, this strategy through consensus meetings. So we tend not to go with a PSA above 20 unless it's a very big gland and the PSA density is low. So we do sometimes adjust the PSA threshold based on that. We will treat up to radiological T3A, but not clinical T3. I think MRI overcalls T3A disease in the current paradigm, so we need to be careful about this Will Rogers risk shift phenomenon that's happening with MRI, both in terms of stage and in terms of grade when you start to do targeted biopsies. And as a result, we will treat 4+3 or 3+4, and if there's one area from a targeted biopsy, one core that shows 4+4, but the surrounding biopsies are 3+4 or 3+3, that tumor is a Gleason 7 tumor. It is not a Gleason 8 tumor. And so the US and other practices where you tell that patient you have a Gleason 8 tumor is completely incorrect. You have to take into account all of the cores that are positive from that lesion. We don't apply a cancer core limit, and we do sometimes treat high volume Gleason 6 with a visible MRI lesion because the data does show those men tend to progress more than non-visible Gleason 6. But we try our best not to treat Gleason 6 high volume disease. And we will leave up to 5 millimeters of 3+3 or non-visible low volume 3+4. with a small amount of pattern form. But they have to really have had a good biopsy. When we look on our diagnostic studies, and these are PROMISE, PICTURE, Prostogram, and our RAPID protocol, and a few other studies that we've carried out, we apply these criteria to, in many respects, a few thousand men coming through the UK. Now, obviously, the prevalence of disease and the disease characteristics are going to be different between different countries. But from these studies, about 40% of men who were diagnosed with clinically significant prostate cancer were suitable for a focal therapy strategy of some form or another. So a lot of men. The UK HIFU registry, and it has been going for the last couple of decades now, and this slide is slightly outdated by about 4 years. But you can see we do not apply focal therapy as an alternative to active surveillance in low-risk men. Low-risk men, we hardly ever treat now unless they can get a letter from a psychologist saying they really can't cope with active surveillance. And even then, we really try our best not to and convince them to stay on active surveillance. So focal therapy is not an alternative to active surveillance to treat anxiety. Our thinking about focal therapy has changed. We started off doing hemiablation, and these are rates of cancer and significant cancer within the treated area from our early studies. And with hemiablations, we were getting very good results. As we start to get closer to the cancer, like any surgical oncology field, as you start to reduce your margins, you start to get closer to the tumor and any stray cells. And so the rates of disease control start to deteriorate. And we went through a period, maybe 10 or 15 years ago, where we were trying to be too clever, and we were trying to treat right onto the lesion that was shown by the MRI. And as you can see, the rates of recurrence in field started to really drift up. And one of my concerns around using image fusion to drive focal therapy delivery is that people see the red blob on the screen and they get really close to it. You have to apply 5 to 10 millimeter margin around the tumor. And so really you have to deliver a quadrant or a hemiablation approach. And that still gives you the toxicity benefit, but gives you much better disease control. So that last 15, 20 years of data is reflected in this study that we published. So it includes all the failures, all the poor practices that we learned from. But nonetheless, the overall outcomes very reassuring in terms of failure-free survival and also metastases-free survival. The key difference when failure does occur is that we can do focal therapy again. And the side effect profile is again very similar, and men have effectively 2 bites of the cherry before they have to shift to surgery or radiotherapy. This is just reflecting the same series showing metastases-free survival or overall survival as a composite. These men do well, whatever they have. But it's important to realize that when we first started focal therapy, everybody thought we were going to compromise men's life expectancies and there was going to be huge amounts of metastatic disease because we were leaving disease untreated. That has not been borne out by the facts of the data. There was also a concern that there would be a lot of out-of-field progressive lesions. Out-of-field lesions that are significant and that declare themselves over a 5 to 10 year period occur in about 1 in 20 men. So it's not zero. 1 in 20 men, I would argue a 5% risk reflects the inaccuracy of our MRI scans and the inaccuracy of our biopsy strategies. So there's always going to be, when you leave tissue untreated, breast cancer, any kind of cancer where you preserve tissue, there's a risk of new lesions occurring. But that signal is not concerningly high. This is cryotherapy. Again, there are some low-risk cases. You just can't see them. There's a tiny green bar at the bottom. I would challenge any prostatectomy or radiotherapy series to show these bars and show almost no low-risk cancers being treated. So the stick that we get beaten with is that we're treating men who should be on active surveillance. Certainly in the UK, that is not happening. And I would say prostatectomists and radiotherapists are over-treating more than we over-treat. This is early data again from cryotherapy. We apply cryotherapy for anterior tumors. We've learned that HIFU, because the sound waves have to travel through more tissue, struggle to treat anterior lesions as effectively. So the recurrence risk after HIFU for posterior is about 1 in 5. If you treat an anterior tumor with HIFU, it's about 1 in 3. So we switched treating most anterior tumors to cryotherapy or recently to nanoknife in some centers. And again, very reassuring, this time early to medium-term outcomes from cryotherapy in terms of failure-free survival and certainly no evidence of metastases or survival issues. So reassuring case series data, registry data. Do we have comparative data? So we carried out a propensity-matched analysis of focal therapy using HIFU or cryotherapy versus prostatectomy in the UK. And as you can see, the failure-free survival probabilities from these Kaplan-Meier curves effectively overlap. So it's no significant difference from these studies. We also did a 3-way propensity-matched analysis with surgery, radiotherapy, and focal therapy. And whilst the patterns of failure that you see are different, radiotherapy often uses hormones, so you see failures a bit later on. Focal failures tend to happen more consistently over that time. Surgery failures tend to happen a little bit earlier. The patterns of failure are different, but the metastases-free survival and the cancer-specific survivals over the medium to some long-term data shows no differences. However, these are propensity-matched studies, and there will be some residual confounders that we have not taken into account. So they do not represent level 1 evidence randomized study data. So can we get randomized study data? I mentioned the PART trial earlier on, and I showed you some toxicity data from that. This was run in the UK, focal HIFU versus prostatectomy. They reduced their target from 110 to 90. They did meet that new target, but using an extended period of recruitment. It only recruited in certain centers who told patients incorrectly and unethically that you cannot get focal therapy outside of the trial. And then, as you can see, the dropout, the non-compliance between the two arms was hugely asymmetric. And just focus on that 1 in 4, 1 in 5 men who drop out in the prostatectomy arm because they do not want to have prostatectomy. They went into the trial hoping that they would be randomized to focal. And then when they didn't get it, they did a bit more digging it around. They realized they could have focal in the NHS under the public system. It's been approved for the last 10, 15 years within registry data, and they went off and had that. The Oslo trial was much worse. So they did randomize 213 patients, huge achievement. It's always a huge achievement to randomize in these trials. But about 1 in 4 patients in the prostatectomy arm refused to have prostatectomy and had focal, and a further 7% just declined to have treatment because they just went on surveillance. And so there was a 1 in 3 non-compliance rate in the prostatectomy arm. That is enough to take away any power calculations that are looking at cancer control. You can't have that sort of asymmetric non-compliance unless you take that into account in your power calculations, which neither of these studies did. And then we were forced by a funder, we were interested in the paradigm of neoadjuvant hormones before focal therapy to reduce the number of men going off to needing further treatment. But the funder insisted that we also carry out an RCT of focal versus prostate versus radical treatment. And so we did this. We had a target of 60. We had to lower it to 36. We extended the recruitment period. We did randomize 36, but almost equivalent, 1 in 5, 1 in 4 men refused to have prostatectomy or radical therapy in the radical therapy arm. There was a few men who refused to have focal in the focal arm. They went on surveillance. So it's a sort of a, I think it was Albert Einstein who said it's a sign of madness to keep on asking for the same thing despite getting the same answer. And people keep on asking for an RCT. I've just shown you 3 RCTs that have failed. There have been other RCTs that have failed. Active surveillance in its current form has never been tested against radical therapy. Active monitoring has, watchful waiting has, but active surveillance has never. And Laurie Klotz and Chris Parker in the UK, Laurie Klotz in Canada, has tried. They tried and they couldn't accrue. Brachytherapy, which is in the guidelines solidly to be offered as a legitimate treatment option, 2 RCTs which failed because patients did not want to go down that route, as well as clinicians probably undermining the randomization. And yet we do allow brachytherapy. So there is an asymmetric way in which experts in the guidelines committees look at ablation. There's this sort of emotional response. And again, I've said this in front of the EAU audience and the EAU chair of the guidelines committee, and I've said this has to stop because this is wrong. We have to do it for our patients. So the guidelines for EAU have shifted. Initially, they said research only. In 2023, they have said HIFU and focal cryotherapy can be done within a prospective registry. And that can be data that you collect as you go along, but you must put all of your cases in there. And then lastly, for those of us who are calling for screening, as you will all be familiar, there are a number of criteria for meeting screening. I'm not sure we meet many of these yet, but one of the key issues is the treatment morbidity. The harms from treatment are significant still, and focal therapy is one of the heroes for those calling for prostate cancer screening. And I've said it a few times, there can be no screening without focal therapy. And we've insisted in our new Transform screening study, which is funded to the tune of 42 million, looking at new ways of screening for prostate cancer using MRI, prostagram scans, that they have to offer, those centers who want to take part have to offer focal therapy in a robust and rigorous manner, not just pay lip service to it, but offer it to the vast majority of men who come through screening who will actually be suitable for focal therapy. We cannot afford to replicate, to repeat the mistakes of our forefathers in screening and carry on over-treating men with radical therapy as they come through with early disease. So in conclusion, the new diagnostic paradigm forces us to revisit how we manage prostate cancer. We need to avoid biopsy in almost all men who have a non-suspicious MRI, if you can be sure about the quality of the MRI and the reporter. We need to carry out surveillance in almost all grade group 1 cancers and many grade group 2 cancers. We need to inform the thousands, maybe tens of thousands of eligible patients about focal therapy being a legitimate standard care option. And overall, for those advocating for screening of prostate cancer, we need all of these strategies to be brought in into our practices to justify population-based screening. Thank you very much.
Thank you, Dr. Hashim, for an excellent presentation of the current care for the prostate cancer and the role of focal therapy. I think so your lecture has been very interesting. Anyone like to make any comments? Some centers in India have just started the focal therapy. The many centers are not doing it still. So your lecture was very interesting. Yes,
Yeah,
Dr.
Hashim,
Rawal
I am
want to
Dr.
make
Rawal. We do focal therapy in a very selected patient, as we do not get patient like you have in England. My question to you is, what is the status of using HIFU in high-risk cancer prostate? Whether you give this with any ADT or something else, or you are just not treating high-risk prostate cancer with HIFU?
Thank you for the question, and thank you for having me at the conference. So I think it's one of the key questions going forward, and it would be great to look at setting up studies. So there are academic reasons why we should try and avoid high-risk cases, the incidence of micrometastases, but that is changing now with PSMA PET in order to rule out those. There is a sort of a geopolitical cause and reason as to why we should avoid high-risk disease, because people get so emotional about HIFU and cryo being used in intermediate risk disease. If we start shifting our focus on high-risk disease and we're going to get more failures, because all treatments have higher failure in high-risk disease. But whilst its failure in high-risk disease is forgiven when it's prostatectomy and radiotherapy, if it occurs with focal therapy, I suspect the hounds will be let loose on all of us for carrying out treatment, in a group that we shouldn't. So I think you are right. We should be moving more towards that. Whether that includes a neoadjuvant strategy in order to cytoreduce and then ablate, I think is a really, really good question. In Atlanta, which is a randomized trial of metastatic disease, one of the arms is ablation of the prostate after their after their systemic therapy, followed by SABR2 METs. So we are doing it in a trial, and the early pilot outcomes is that the harms are really quite low compared to standard of care and radiotherapy or prostatectomy.
Thank you. I just have
Thank
one
you.
question,
Yeah.
sir. You have mentioned about the driver lesion. Is the size only criteria for the driver lesion, or determining which of the lesions is a driver lesion? That's one. And second, how do we define failure in focal therapy?
Thank you for the question. So I think we're still learning more and more about what the threshold of size is for clinical significance overall, just to decide on who goes on surveillance versus non-surveillance. But in terms of focal therapy, I think image visibility is going to be a key thing. But image visibility is a sort of overall assessment of how much how much pattern 4 there is, and pattern 5 there is in a tumor. I think that's what the image visibility is showing, and the size of the tumor. So I think image visibility is going to be a key driver and risk classification. So we tend not to leave untreated something that is visible or of a, let's say, 3 or 4 millimeters or higher grade group 2 tumor. But most of the time, we will leave up to about 4 or 5 millimeters of Gleason 6, as long as it doesn't have a concomitant visible lesion.
And how do we define
and
failure?
I forgot your last question.
How do you define failure in focal therapy?
Oh, how do you? Yeah, it's a really good question, because we've been struggling with this when we design trials, because radiotherapy uses PSA. Oncologists refuse to allow biopsy to be in randomized trials, because we argued that the best way to monitor focal therapy is to use biopsies. But oncologists said, no, you can't use biopsies. It's not a good enough surrogate endpoint. You have to use survival or METs. With prostatectomy, there's nothing to biopsy. The prostatectomists refuse to allow positive margins to be used as a surrogate, probably just justifiably. But they define failure by biochemical failure. Whereas with focal therapy, it's quite difficult to come up with a biochemical failure definition. We are looking at our data to see whether we can, but nobody agrees on biochemical failure being a good enough surrogate endpoint for survival and METs. So whenever we've spoken about trials, people have talked about, well, you have to do survival and metastases. There's no way around it. That requires 1,000 to 2,000 patients being randomized. So I think the pragmatic answer is failure should be defined as transition to whole gland treatment using objective criteria, whether that's usually biopsies, or METs or death. I think that's the most pragmatic way of looking at what is failure of focal therapy. Partial nephrectomy, if you have to switch to radical nephrectomy, then that's a failure of partial nephrectomy. So that sort of makes intuitive sense, I think.
No, sorry. In the ones that you have presented already, progression-free survival, what has been used?
So we've used a composite. So it's the percentage of men who have gone on to have whole gland ablation, some of them do, or prostatectomy or radiotherapy, or have gone on to systemic therapy, a small proportion, or METs or death. But the latter two, as you can see from the graphs, are very little. So we've used a composite of that.
Thank you.
Dr. Hasim, you have good experience of the focal therapy. So the number of cases, what you have done, what is the nadir level of the PSA which comes down after the focal therapy? Why that cannot be taken as a cutoff point or something like that?
Yeah, so it's a really good question. So nadir plus 1 or 1.2, our last analysis of the data in Journal of Urology was published, showed that seems to be a good predictor of failure after 1 year. That hasn't been validated in external data sets yet. And so we're looking at validating that before we recommend nadir plus 1 as a failure definition. But it's a really good point. I deliberately haven't mentioned it because it hasn't been externally validated, and I think it would be wrong to use it until we know for sure that is the right definition.
Okay, thank you, Dr. Hashim. We really enjoyed your lecture, and you have given some good insight to us about the role of focal therapy in overall management of the prostate cancer. Dr. Amitabh, like to make any comments? You like to give your second talk now?
I'm happy if you would like me to. I can wait until the next session, or I can give both.
It's fine. You can finish it now, sir.
You can finish it now. You like to have coffee or something, then you can take a break, otherwise you can continue.
We can finish it off, then he doesn't need to wait around.
Okay, please. Continue.
Let me just switch. Can you see that?
No, sorry, we are not seeing.
Not able to see the slides.
Ah.
Now we are able to.
Yeah, we can see now. Yeah, sorry.
We saw it.
Okay, let me just go back in.
Yeah,
we are able to see them.
Yes, we can see them.
Okay. So again, thank you for allowing me to speak to yourselves about this. So this is about radio-recurrent prostate cancer, which is, I think, what Dr. Amitabh wanted me to speak on. Just to reiterate my conflict. I think this is an area that we have been remiss on. And we really do need to focus more of our attention on the fact that whilst radiotherapy is an effective treatment, nobody is saying it is not effective, it does have failure, like all treatments. And we've spent the last 2 decades focusing on trials and funding and investing in failure after surgery, but we've been really remiss in not concentrating or as much on failure after radiation. And I think you can all guess as to why that occurs. often the funding bodies and the funding panels are not full of as many surgeons as we would like, and the concentration has been on focusing failure after surgery and not looking at failure after radiotherapy. As almost, if you start focusing on it, then it becomes a thing. That's my personal opinion. I think there's a wrong way of approaching failure after radiotherapy, and we need to really look at it more. Because thousands of men every year around the world, tens of thousands, have radiotherapy, and in the low and intermediate risk group, about 10 or 15% fail over 5 years, and in the higher risk groups, it's much higher, as you know. And these men, when they do fail, they're usually a little bit older and have more comorbidities. They've had lots of hormones, which will have impacted on their comorbidities, and so the general perception is that if they do have failure, they should just go on systemic therapy. But there is a problem with that. A lot of the men who have radiorecurrent disease have microscopic or macroscopic metastases following biochemical failure, and that leads to a significant detriment in their life expectancy and their quality of life, and significant expense with the prescribing of systemic therapies and lots of drugs, which are very expensive. And obviously, the concentration of these patients into drug trials, somebody made a comment about that, it is an issue. These patients often are put into drug trials for that reason. And so we do need to concentrate on this. This is just to reiterate that there is a big difference between incidence of prostate cancer specific mortality following radiotherapy and prostatectomy between high and low risk groups. Obviously, these are not randomized trial data. And the guidelines are currently a little bit confused, or there's very little data to help guidelines determine what the best approach is for these patients. So a weak recommendation is to offer monitoring, including PSA, to low-risk biochemical failure patients, offer salvage prostatectomy or re-irradiation or ablation only within very well-designed cohort studies or trials, and salvage radical prostatectomy should only be offered in experienced centers. So we don't really have level 1 evidence on any physical salvage treatment. And just to focus in on the EAU guidelines on salvage prostatectomy, clearly, because these men are later on in their lives, they may have additional comorbidities. They may be able to recover less well from prostatectomy. We know that age has a relationship to continence after surgery in the primary setting, and we know that these men with their prostates really stuck down, this is tough surgery, it's difficult surgery, and the outcomes are pretty poor in terms of functional outcomes, although the cancer control outcomes are actually pretty good over a 5-10 year period from the case series that are out there. But we're looking at almost near certainty of urinary incontinence and up to 5% rectal injury risks. To the point where I think a lot of surgeons, and I don't know what the landscape is like in India, you have excellent robotic prostatectomy surgeons, international level, but how many of you offer routinely salvage prostatectomy? I don't know, but certainly in the UK, most surgeons try and avoid it as much as possible. And those centers that do offer it, when we send patients to them or ask them to review it, about 1 in 20 are actually operated on. So very little appetite for carrying out salvage prostatectomy. And very little appetite from oncologists to refer for salvage prostatectomy in the first place. And often those referrals are late if they do come. So minimally invasive therapies, we've heard about how it can be applied in focal and whole gland areas, but it can be used for recurrent disease after radiotherapy. And it makes mechanistic sense. This sort of supports the index lesion paradigm. If you look at studies which have evaluated patterns of local failure after radiation, almost all of the local failure occurs in the original index lesion. And so this, for whatever reason. And I think we're pretty good now at not only diagnosing recurrent disease and ruling out metastatic disease or identifying metastatic disease, but also localizing areas of cancer within the prostate. And there's a whole body of evidence behind it, but the Forecast trial in the UK was one study that we carried out about 10 years ago, completed about 7 years ago. And this looked at a cohort of men who were referred for with biochemical failure, who at that time it was choline PET. We didn't really have PSMA PET in those days, or very little of it. And they also had a bone scan and a prostate MRI. And they were followed by having a transperineal mapping, 5mm biopsies throughout the prostate, because that was the gold standard to evaluate what was going on in the prostate. And they also had transperineal targeted biopsies if there was a suspicious lesion. If they had localized disease, we would treat with ablation. But interestingly enough, and we are looking at continuing that paradigm, those who had oligometastatic disease would also have salvage focal ablation as a proof of principle. We didn't have enough patients to really consider cancer control, and at that time SABR wasn't around, so these men had systemic therapy plus ablation to the prostate, but the vast majority had localized disease only based on these imaging modalities and underwent cryotherapy or HIFU. So how does MRI perform in this setting? As you can imagine, a lot of men had recurrent disease in their prostate, so MRI sensitivity was really high, but the specificity was better if you used a threshold of a Likert 4 to 5. Again, in those days, we were very early in the days of PIRAD, so PIRAD scoring hadn't come along, but we know now from studies that Likert and PIRADs, there's very little to distinguish between them. So MRI is pretty good, but you do still need the biopsy. And what we found was about 6% of cancers were missed by systematic biopsies that were picked up by the targeted biopsies, and about 8% were missed by the targeted biopsies and only picked up on the systematic biopsies. So there's a sort of a need to do both. Was our conclusion. And in those men who had treatment, the continence risk is not as low as it is in primary disease, but it is certainly lower than what we would expect these same men if they had prostatectomy salvage carried out. And in this study at least, we didn't have any rectourethral fistulae, but rectourethral fistulae does occur in about 1% of patients, maybe 1 in 200, as we've learned from our early mistakes to try and reduce fistula risk, because that is the one thing that really does mess up that patient's life and ruins your life for about a few weeks whilst you have to deal with it. So pretty good continence data, but not as good as primary disease as you would expect. So, and then this was the progression-free survival defined as anybody with biochemical failure according to Phoenix. There's arguments as to whether we should use Phoenix post-ablation for radiorecurrent disease, but given that it was used in the first place to define radio-recurrent disease, we felt that that was most applicable. The PFS included metastases or death. And then this shows the specific definition of metastases-free survival, which is probably more pertinent in this group, and certainly we will find this as an endpoint in studies to be much more pertinent because you get the endpoint much quicker in a higher risk group. But pretty reassuring. Outside of the trial, we've treated quite a few hundred men now with salvage ablation as part of our UK registries, and this shows the failure-free survival, again using that same composite. Pretty reassuring, pretty consistent with the forecast formal trial. Still not long-term data, but early to medium-term data looks reassuring, and overall survival in a high-risk group, as you can see, is very reassuring. And a systematic review, there's been 2 systematic reviews, one by our group led by Tamer Shah, who leads our academic program in salvage disease, and another one led by Amar Kishan. Again, showed that studies were really all over the place in terms of their inclusion criteria, in terms of what they did, and not surprisingly, the biochemical disease-free survival rates were hugely heterogeneous and varying. But grade 3 adverse events were quite rare. We are still interested in comparative data, and it's something that I'm very keen on. I think this is an area where we should be investing, as I said, more effort and more funds to look at that we haven't been. And so we looked at another propensity match study between an international salvage prostatectomy data set and our own registry focal salvage data set. And as you can see, the cancer-specific survival and the overall survival, those curves really overlap. Now, both curves very reassuring. And we know that after ablation, the harms are less. So I think there's starting to be a shift towards the fact that this ablation paradigm in radio-recurrent disease may be the way to go. Clearly, again, a health warning about propensity match studies. There are plenty of residual confounders that we will not have taken into account. So, in conclusion, radio-recurrent prostate cancer is a significant healthcare issue. We need to invest in trials and treatments in this area, not to excuse, not to do fewer studies in failure after prostatectomy, but there has been too much of a focus on failure after prostatectomy, and I think that's a legacy issue because it's our fault as urologists. We haven't been pushing this cause as much as we should. We haven't been sitting on those funding panels. We haven't been getting involved in peer review as much as we should. So I think it's a failure on us urologists. Radio-recurrent prostate cancer has been treated with systemic therapy on the whole, and these patients have, on the whole, gone into systemic drug trials. Salvage radical prostatectomy is high risk, even in those few men who are eligible, but when we do it, it should be done by the very best, and in men who are highly motivated. It's a very effective treatment. Salvage ablation clearly has fewer side effects and complications, but is higher risk because of the radio-recurrent setting that we are in. Early to medium-term cancer controls may justify its use in expert centers. It does have a lot more of a learning curve, so it really should be done by people who've done quite a few cases for primary ablation of prostate cancer. I always advise new centers who are starting HIFU or cryotherapy, this is not the group of patients to start off on, because you will get complications, you will get strictures, you will get abscesses forming. Sometimes the whole urethra just completely obliterates. You will have incontinence and occasionally fistulae, and your colleagues around you will start to, think what on earth is going on. So get some really good outcomes in primary ablation and then speak to your oncology colleagues and see whether they may start to refer men for salvage ablation, but they must refer those patients early. The tinier these lesions, the better their outcomes. And I think this is an area where we can really get some nice level 1 randomized data. Thank you very much.
Thank you, Dr. Hashim. Again, giving us the insight for management of the post-radiation recurrent bladder prostate cancer. My question to you is, in this focal therapy, between HIFU and cryo, I think so cryo has been done for many years actually, And so how do you select a case, or it depends upon the center which modality is available? Is something like that?
Yeah, I think it's mainly the latter. So if you have an ablative modality which is just HIFU, anything that isn't eligible for HIFU, you either have to send to another center or offer them prostatectomy or radiotherapy. In centers where we have cryotherapy and HIFU together, we generally apply HIFU for posterior tumors because the risk of rectal damage is very, very rare. And we worry about that ice ball drifting down into Denonvilliers fascia because that's how much you have to push the ice ball. So we're worried about rectal damage. So cryo for anterior because there's plenty of space to grow the ice ball.
Thank you. Yes.
Thank you very much, sir. Thanks for highlighting where we can use it and where we should not. Thank you. And thanks a lot for joining the sessions.
Thank you very
Dr.
much.
Hashim.
Thank you for having me.
Excellent lecture, sir.
So
thank you. It's very kind.
We'll have a break for 15 minutes and rejoin at 4:45. We are running around 25 minutes late. So if we can come back by then, for them to collect it and come in. Yeah, you can go out and get it done. Then we can try to continue and probably finish on time. Vineet sir, what do you advise? Okay, we didn't. So that's what I was talking about. So I'm going to request for the next set of chairpersons. Okay, Dr. Vineet Talwar sir and Dr. Malai Bera. Dr. Mandal and Dr. Sujay Gupta are not there, I'm told. And I'm going to request Dr. Vinay Maka to start off with the talk on next generation sequencing and the role of PARP inhibitor therapy in 2024. Malai Bera, Dr. Malai Bera. He's not there. Okay.
Thank you. I would again thank organizer giving a talk to me. Very interesting. So the topic was serial next gene sequencing or NGS and role of PARP inhibitor in 2024. So the coverage will be general indications for genetic testing in prostate cancer, the rationale for the serial testing of NGS, and what is relevance for us is how to sequence or use PARP inhibitor for this subset of patients. First, general indications, just to give a perspective, there are germline mutation and there are somatic mutations. The germline mutations are the one which we occurs before the conception, and all cells in our body will contain this thing and can be easily tested on the blood, whereas somatic mutations are the one which you find in patients diagnosed with cancer and in the specific cancer cells. They are not present in the rest of the body. So the guidelines, the NCCN guidelines tells two things. For germline testing, any patients with prostate cancer and strong family history or a specific ethnicities like Ashkenazi Jews, and all patients with high risk localized or metastatic prostate cancer, we do it. And the sample is usually blood sample, whereas somatic mutation is what we see in the cancers. We do it for two kind of mutations. One is homologous recombination repair mutations, BRCA1, BRCA2, ATM check, PALB2, Falconi, RAD1 and CDK12 and MSI. And this is done in all metastatic, regional and high risk localized disease, and we prefer to use a primary tumor sample. So what is the rationale or what is the reason for serial testing or repeat testing of NGS? So let me have one case where we have a patient with 69-year-old male, initially presented as hormone sensitive stage 4 cancer, multiple lines of chemotherapy. One of the tests done post 2 lines of treatment was germline testing was done, it was negative. Then we continued 2 more lines of treatment, and then he agreed for a BRCA testing we did on liquid biopsy. So this is a case which typically happens. Why do we need to test again is the question. So cancers evolve over time. So we need to know at the start of the treatment what happens. So what is the rationale is the mutation incidence increases as disease progresses. So how much? So in a localized non-metastatic disease, there's 10% chance that a tumor cells will contain a DNA repair mutations. Among them, 5 will be inherited. Whereas in castrated metastatic disease, you will have 20 to 25% chance of them being mutated, somatic mutations, and among them, germline will be 10. So the proportion of patients will almost doubles. Apart from this, there are indications, specific indications for TMB and microsatellite instability where immunotherapy can be offered. So why we need to do test? Test could be wrong or incomplete, and the tools available for the sequencing have changed from first, second, third, and if you see the cost of the test and the speed of the test, it is proportionally, inversely proportional, and it has come down drastically. So that is one. Second, there is a discordance between the liquid biopsy and the tissue testing. This is the same study, Triton study, Profound, Magnitude, Propel, and Trito, where they have looked into the HRR genes in plasma or circulating tumor DNA and tissue. There is a range from 52% to 93%, there is a variance, and wherever possible, we should have both tests done if the patient can afford. Second, the impact of the tumor gene, the paraffin block which we take, how much relevant is the genetic information gives. So this study has been looked closely. What they've seen is as the sample ages, beyond 5 years, the results are not very helpful. So these are 3 reasons, and this patient turned out to be BRCA2 positive, and we offered him rocaparnib, and he was on DFI for almost 12 months. Then he's again relapsed. So that's a different story. So the preferences or best practice for in testing somatic gene is first, sample should be a new sample, first metastatic sample, if not possible, the archival sample, if not possible, liquid biopsy, last but least, a germline testing on the blood. This is your practices. Why this is relevant? So the only thing we can offer them is a PARP therapy, and how it's going to change. So it's mainly done because tumor evolve, the test maybe fail, or the indication changes. This is the multiverse. Like you can see 4x4 table. You're not given taxane, not given hormone therapy, or you're given taxane but not given novel therapy. All 4 options, but they're not same. So the difference, just dissect it out. So before we go there, PARP inhibitor, the mechanism. So there is a DNA damage. In our body, whenever DNA damage occurs, it can be single strand or double strand. Single strand is always repaired by PARP, where a double strand is always repaired by predominantly HRD panels, and there are non-homologous also there. Whenever there is a deficiency of double strand repair mechanism, either by BRCA or similar genes, it depends upon the single strand genes. So you can induce the single strand repair inhibition, and it causes apoptosis to the cell. So this is called as synthetic lethality because we induce the lethality for the patients. So there are multiple resistance for PARP also. Remember, it's not a standard because eventually it may be inherently resistant, which is primary resistant, or it may be secondary resistance, giving example here. So when patient is on PARP therapy with a BRCA2 mutation, there can additional reversion mutation can occur, and it can revert back to wild type. So it will lose the effect of PARP inhibitors. Second, so cross resistance. Can we sequence rocaparnib, olaparib? No. It's a class effect. So most of the drugs which are resistant to one line will continue for second line. Exceptions are, you have a concern that patient is not taking tablet or not tolerating, or you don't think inhibition is there, but most of the recommendations do not advise sequencing. Coming to the difference in predictive significance of HRD genes. So let's assume this is a chart. We have 4-5 parameters. For PSA, 50% response. In that subset, PALP2 has the highest response to the tune of 70%, BRCA2 is 60%, and BRCA1 is 24%. Whereas mutations such as PALP2 will have an objective response as well as composite response. Compared to this, the three, first PALP2, BRCA2, BRCA1, CDK12, CHEK2 and ATM do not have that kind of objective response. So I give you two examples. So BRCA2 is the most common and more aggressive, worse outcomes, will present with higher glycation scores, have a higher rate of PSA, have lower chance of survival, but there are almost 50% of the first relative will have a mutation. But these drugs are more responsive to PARP inhibitor when compared to BRCA1. So ATM gene is the second most common mutation in this prostate cancer. They don't respond to PARP inhibition. Why? They are involved in DNA repair. Their job is not to repair the protein. Their job is to sense the DNA damage. So those are not effective, and we need a better drugs like ATR inhibitors. So these are the difference in the predictiveness stiffness of the HRR genes. Coming to where we should offer combination, where we should offer monotherapy. So same chart again. These are the studies. I will not go in the depth of the studies. Approved drugs, their studies is there. So coming to where the drugs have been approved for single agent. So olaparib is approved for HRR gene mutated CRPC, metastatic castrate-resistant prostate cancer, who have been prior treated with enzalutamide or abiraterone. Rucaparib is only for the BRCA mutation. Very clear. Single agent, if you are using rucaparib, it is BRCA. As of now in India, only olaparib and abiraterone has the data. No, and this can be used only for BRCA mutated CRPC. This is the thing. Only thing to remember, you cannot use a PARP inhibitor in a wild type HR mutation status. These are the new drugs which are coming. You have to manage toxicity. There are some guidelines to manage MDS, bone marrow suppression, cardiovascular side effects. For example, GI toxicity, you can just give night dose and make the tolerance better. So to conclude, serial testing is necessary because tumor evolve. Test may not be showing accurately. They change over time. PARP inhibitor can be used alone. They can be very effective in the management of CRCC. Efficacy is closely related to the qualifying genomic alteration. You have to use in what indication they have been approved. Toxicities of the PARP inhibitor is very important, significant, and has to be.
Thank you, Dr. Vinayak. And you have nicely brought about few salient features. One is that BRCA2 is the commonest mutation which is there, and at this point of time in prostate, we should focus more on BRCA1 and BRCA2 whether PARP blockage is concerned, because the others may not be as efficacious. And as far as the testing is concerned, HRR has to be done. If possible, it should be done in tissue and blood both. If not, then of course, tissue is to be done first. So thank you so much.
Thank you, sir.
Any questions? Yeah, Raghavan.
Do we have any data as how many patients in our setup in India has HRR positive mutations?
So
do you have any data?
Published data is there, but I didn't quote it. But it was
5%, 20%?
So what we've seen is 20% in castrate-resistant prostate cancer. So till now, other than BRCA1, BRCA2, I've seen PALP2, CHEK2, and hardly 3 or 4 patients.
I think this number, sir, is one digit.
Yeah.
It's not. It's single digit.
See,
It may be two,
okay,
but we have just analyzed so it's around close to 7%, 8%. It's not that whatever quoted in the literature. And most of them are BRCA2, but definitely it's not in a 2 digit.
Only 20% of the castrate-resistant have DNA repair mechanism. Out of them, 10% is BRCA or BRCA2, and rest 10% are other DNAs. Out of them, ATM is a most
presume
common.
this is all Indian data, as in
No, no,
the human beings that come to our clinic.
No.
So I know why you're asking that question, Raghavan, because you must have done it many times and you would have found it negative.
Sadly, yes.
Yeah,
Yes.
that is the thing. So the answer is very clear. It's about 7 to 9%.
Thanks.
And
Thanks.
actually in BRCA also, there are variant types are more common in our practice than otherwise. In fact, my patient was variant.
Thank you, Dr. Vinayak. Thank you so much. So we move on to the next talk. This is the technical advances and innovations in robotic surgery across the 3 platforms. What is on the horizon? And may I
analyzing data and how that data can be used for surgeon training and then teleproctoring and telesurgery. So I'm not going to talk about anything which is there from last so many years, which we are using. So I'm just going to talk about what is new around the globe and what in near future we might see. So we all know Da Vinci 5 has come. So all of us agree that ergonomics are a very important issue, and robotics, we have improved ergonomics, and still we have been using this Da Vinci system, older system from last so many years, but still there is a potential to improve, because you cannot just sit straight and in your natural position and do the ergonomics in the present systems. You have to bend your neck a little, and that was the premise for open console robotic systems. So with Da Vinci 5, that was improved, and in Da Vinci 5 ergonomics headset was like the technology was changed. You can just sit straight and in your natural position, and you can take the headset towards your position instead of having that limited amount of ergonomic control. Also in Da Vinci 5, more controls were there on the surgeon's console, like insufflator was integrated. You can control the insufflator from the console, and other cauteries you can control, settings you can control from the console. The more important feature was the force feedback. We know that there is no haptic feedback in a robotic system, but in Da Vinci 5 there is sensors at the tip of the instruments which give a force feedback to the hand controls, and the surgeon can feel how much force you're applying alongside the visual cues. Earlier it was only visual cues. Now with the visual cues, you also get a feel of how much force you're applying, and this can help you in doing gentler surgery and better outcomes. Mantra 3, there has been significant improvement over Mantra 2. So the arms are sleeker now. You can use up to 5 arms. You can use both sides. You can toggle and use additional arms. And with sleeker arms, you can use them in a straight line. Multi-quadrant surgery with smaller footprint can be done. Also, the main difference was in surgeon command center. Surgeon command center is totally gone. Now we have smaller, we have the advanced immersive 3D glasses, and you can see through that. And we have a smaller hand controls which make magnetic field in the around that. And with the safety feature, you can operate. It is very light, and you can use it freely. So also this system has teleproctoring and surgery capacities. There are multiple instruments for Mantra 3, and one of the good instruments which we look forward to is multi-fire clip applicator. So you can use that clip applicator multiple times. So simultaneous to these instrumentation advancements, we see application of AI and also augmented reality. So IRAs, which is now called 3D models, have been used for some time now. So we are not using it in India very often, this system. But you have 3D models superimposed. We can see these 3D models in the Tile Pro. And a study which was presented in AUA a couple of years back showed that 20% of the time decision would have changed if iris was used. So more than this, the augmented reality can be used for overlapping the 3D models on the real-time endoscopic picture of the robotic system. So imagine if you have like technology like having force feedback, also augmented reality, and combining all this, you can have a idea of where the positive margin would be, what amount of force you are giving. Also with machine learning and algorithms, you can have an idea of what are the planes where you can have the bleeding. So all this technology is in the near future you can use. So this video was taken from a publication done a couple of years back by Italian group. So in this, they use a software which is called RViewer, which merges the 3D models with the endoscopic image. After merging, that is sent back to the console, and along with the image, you can see this overlapped image on the console itself. So it can help you in dissection as well as the reconstruction of the, so this is the reconstruction part. You can see where the arteries and all the things are there. So Now, similarly, SSI Mantra's Maya division, they are coming out with the Diacom, viewer, which can pull out 3D images and help you in the seeing those images during the intraoperative period. So, lastly, the data is actually very important. We have been using this data for publishing papers, learning theoretical knowledge, but data has never been used to learn, it has never been analyzed objectively and used to learn from your own surgical technique. So, My Intuitive app, many of us know, it is there. It will give you a lot of insights how you have used the instruments as compared to the experts. What is the unproductive time which was there, whether you can use it better, how many times, which instrument you have used, also whether the surgery time can be decreased by using different combinations, and the important use of third arm. So kinematics data, if you go finer, kinematics data have been used. So kinematic data give your use of two instruments on the two hands, and also the camera instrument. And then you can analyze the degree of variation you are using as compared to the expert. On the right side, you can see the graphs. The lower graph is the neurosurgeon with the wider space, and in the expert, it is more of a focal. So, and then with the machine learning and algorithms, you can also predict outcomes of your surgery. After doing few number of cases, you can actually see how your results are going to be. So, for training purposes, you can also view your videos as compared to the other standard videos. Step by step, you can see where you are lagging behind. You can improve on those steps so that you can improve with your own surgery feedback. So this is courtesy of SSI. This is Dr. Srivastav. So he had already done teleproctoring for 2 cases. So it is there in the SSI Mantra 3. Sir is sitting here, Dr. Awal. They have also done telesurgery. I think at the time of RFCON, sir, if I'm not wrong, it was demonstrated. So another system which is there is Hugo RAS. So Hugo RAS has a software which is called touch surgery. It is used for basically, educating surgeons all across the globe. So you live stream the surgery with this software, and many participants can see it. You can record that surgery in the cloud, and then from the cloud you can retrieve it, and segmentation of the surgical various steps can be done, and more insights you can get it based on those particular areas of surgery or particular steps of the surgery. So I think with all this combined innovations in the newer instrumentations with the software, AI and augmented reality, along with the objective data analysis, we are still far away from reaching the pinnacle of robotic surgery. And I think in time to come, when these new techniques come, so surgery is going.
Thank you very much, Puneet.
Thank you, Dr. Puneet. Any questions from the House?
No question.
Yeah.
It did address the point that we wanted to raise. Sir, you can.
Yeah. So I actually didn't cover, sir, this thing because we were not using that much across these 3 platforms. Okay. Group surgery, yeah.
I had requested only for the robos that are available in India. Yeah. Thank you very much, Puneet.
Thank you.
So now we go on to the next topic. This is neoadjuvant immunotherapy for urothelial cancer. Will it be the future standard? And I request Dr. B.S. Biswas to come and delve on that. You have to switch gears.
Thank you, sir, for the introduction, and good evening to everybody. I like to thank the organizer for giving this opportunity. So it's a new topic. It's new to me, so I had to do some literature search and learn myself what is the role of neoadjuvant immunotherapy in urothelial cancer. So let's see what is the current data says and where you can put it. So you all know that neoadjuvant chemotherapy, be it DDMVAC or the GEMCIS, is a standard of care for all locally advanced MIBC, either T2 onwards or node positive bladder cancer before the radical surgery. But there are some challenges. We see many patients who are not fit for, who are cisplatin ineligible because of poor renal function, comorbidity, and many other factors. And there put the limitation of neoadjuvant, and patient directly go for radical surgery. And for the upper tract, the radical upfront surgery is the treatment of choice. There is no role of NSCT as of now. Immunotherapy is a new, not new in bladder cancer. It is one of the most immunogenic tumor among the whole solid tumor landscape, and we have shown that immunotherapy shows excellent result in terms of overall survival benefit in advanced stage. So now it is coming in combination also in the advanced stage setting. So let's see what is their role, and is at all we can improve the PAT-CR rate and as well as the outcome in muscle invasive bladder cancer. As of now, the DDMVAC and the GMCs shows a PAT-CR rate between 35 to 40%. So this is the cisplatin eligibility criteria. You all know that there's a GALSI criteria, PS2 or more, GFR less than 60, more than grade 2 audiometric hearing loss or peripheral neuropathy, or the NIHA class 3 heart failure. And these are the situations where we cannot use cisplatin, and as of now, there is no role of carboplatin also in the neoadjuvant setting. So patient become either cisplatin eligible, we go for neoadjuvant chemotherapy. Those who are cisplatin eligible, we directly go for surgery. So the roles of neoadjuvant immunotherapy come, can we give neoadjuvant immunotherapy those who are cisplatin ineligible, number one. Number two, can we combine with cisplatin to get a better result in terms of higher PAT-CR and OS benefit. So these are the busy slides showing lots of clinical trial, mostly phase 1, phase 2 trial in neoadjuvant setting with pembrolizumab, nivolumab, atezolizumab, and nivo-ipi avelumab combination. I am not going to the details. Another set of trials, again mostly phase 1, phase 2, 1 or 2 phase 3 trial. Most of the endpoint for all those trial is the pathological complete response rate followed by EFS and DFS. So this is one of the important slides. They're showing the combination or the monotherapy strategy of neoadjuvant immunotherapy in bladder cancer. The first one is a PD-1 blockade, POR1 and the Abacus trial. Mostly cisplatin eligible or ineligible patient, Pembro or Atezo. Pembro is for POR1, Atezo for the Abacus. We have IO-IO combination. There are 3 trials. Nabucco is a Nivo-EP combination. Deuterino is a Durva-Tremelimumab combination. And another is a NCD2124, another Durva-Tremelimumab combination. Mostly 2 to 3 cycles of neoadjuvant immunotherapy followed by radical surgery. And if you see this pie chart, this is mostly showing the T2 tumor. There are few T3 tumor and very few node positive disease. We have chemo-IO combination, 4 clinical trial. BLAST 1 is the GEMCIS plus Nivo. SAC trial is the GEMCIS and Durva. And we have other trial with Pembro combinations. And there is one more trial is IO and target therapy, that is with olaparib and durvalumab. And majority patient again with the T2 and T3, very few T4 and node positive tumor. So these are the various combination strategy, immunotherapy either as a mono or combination being tested in neoadjuvant setting. So this is a neoadjuvant pembrolizumab POR1 trial, PAT-CR rate 40%. Pathological downstaging rate is 51%. This is a Nabucco trial with the Nivo-EP combinations, 24 patients. Almost all underwent surgery at 12 weeks. PAT-CR rate is around 46%. This is the cohort 2 of the Nabucco trial with a different dosing combination of Nivo-EP, mostly Nivo 1 mg plus EP 3 mg versus the vice versa in EP 1 mg versus Nivo 3 mg. Now, if you compare all 3 trials, if you see the PAT-CR rate, 46% in the cohort 1, the initial one, 54% with the EP 1 mg and Nivo 3 mg, but very low PAT-CR rate in case of the other one, the cohort 2B. So that shows that nivolumab 3 mg and ipilimumab 1 mg may be the best combination. This is a Deuterino trial, similar T2, T4 tumor are node positive after TURBT neoadjuvant setting. Durva-Tremi, those patients were cisplatin eligible patients. And there is a different design in terms of tumor inflammation signature. If the hot tumor is given chemotherapy versus immunotherapy, in the cold tumor is it only chemotherapy. PAT-CR rate in the cold tumor with chemotherapy is 70%. In the hot tumor with chemotherapy, it is 36%, and with immunotherapy, it is 34%. So in the hot tumor, there is not much of difference in path-CR rate between chemo versus immunotherapy. Unfortunately, in the cold tumor, they have only used chemotherapy, but with high path-CR rate, and the path-CR rate was more in the PD-L1 was high. This is another trial of INCT2124, durvalumab, but in cisplatin eligible patients. It also has a very good path-CR rate. Toxicity profile was overall manageable. There is no new septicemia. You all see lots of IRE, mostly between grade 1, grade 2, 10 to 20%, very rare grade 3. Another study is the nivolumab with the CZ007. This is a oncolytic adenoviral vector vaccine, intrathecal therapy with immunotherapy in neoadjuvant setting. 15 patient, 47% patient has a T2 disease. No DLT was identified. Overall grade 3, grade 4 AE was in 75%, but mostly related to the surgical morbidity. No delay in time to radical cystectomy. path-CR rate is 54%. This is another trial with anti-PD-1 tislelizumab with GemCis as a neoadjuvant setting, 4-cycle. path-CR rate 55%, downstaging is 77%. So this is the comparative trial, all these 4 trial. Nabucco, Deuterono, and the other durvalumab combinations. If you see the path-CR rate range between 35 to 45%, and there are another few 10 to 15% of downstaging. Mostly was cisplatin eligible, except the Deuterono, and there was also cisplatin eligible patient in the cold tumor. This is the comparative trial of all the 8 tumor, but in general, the path-CR rate remained between 35 to 46%, downstaging rate between 51 to 60%. Radical cystectomy rate between 90 to 100%. And these are the various biomarker has been tested in all those trials with a genomic signature, PDL1, TGA beta, CD8 cell, Treg cells with a different cutoff and heterogeneous results. I'm not going to the details. So these are the clinical trial ongoing for a cisplatin eligible and cisplatin eligible patient. These are phase 3 trial in monotherapy or as a combination, in the different combination. GemCis with nivolumab, durva with GemCis, pembro with GemCis. We have to wait for the trial. So phase 3 trial is awaited for this confirmatory result that has been shown in the phase 2. So to conclude, this neoadjuvant immuno or chemo or in a different combination before radical cystectomy showed promising activity in terms of path-CR with manageable safety profile. Maybe potential promising alternative for cisplatin eligible patient also. And also as a combination strategy for higher path-CR as well as a higher outcome. The survival outcome data for this phase 3 trial is awaited, and we need to see the result before we can use this in a clinical setting. Thank you very much.
Thank you, Dr. Beavers. First, for completing on time.
Yes, sir.
And second, it's a tough topic. At this point of time, how would you position immuno-oncology drugs in the non-metastatic setting? Because metastatic setting, we know patient is cis ineligible, immediately you go forward. So here you have 2 sets of trials. One is cis eligible and cis ineligible. So how do you meander through?
So for the currently, as of now, for cisplatin eligible patient, we are using neoadjuvant. I mostly use GemCis, but the DDMVAC also has a very good outcome, followed by radical cystectomy. For ineligible patient, we are not offering anything. Directly go for radical cystectomy. Few patients do receive in adjuvant setting carboplatin base, but for the POUT trial, the benefit is not that great. And now we have adjuvant nivolumab for PD-L1 positive patient in both for patient who has received neoadjuvant with a residual disease versus those who didn't receive neoadjuvant in adjuvant setting with a 1 year of nivolumab. That shows DFS benefit. The OS data is still awaited.
So that means yes.
Sir.
No, I just wanted to ask him about in NACT situation. I recently, this year I went to GU ESCO, they presented the data of GemCis plus pembrolizumab, and they showed 80% response.
Sir,
have you used it, or you have any personal experience?
Not used it. I think that is from the phase 2 data, sir.
Okay, but it was there.
Yes. One of the trial is that.
At this point of time, either you give chemo as neoadjuvant or you don't give. You do surgery directly, then in the adjuvant setting, if you find that is high nodal positivity or patient had received neoadjuvant, then probably you can give adjuvant IO.
Yes,
Sir,
for
if
1
I
year.
may.
Yeah, one.
So the data that was presented, I think what Dr. Sudhir Raval was referring to is that in the same, in GEO-ASCO itself, there were two sets of studies that were presented. Even in the cisplatin eligible patients, it was EV
Yes.
plus Pembro. Even in the, not the ineligible, the cisplatin eligible, the first day that was presented was the EV plus Pembro was better than chemotherapy, GemCis. And the second day that was presented was the GemCis nivolumab was better than GemCis.
But that is in the advanced stage, sir.
In the non-metastatic setting.
Non-metastatic PVV Embro.
It was in metastatic. It was in metastatic. Yes. Cisplatin in even cisplatin eligible patient EV plus Pembro.
Yes.
So that was in a metastatic setting.
I'm so sorry. Maybe
Yeah, advanced stage. It is in
advanced
stage.
stage.
Yes.
So neoadjuvant IO, I think at best there are good phase 2 trials.
Yes, sir.
Phase 3 has to mature probably, I think, in the
Probably
next
it will
year.
come very soon.
Yeah.
And I'm sure it is going to one of the promising, probably a positive trial.
Yeah, it has
Look
to
like.
be a natural progression of any drug.
Yes, sir. Look like.
Thank you so
Thank
much,
you, sir.
Dr. Bukes. So with that, we go on to the next session. This is a simulation-based training in uro-oncology. And I would request Dr. Vivek Venkatramani. Yeah.
Good afternoon, everyone. Thanks to Sogo and Sanjay sir for the opportunity today. So simulation is an imitative representation of a process or system that could exist in the real world, and it's commonly defined as experimentation with the help of a model. So important types are physical, where a physical object is substituted for the real thing because it's smaller or cheaper, and interactive simulation, which is a human in the loop, which is a physical with a human. For example, the common flight simulators, which are very crucial in the airline industry. And healthcare training and the healthcare industry has incorporated simulations from very early days. In fact, there are archaeological discoveries of disease models which were used as simulations to train doctors in the past. So the use of simulation in our training is to kind of balance the see one, do one, teach one algorithm which existed years ago with the newer and much safer, never do the thing first time on a patient. Because you have to have adequate experience before you actually step onto the patient. And surgical skills can account for up to 25% variation in patient outcomes. And gaining experience and skill is not always possible on physical patients. We've seen this ourselves in the last 10, 15 years with a huge increase in seats, variability in training across centers in the country, that there will be a gap, and that can be bridged with the use of simulators. So simulators facilitate learning in safe and low stress conditions. They allow for standardization, completeness and personalization of training, and they also allow objectively to assess performance. So these should include technical as well as non-technical skills, and that way the whole training may be completed. So just a few characteristics of an ideal simulator. Fidelity is its ability to replicate reality. Replicability is its ability to replicate or repeat the same setting, which allows for a standardization of a task and the possibility of measuring and quantifying progress. Cost is important because it may be expensive, especially virtual reality simulators, and wet labs are also considered as high cost. Portability refers to its ability to be transported or transferred between different systems or platforms without affecting its performance. So in uro-oncology, we have a number of simulators and simulation trainings available, right from a basic digital rectal exam, where you can learn it on a simulator, and up to much more complex things. So TURBT is one thing which has a lot of difficulty in learning. So there are both low fidelity and high fidelity simulators available for TURBT as well. So these are the classifications. We have real simulators or physical ones, which may be wet, dry, synthetic, cadaver, or fully immersive, and the virtual simulators, which may be computer assisted or augmented reality. Dry labs are basically covered boxes, such as the pelvic trainer, which develop hand-eye coordination and allow the surgeon to gain familiarity with a specific field. It develops skills such as ambidexterity, pattern cutting, positioning, suturing, and knot tying. Wet labs are utilized to create a more authentic environment because you get a feedback from the tissue and understand its response to instruments and diathermy, and also the tactile feedback which may be required in the OT. But it's difficult to organize, costly, and the ethics of using animals are now under scrutiny. So that's why there are a new wave of synthetic organ models which use physical models made from artificial material like sponges, tubes, 3D printed material, and tissue-based models. They may lack anatomic precision, but they do provide some haptic feedback, and the color accuracy and lack of electrocautery basically functionality, and they may not be able to simulate bleeding, though there are some models which also show bleeding. A 3D printed model, I know Dr. Raghavan sir has a great talk on this, allows for the production of personalized models representing a patient's anatomy or medical condition, which allows preoperative planning and optimization of the approach. So that's one example of a 3D printed model. Injection casting is the best method to simulate tissue texture, and that closely resembles human organs. It involves 3D printing to replicate the specific morphology of the organs. And this is coming closer to what you would get in a classic wet lab. So just an example of a testicular self-examination model where you teach the patient based on such a print. The most commonly used ones nowadays, especially for the robotic training, are the virtual reality simulators. These enable the trainee to interact with a real-time computer-generated reality, and it enhances their skills by repeating tasks in a controlled setting. It has a high cost, requires maintenance, and has poor or no haptic feedback. And augmented reality superimposes the digital information onto the real world. It has enhanced visualization, interactive learning, and it is more cost effective because of the elimination of some of the hardware that a purely virtual reality simulator needs. So the robotic surgery simulators that we have, the most common is the Da Vinci. I have spent about 80 hours on this in the first year of my fellowship, and it features 30 exercises with 9 robotic skills. Performance is graded based on the feedback, and deductions are made, and you may track and record your progress, and the supervisor may also monitor your results. There are other standalone systems. The Hugo itself has a new console which has been shown to be effective in improving surgical skills, and they offer the opportunity for unlimited repetitive training, but they do come with a hefty price tag. So training in robotic surgery using these simulators has actually been published, and there is a EAU ERAS training module which involves preclinical simulation training, and then only you step onto the patient and repeat the same steps. So my main, next part of the talk will just focus on, does all this actually work? Do we have any data to show that simulating in the non-real environment works in practice? So just going back to that, prostate biopsy, there was an RCT which showed that the training transfers well into clinical practice. A great study from Denmark where a national simulation program training for TURBT significantly improved the clinical performance outcomes, published just 2 years ago. We know that procedure-specific warm-ups improve perioperative outcomes in laparoscopy and robotics. There is one study showing improvement of laparoscopic partial nephrectomy outcomes among residents who were trained by simulators versus those who weren't. This was a nice study where a novice who repeated the exercise 20 times compared to an expert MIS surgeon, they were outperformed by the novices. So the simulators were that good that you could actually beat an expert surgeon. This is one in real-time practice where the MIMIC simulator, the needle driving scores were assessed, and they were shown that it had significant correlations between the virtual reality and live surgery, especially among trainees, and they were associated with continence recovery. So there is even a potential for improving clinical outcomes. And this another study which showed that using this ring and rail 2 and suture sponge, these skills could be transferred from the simulator to the OR. And finally, we have a randomized study underway. Dr. Prokar Das Gupta will be heading this, which will study whether these outcomes can be translated. So across multiple studies, we have seen that simulation-based training works, and the use of AI and augmented reality in the future to improve the algorithms as well as the provide feedback will help. So thanks. I think that would conclude the talk.
Thank you, Dr. Ramani. And I think we can
opportunity. So after a lot of discussion on we already heard an HIFU talk of the local failure. Let's talk about the post-radiation local failures. So this is a concern. The incidence is varying across literature because many a times it's not purely the local failure, counting even the metastatic or the nodal disease. In the modern RT series, it's close to 10 to 15%. We still rely on the good old Phoenix criteria to define it. Maybe the incidences will vary with more incorporation of PET. To do a biopsy proven local failure is debatable. The AUA guidelines are in favor, but the recent master meta-analysis is not purely a requirement. We know the options: surgical, non-RT ablative like cryo or HIFU we already heard about, or ablative RT by brachy or SBRT. So what are the controversies while treating for local treatment? In this, these are radio recurrent diseases. One, the natural history is variable. There are no definite guideline as we have for salvage radiations. One radical prostatectomy is done. It is not biomarker driven. Many a times these are not true local failure. There is always a metastatic disease component, or it is in line to occur. The biopsy itself to prove is also debatable. There are some options like doing ADT alone because patient is treated heavily, but that's never been curative. And that's also a reason of less utilization of local salvage options. So can we predict before going of the recurrences when the patients are treated primarily by radiation? Yes, it is most of the times from the pattern of recurrence studies. It is local or the pelvic nodal, and there are factors to it. As the RT has moved on to SBRT in many cases for curative intent, can we predict the failures in that? Yes, we can. There's a dose-dependent prediction. There's a site-dependent prediction, and depending on few other clinical factors where they will fail, maybe this can give an estimate to it. Now, there's a whole lot of evaluation for recurrent disease after the radiation therapy, both patient-centric, the diagnostic-centric, as well as biopsy-dependent, and two very good stratified scoring criteria from European Urology Association and from the ZoomText criteria, taking into the PSA previous treatment and the doubling time and the treatment-free interval into account. Now let's look the surgical few lines of the post-radiation radical prostatectomy. This is an option. This is the newer systematic review and meta-analysis. They have targeted and analyzed the oncological as well as functional outcomes by incorporating the robotics as well. The biopsy is required before the salvage radical prostatectomy. Post 2010, in the analysis, there are more usage of labs and robotics. The timing of salvage radical prostatectomy do matter after the primary RT. There is a statistical difference to that. The PT2 coming post SRP is close to 35 to 70%, and the 5-year biochemical recurrence-free survival is varying between 35 to 80%, even overall survival around 64 to 95%. But the concerns remain the functional outcome related to urinary and sexual features. Are there a favorable group? I've heard this in one of the lecture before. Yes, a longer life expectancy with lower preoperative PSA, lower Gleason score, lower post-prostatectomy staging and node negative, maybe there's a role of that. Now, coming to the radiation, there's a systematic review meta-analysis I've highlighted first for brachy. Since the surgical prostatectomy has a lot of urinary and other toxicities, then why not a focused radiation like brachy? So this systematic review had 39 studies with 28 for brachy, equal distribution of low dose rate and high dose rate, with a median follow-up of 47.5 months, the median 2 and 5 years biochemical recurrence-free survivals. For low dose and high dose, it is similar to the tune of 70 to 50% between 2 to 5 years. What about the toxicities? The grade 3 or more, around 7.4 to 2% between LDR and HDR. The late toxicity is around 13.6%. And the GI acute and late are quite low, in HDR almost negligible. And the good part of this systematic review is 30% of them used also patient-reported outcomes, mostly by IPSS. Well, for a salvage, brachy is still not proven to be effective. For the recent JEC-ISTRO-ACROP prostate brachy guideline-wise, there are concerns related to selection, focal or whole gland, or even the dose schedule. The late GU toxicity is close to 30%. Although there's a good salvage LDR brachy data from the RTOG 0526, but the recent master meta-analysis has not shown much difference across the modalities in terms of 5 years RFS. And their recommendation still stands at grade C level 4. What about doing a very focused high dose SBRT, which is akin to brachy? This is one of the initial report from Fuller. Because we resort to SBRT, because doing a re-RT by conventional, we already know from Thomas Dilly's paper, is detrimental, in fact, because of the large volume and treatment-related side effects. When we move on to some long-term outcomes, and the outcomes are quite encouraging for after the primary radiation recurrence of doing SBRT, there are certain features like to select for radical prostatectomy, and which would also determine the failure pattern after the retreatment. Then this recent systematic review and meta-analysis across 400 patients with median follow-up more than 2 years, 92% have used prostate SBRT. Minded, this is after the primary RT. 52% had partial gland, 30% also have used ADT with a good amount of local control and biochemical recurrence-free survival, and very, very, very low lead GU and GI toxicities. Now, the Italian group has long been utilizing the retreatment, their biochemical failures at 2 and 4 years at 23 and 35%, with low morbidities and quite favorable toxicity outcome. They have given some hints also from their study. The GU toxicity remains most important, with dosimetric hints toward the Dmax of urethra and the volumes, which is akin to the LDR brachy data. And there is no correlation between the primary RT dosimetric features and re-RT toxicity outcome. This led to the master meta-analysis, which kind of analyze a local salvage therapy options of the surgical, the non-surgical ablative, also the radiation related. And in 2 years recurrence-free survival for the radical prostatectomy, it's around 72%. It is actually similar across the modalities. In 5 years, the HIFU is a bit lower, other modalities between 50 to 60%, but the concern remains severe GU toxicity, which is around 20% with HIFU and radical prostatectomy, whereas up to 4.2 to 8% with re-radiation either by SBRT or brachy, and GI toxicity remain low across modalities. So this led to the ISTRO-ACROP Delphi consensus on the salvage stereotactic radiotherapy for intraprostatic relapse. It has 3 sections related to questionnaires, related to patient selection, imaging, and dosimetric parameters. Their overall consensus is around 35%. Age, previous ADT is not a criteria to select, not even previous grade 3 plus toxicity, although 44% would refrain from doing in this Delphi consensus. The choline PET and PSMA remains paramount to diagnose that. Phoenix definition is still valid. The role of ADT remains questionable will salvage SBRT, and CTV choice between whole gland or partial would not change to the survival outcome, but definitely would be less toxic in terms of partial prostate RT. Now, few technical details while doing salvage HRT, we know the imaging, we know the target volume, what to select. There's a certain dose which is required from this data and certain dose constraint. And this slide is the data from Professor Barbara. She is the leading author for this ISTRO-ACROP. There are trial and data going on related to that. JTFU31 on a very pragmatic manner of analyzing the dose limiting toxicity as well the efficacy and outcomes so as the German group, which they recently published their dosimetric and OAR constraint data. Maybe we can improve by these endorectal balloons, urethra sparing, gel or tissue spaces, and maybe proton in select cases for these salvage SBRTs. So I'll end. This is a slide and points I written to Professor Barbara. She happened to my online mentor for an European GU radiation oncology course for a year. So these are her points that what they do in IO Milan, they have huge, largest series of data of re-RT by SBRT. They always do a joint clinic discussion. 15% of their prostate SBRT workload is re-RT by SBRT salvage. They follow the Eastro Delphi consensus and document toxicities religiously. Thank you.
Thank you, Dr. Bose. And I think with that, we close this session.
Yeah,
of
thank
Dr.
you.
Sanjay.
So we'll go into the industry-sponsored session, but they are quite relevant talks. We'll just reverse the sequence of them. I'm going to request Dr. Aditya Murali to talk about evolving landscape in hormonal management of prostate cancer.
Next section. You need to get the slides for the next session, please. So before we get the slides in order, I'd like to thank the Society of Gynecological Oncologists and AstraZeneca for having me here. It's always a great learning experience to be talking at a podium wherein we've got a multidisciplinary team together, and it's a fantastic opportunity. Also, we will be talking about a molecule which the data for which, just like wine, has aged quite well over the past few years. So many people still think, is it relevant? Should we be talking about goserelin in today's day and age? But yes, there are certain areas wherein goserelin has still stood the test of time, and if I can say, is still the gold standard. So this is the brief outline of my talk. Having said that, I would like to concentrate on a few areas. Area number one would be, what is the cardiovascular evidence? Because that is something that we are seeing more and more, whether one type of molecule is better than the second one. That's one. Second is, where has the evidence taken us after all the 10-year, 5-year, 15-year updates with all of these molecules? So I think we all know the burden of prostate cancer in India. Globocon 2020 has gotten some data, but this is still a huge understatement. As per the 2022 data, about 40,000 new prostate cancers were diagnosed in India, with about roughly about 18,000 deaths due to prostate cancer. I'm sure the real world numbers will be more. When we talk about the journey for prostate cancer, I think predominantly we will see prostate cancers in two settings. It's either in the locally advanced setting or in the hormone naive setting. For both of these settings, goserelin or hormonal therapy, for that matter, is basically one of the most important treatment backbones. I think on Monday morning, when we reach the clinic, the most important question which our patients will ask who have got prostate cancer is, what is the 5-year survival rate? And if we are able to quote these fantastic numbers, I think that's a great message of hope that we can give for everybody. We all know how the hormonal pathway works. I'm not going to spend too much time on this. Essentially, there are two class of molecules. There is a LHRH agonist and there is a LHRH antagonist. The agonists include leuprolide, goserelin, triptorelin. LHRH antagonist is the degarelix. I think I will skip through this, but the important thing to note is that with goserelin, it's a subcutaneous injection, and it's by a 16 gauge or 14 gauge needle. I think the commonest dosage that we use, the 10.8 milligrams 3 monthly with a 14 gauge needle, not very painful, and it's a single step delivery system. However, when we look at the LHRH agonist, so with degarelix, the issue is that if you have tried to mix it, if you have tried to deliver it, it's a very oily solution, and it has to be given IM. It's to be given SC. So the problem is that it is very painful. The second bit is that, it has to be given monthly, which means that much more hospital visits for the patient, which is never good in these days. And most patients, with prostate cancer do have other comorbidities. They might not want to visit the hospital so soon. So these are the small differentiators between the agonist and the antagonist, and why A can be picked over B. Having said that, both of them are equal standards of care, goserelin 10.8 or degarelix 240 mg. But so in terms of patients who've got hepatic impairment, there is no dose adjustment needed for any of these. And this is one point where I'll spend some time. This is looking at the cardiovascular safety data. So we know that the prostate cancer is a disease of the elderly, and most patients at that age will come with the whole gamut of all the inherited disorders that we have: hypertriglyceridemias, hypertension, insulin resistance. So all of them will be there for most of our patients with prostate cancer, all of which predispose them to a cardiovascular high risk. So there is evidence which suggests that both goserelin and degarelix have a similar acute and a long-term safety profile. And the most common adverse events associated with goserelin are caused by a decrease in the testosterone levels, while the injection site reactions, which is something which a patient finds it a little more tough to digest, is more commonly seen with degarelix. So this is some data which was published in 2020. This is the PRONOUNCE trial, which had a very unique endpoint. This looked at the cardiovascular safety of degarelix versus leuprolide in patients in prostate cancer. The primary outcome of this was the time to the first adjudicated major adverse cardiovascular event, or MACE as they call this, through the first 12 months. And the results from this study showed that there was no difference in the adverse cardiovascular events at the 1 year mark, be it the big GnRH agonist or the antagonist. So that was one bit. Let's talk about some more real world data. This coming out of the NHS, Dr. George's group. And again, in this, this is the first international observational study to directly compare the risk of 6 cardiovascular disease outcomes between the agonist and antagonist, and patients across Europe were followed up for this. The important thing was the mean age across the patients in the study was about 75 years, which kind of mirrors our own practice. In fact, our patients might be a little younger than that also. So very old patients were actually taken in this, and there was no difference in the risk of any cardiovascular disease for men, be it on the GnRH agonist or on the antagonist. And this includes not just acute myocardial infarctions, it includes angina, it includes heart failure, it includes arrhythmias also. Again, another French health insurance data looked at patients between 2010 and 2013. This was published in JNCCN in 2022. 5 types of events were assessed, and in terms of the results, about 70% of the patients received. So across the world, still the GnRH agonists are going to be more popularly used, and even in them, there was no meaningful differences between the agonist and the antagonist in terms of the cardiovascular risk. There is some data to suggest that if we shift from antagonist to goserelin, but this is just one study and would not want to place too much of emphasis on that. But the important thing, that in interest of time, I'm skipping a few slides. The important thing to note that for our patients is that there is a new hormonal therapy which has been available for the past 6-8 months. This is a once a day pill for our patients, and some of us have tried this molecule, some of us have not. There are reasons, yes or no, to say. Most patients will say, okay, a pill a day is better than getting poked in the hospital. But then again, this may not yet be standard of care. There are reasons why relugolix is not yet standard of care, and that is because the primary endpoint of the trial was not a patient oriented endpoint. The endpoint of the trial was just the hormone control, the level of testosterone suppression that we could achieve. And we still don't know whether that is a good enough endpoint to say that a particular molecule works as a primary treatment modality for prostate cancer. The second bit was, if we are trying to combine hormonal therapy with chemotherapy, be it in the locally advanced or in the metastatic setting, they were not a part of the study. So patients were excluded from the trial if they're expected to undergo chemotherapy at any point of time. So I think the newer molecule that we have, which is relugolix, may not have enough data for us to already start using this. I mean, it's not wrong. There is some data, but still it needs to stand the test of time. So these are the criticisms about the Religulix. There is some, what NCCN says in this setting is that the oral antagonist has not been adequately studied in combination with potent androgen receptor inhibitors, and data are limited on long-term compliance of oral antagonists. And I think, this is something that we need to explain to our patients, that just because they are on a pill a day, what if they forget? I mean, with old age, there is a big problem in terms of compliance to treatment also. So one injection in 3 months probably is the best chance of getting a compliance as compared to oral pills. There are certain other advantages of GnRH agonists or antagonists, may not be too much in terms of the disease outcome as such, but more in terms of the patient ease of administration. I think the last 1 minute I will take on the data that Goselin has, and this is what I said when I said the data has stood the test of time for us across all three settings, be it in the localized setting, be it in locally advanced setting. We know that there is data for leuprolide, with data for degarelix in the metastatic setting. But when we talk about the localized setting and the locally advanced setting, there is a 40% improvement in the 10-year overall survival versus radiation alone. There's a 46% reduction in the risk of progression over 10 years when we talk about the locally advanced prostate cancer settings. These are the trials. In the interest of time, I'll not go into those trials. But if you look at it, large clinical trials with extensive follow-up demonstrate the clinical efficacy of goserelin across localized prostate cancer and locally advanced prostate cancer. Metastatic cancer, anyways, we know that there is plenty of data with all of the other molecules. I think time is... Yeah. So in terms of the long-term outcomes, goserelin has been effectively used for more than 3 decades alone or in combination with other therapies. It's well-established safety profile, especially when we talk about the localized and the locally advanced setting. This probably is the one molecule which has got the longest data, both in terms of efficacy and safety. And at least in my own clinical practice, if there is a space for such a old molecule, it is still in the localized and locally advanced setting. Thanks for a patient listening. I'm happy to take questions.
Thank you very much. Why do you think there is that difference that we are noting in the cardiovascular toxicity in some trials, and there is no difference at all in either what is happening in the societal usage? Why is there that much of, because there's a 50% difference in both the trial, the HERO trial and the initial degarelix trial?
So there is a tremendous heterogeneity of the patients that we take. So the trial looked at one particular set of patients, but in the real world, when we look at our patients, at least just about the Indian data. So I think I didn't present that data, but I had one of the slides which looked at Indian data by Dr. Ankur Bell and Dr. Senthil Rajappa. They also published, when they looked at patients walking into the clinic with our set of risk factors like hypertriglyceridemia, hypertension, essentially there was no difference. So it is tough. So the point I'm trying to make is that we probably are not right if we extrapolate Caucasian cardiovascular safety data into our own safety data, sir.
I thought the difference would be more. The reason is, if you look at any of the trial data, the comorbidity was only 27%. There is a German community study wherein they looked at 60-year-old prostate cancer. What is the overall incidence of hypertension, diabetes, or coronary vascular? 27%. In India, it's 70 to 80%. So if there is anything, I expected the difference would be more, but not what we are saying.
So in terms of, so we still don't know whether there is a direct causality between the agonist and the cardiovascular problem.
Thank you. Thank you very much. We'll move on to the next one, going on to the other side, just a bit higher than the prostate, bladder cancer and the magic drug, which is the EV. Electric vehicles, huh? Probably more expensive than all the EVs combined. But this, I think, will be the game changer when it is available in India.
Can I have the slides? So the timer has started before the slides. Yeah, so this is the new kid on the block, enfortumab vedotin in relapsed refractory bladder cancer. And this has given astounding results, whether you give it in the first line, second line, or the third line. So This is an unmet need because up to 50% of patients with the metastatic urothelial cancer are unfit for first-line cisplatin-based therapy. And amongst them all, again, 50% may not respond to platinum therapy. And 70 to 80% of patients with the MUC do not respond to PD-L1 inhibitors, and 5% may survive for more than 5 years. So this is a kind of a dismal situation in metastatic urothelial cancer. And this is the drug which is indicated in those patients who have been given prior platinum-based therapy or prior immunotherapy in metastatic urothelial cancers. So word about this drug, what is enfortumab vedotin is basically a ADC, antibody drug conjugate. You have three parts in this. One is the monoclonal antibody, second is the linker, and third is the payload. So it's like a Mirage 2000, which has got the bombs which are stuck to the wings, and it is stuck with the linker. So the monoclonal antibody here is the anti-nectin-4, which is present on the cancer cell. So the antibody goes and latches on to the antigen, that is the nectin-4. Linker is the one, once this latch-on occurs, what happens is the lysosome, it invaginates the whole molecule inside, and once it is invaginated, the linker breaks the monoclonal antibody from the payload. The payload here is MMAE, and that is the one which goes and causes disruption in the topoisomerase, the isomerase molecule inside the cell. So that leads to the disruption, and finally it leads to the apoptosis. So you have the linkage, you have the antibody which goes and binds to the TA, that is tumor-associated antigen, and then it is taken inside, and then it leads to the disruption of cell. So this is the study EV301, in which it was used in previously treated advanced urothelial cancers. And this is again, this is the schema of the study. This was EV, this is 1.25 milligram per kg in a 30-minute infusion, day 1 to day 8, 28-day cycle, versus the investigator chosen chemotherapy, which could be docetaxel, paclitaxel, or vinflunin. The primary endpoint in this was the overall survival. The secondary endpoint was the progression-free survival and the quality of life indices. And these are the demographics, which are very well balanced. Suffice to say that the rest of the world was about 43%, and the Caucasians are the rest. And also another interesting thing is the history of tobacco use. So about 50% of patients were tobacco smokers, and that we know that has a direct causation and association. The other criteria which you see, you can see that the variants were about 9%, rest all were the transitional cell type. And the maximum metastatic sites were again the visceral disease, and liver mets were about 30%. So it had a good response. As you can see here, the median overall survival is 12.8 months versus 8.9 months. And this is very significant. And you see the forest plot, it is towards the EV side. And so was the progression-free survival. This is about 5.5 months versus 3.7 months. And this is the forest plot for that. So the response rates were about 41.3% versus 18.6. So it's an exact double. And mind you, this is in the second line. This is not in the first line. And there was a trend towards higher overall response rates. So you have an increased progression-free survival, overall survival, and the overall response rates. And this is the quality of life indices, which you can see, which is much better than what it was in the chemotherapy arm. So EV maintained a baseline quality of life with less variability. When I say less variability, I mean that there is a significant reduction in pain. The health status was maintained, and most symptoms, which are including pain, fatigue, dyspnea, and constipation, were reduced in these patients. Now, this is a very important slide, the treatment-related adverse events. So the most common was fatigue, followed by peripheral neuropathy, alopecia, and also maculopapular rashes and anemia. Fortunately, the grade 3 side effects were very, very less, as you can see, about 1 to 2%, as against 35 to 40% patients. And the treatment emergent adverse event, that is the TEAs, leading to death was about 2.4%. And as you can see in the chemotherapy arm also, it was there about 1% patients. And leading to dose reductions, so about 2.7% patients were the ones which had dose reductions in this group. And that, as I told you, that the adverse events which are more than grade 3, they were very, very less as compared to grade 1. And it was seen in both the arms, that is the EV arm and the chemotherapy arm. And this is the time when these adverse events come. Initially, you have the skin reactions, the infusion-related reactions, and then subsequently you have the dry eye syndrome and peripheral neuropathies and the rashes. And they occurred generally in the first few months of initiating the treatment. And these are the key outcomes which I have shown you, the OS, PFS, and the response rates and the QOL indices. To summarize, this is an effective treatment. It has a high ORR rate and 2.2 times higher rate of complete or partial response in patients as compared to the other chemotherapy drugs. So when you have a clinical trial, you have a real world evidence to support the decision making. And you have a plethora of trials. One is the UNITE registry, which was collaboration across 16 US institutions. And they also showed that there was a OS benefit of 14.4 months. This was higher than the ones which was in the clinical trial, which was about 11.5 months. And these are the patient subsets which are very well matched. And you can see there is a variant histology. And whether you have a GFR of more than 30 or less than 30, it is almost the same. And this you can see, it is across the academic institutions, no difference in heavily pretreated patients or if the patients have mixed histology. So this was something very different. And also whether the patient has good creatinine clearance or not. And what about the North American patients? This is again another study from European base. This was presented in ASCO 24. And the PFS and OS, as you can see in the bottom, is almost the same, which was earlier. These are the studies from Germany and Switzerland, and they almost mirror what was in the UNITE study, that was the real world study. And you can see those patients who have already got chemotherapy followed by avelumab, they have an additional benefit of about 11 to 12 months, which is very unique in this situation. Another study from Japan that again shows that overall response rate was about 41%. And here it is seen that patient who had any grade peripheral neuropathy, meaning thereby if you have a side effect, you have a better response, which is what is seen in other TKIs, which we see in RCC. So real world evidence in EV, efficacy is measured by the response rate, PFS and OS, and toxicities were almost similar in most of the subpopulations. So I think I'm before time and I stop here.
Thank you very much. So currently in your overall sequencing of metastatic bladder urothelial cancer, where does this fit in? So patient presents to you with metastatic disease. Your first one is gemcitabine cisplatin, first line?
So the only handicap here is the availability of the drug, which I think it is going to come.
Yes.
Second is the cost, but if you keep them aside,
Yes.
then my choice would be to give EV plus IO, that is pembrolizumab.
That's your first line.
Because the single first line gives you about 31 months. On the other hand, if you use chemotherapy and then you follow up with maintenance avelumab, you get around 25 months. Third hand, if you give chemotherapy, maintenance avelumab, and then you give second line EV, which I've just discussed, you get additional 10 months benefit. So you go to about 40 months. Fourth line, if you give chemo and then you give avelumab maintenance, followed by single agent EV and followed by a third line that is sacituzumab govitecan, you can go to 50 months.
Okay.
So over here, Vinit.
Yeah.
So if availability is not an issue, if the cost is not an issue, the patient was treated with cisplatin gemcitabine followed by avelumab. and patient is also carrying FGFR mutation. So out of three, which will be the next line, EV, SG, or erdafitinib?
I think I would go for EV because you don't have the problem of markers, you don't have the problem, and you have a good data in which you're getting OS of about 14 months, whereas with FGFR, you would get about 8 to 9 months.
And,
Okay.
and
And
you
the
have
other thing which I wanted to make out was that if you just keep on doing mathematical tabulation, that you give the patient chemotherapy and then you put in on maintenance avelumab, and then you put on EV. The problem here is, which nobody addresses, is that first line you have 100% patients. Unfortunately, second line, it is just about 35 to 40% patients. Nobody takes cognizance of that. You just keep on having a mathematical treatment highway. So you are focusing on those 40% patients which are left in second line, and then you say that you add up, you get almost the similar amount of OS which you get with EV plus Pembro. And all of us know that first line is the best line. Next line, you never know how the general condition or performance status or the metastatic disease status might be there.
So currently there seems to be a synergistic function between the EV and IO.
Yes.
And EV and chemo?
EV and chemo, well, you have a trial in which, you had 3 trials earlier in which you had combination of chemotherapy plus IO. All 3 trials failed.
Okay.
Now you have 1 trial in which you have gemcitabine plus cisplatin and nivolumab. But the difference, survival difference is about 3.5 months. That is one. Second is, this was a post hoc analysis of the actual study. The actual study never included this. So this was taken as an afterthought.
Okay.
And the basic primary outcome, that was never taken into cognizance. That was a negative outcome. So this was an afterthought, and this was the first study after 3 failures. After tweaking the patients and the data, you found that you had 3 months benefit with Nivo.
So you think if EV was available for all metastatic, you would go with EV plus IO as your first line?
That, and I would choose my patients very, very properly, looking deeply into the comorbid status, deeply looking into the performance status, and of course, the finances.
Thank you very much.
Thank you.
For a whole day session, we are only 2 minutes late, which I think is quite a good achievement. So we'll go on to the panel discussion. I'm going to request Dr. Kulkarni and Dr. Bastap Ghosh for the Kulkarni, sir. You agreed and you are refusing to be the chair. Dr. Bastap Ghosh, and I'm going to request Dr. Ganesh Bakshi, and I would request you to invite your panel because you keep changing your panel all the time.
So good evening. We are 2 sessions to end the day. This is a panel on management of CN1 bladder cancer. Dr. Bhalchandra Kashyapi, Dr. Mangesh Patil, Dr. Ashwin Tamankar, Dr. Haresh, Dr. Deepak Dapkara, and Dr. Amit Joshi. So we have 2 surgeons, Dr. Kashyapi sir and Dr. Ashwin. We have 2 radiation oncologists, Dr. Mangesh and Dr. Haresh, and we have 2 medical oncologists, Dr. Deepak and Dr. Amit. Okay. So, and we have chairperson, Dr. Jagdish Kulkarni sir, who is sitting in the center. I think our time has started, so let us go ahead. The topic is very focused actually. Sanjay has given CN1, so it's slight difficult topic to make a panel out of that. But just to start with, Kashyapi sir, let me ask you, survival in MIBC, I mean, N plus. So generally we see these three scenarios.
Yeah. Any nodal disease drops down the survivals by 20 to 30% depending on N1 or N2, N3 again. N2, N3, much significant drop. So nodal disease, without nodal disease, muscle invasive bladder cancer survivals are in the range of 70%, 80%. Nodal disease drops down 45 to 55%.
So any nodal disease, roughly as sir said, 30-35% is what we come to down. And we are talking about post-MIBC patients. So Ashwin, what is you think best method of staging your disease? I mean, I'm not asking for any evidence. Okay, we should discuss it. Many people are here.
Yeah, a standard CT scan of the abdomen and the chest.
Okay. Amit, you are happy with that?
Yeah, I think in the current era, the only thing is that which size to be taken. So, what size you will take it as a positive or not. So, the 8 mm short axis,
So I
10
think
mm.
short axis diameter in the pelvis 8 millimeter. If it is
Yeah,
above than 10 millimeter, that is the then standard definition.
Yeah.
We all accept that.
Yes.
So for lymph node dissection, Ashwin, again, we are talking about CT right now. Morning we had a talk with Sanjay Sureka about FDG PET CT. I mean, last 5 patients of MIBC, have you done a FDG PET CT or?
CT, normal CT.
CT. So CT chest, CT abdomen pelvis we already have. So do we also look at alkaline phosphatase level or we leave that aside?
We generally look into it, but I don't think a lot of bone metastasis we actually see.
With bladder cancer.
Yeah.
Deepak, you agree with that? Okay, so this is actually what is CN plus and we are at a single lymph node in the true pelvis. So just to make it from the beginning, neoadjuvant chemotherapy in PT2 post URBT CN0. So Ashwin, what do you say?
So ideally for neoadjuvant chemo,
It's purposely written PT2 here, not 3. C3,
so
CT3.
ideally for neoadjuvant chemo, but I'll have a round of discussion. If I feel the patient is going to be defaulter, then I will probably operate as well. But ideally for neoadjuvant chemo.
So much literature says that around anything from 48 to 54% world over is referred for neoadjuvant chemotherapy. The rest don't reach.
Yeah.
So if we ask Deepak, what do you say? Don't go by the words which I have put. I have just put it.
For N2, for T2 disease, NSCT is
PT2, same,
Yes.
CN0.
neoadjuvant chemotherapy.
Neoadjuvant chemotherapy. So he wants 100% neoadjuvant chemotherapy. So these are usually the commonest reasons not to receive NAC: patient preference, surgeon decision, 1/3, and many times renal functions which are affected in the bladder cancers. So is there any risk stratified approach to NAC utilization? Amit, in your daily practice, do you apply anything? Surgeon side, many times we say if the patient is bleeding, patient is passing clots, we can't optimize with that, then we would go for upfront, maybe. But what is your thought on the risk? We don't have a proper approach otherwise.
So as such, the platin fitness workup that would be mostly the cisplatin fitness workup. So creatine clearance, the neuropathy, the NYHA.
So that goes to cisplatin eligibility in
Yes, so patients who are unfit for cisplatin, generally we don't consider them giving carboplatin in a neoadjuvant setting. We are prefer to go for upfront surgery and then whatever adjuvant as per the histopathology.
Okay. So this is one data which I had found, but is many times applicable to CN0 again, because CN0, N1 is a very nearby thing. Their high risk population criteria was slightly different: tumor associated hydronephrosis, clinical stage T3B, 4A, and variant histology. What was seen was in high risk, when neoadjuvant was not used, obviously the outcomes are bad. When in high risk NAC is used, a lot of conversion happens from, they get reclassified later on before surgery into lower risk criteria. So technically, how would you say, Deepak, what benefits you can give a patient if you are giving neoadjuvant chemotherapy?
Overall survival advantage of about
5%, which we
6%.
get in the... Ashwin, you want to say something?
It has jumped to 8%, I guess, overall in the meta-analysis. Yeah.
Okay. So Ashwin, the last sentence, you believe that surgeons would say, "Nahi, I don't want to give chemotherapy. It will delay my surgery, or some patients get out of my hand for surgery."
Definitely not. But delay in the chemotherapy, rarely we have seen situations where cisplatin has given a lot of toxicity and patient defaults with the subsequent therapy completely. That's the only worry in the mind, occasionally. But otherwise, no.
So that will be under the monitoring of a good medical oncologist.
The only problem comes with the patients who presents with a hydronephrosis.
Hmm.
So in this, to optimize those patients, otherwise patient is fit. Only thing is that the hydronephrosis, T3 tumor, N0, ideally fit for chemotherapy. But because of the creatinine, we have done a PCN and then waiting for the creatinine to come down. Meanwhile, he develops an infection. So that is sometimes a tricky situation in day-to setting, dealing with that scenario. I think others can also comment that that is the situation. Our threshold for if the patient doesn't improve or creatinine, then we should not wait too much for making them fit for chemotherapy, and by the time the disease progresses.
So would you advise this patient go ahead with surgery?
I think
Upfront.
over period of time, I have realized that it's best to send them early rather than waiting and getting an infection, a PCN related infection, and then everything gets.
Kashyapi sir, you see de novo such a patient and you think that not much advantage will happen. You will refer him to a medical oncologist or directly do surgery?
Bilateral hydronephrosis, bulky disease, not in obvious renal failure or toxicity, not in fluid overload. I would prefer an early surgery if he's otherwise fit.
Okay.
Because it's difficult to manage bilateral PCNs.
And it would take time, probably. Disease might spread, a lot of things might happen. Amit, these are whatever I was reading in the past few days for CN1, neoadjuvant downsizing, induction chemotherapy. I had never heard so much of them. We always used to say neoadjuvant. Why people have so many terminologies?
So the issue is that if you look deep into the neoadjuvant chemotherapy trial, mostly N1 patient were not taken. So mostly it will be T2 to T4 N0.
That's
only the D. So that is the reason the downsizing term, that in those patients who are a very good responder, then you can select them. So that is the reason I think probably they must have.
Universally, these terms are very intermixed. If you see NCCN guidelines, it clearly says downsizing.
So I think that's more applicable for a N plus disease rather than T3, T2 to T4 disease.
Okay. Ashwin, last question is to you, actually.
So only if he has active hematuria, which is very difficult to control. That's the only situation. Otherwise,
the other situation we just discussed.
Hydronephrosis, yeah, and cisplatin ineligibility because of any other reason.
Cisplatin ineligibility. Okay. So these are some quick questions, actually. Deepak, what would you say about this? We all sitting here and in the hall know which is good, what is good. So what would you say? Some quick lines.
All use gemcitabine cisplatin.
Whatever you want to say. These all three are good in bladder.
Gemcitabine cisplatin.
Okay.
I think with the changing the era, I think in a fit patient, DDMVAC is going to be the so in a otherwise fit patient, good creatinine clearance. What's the problem giving them? Only thing is that what I personally say is that before giving at least few cycles, I admit the patient, because that is the toxic. If patient is otherwise fit, I will prefer DDMVAC over Gemcis.
So I think there is data which has been published about patient compliance, which is more with GC, probably because of the side effect profile. But as you said, I mean, this is always a question, why DDMVAC is not used.
So you have to select the patient for DDMVAC for a 60 year with a 2 or 3 comorbidities, that he is not a right candidate. But for a otherwise 50-year fit patient, what's the problem? Only thing is that I feel that these patients should be admitted for few cycles, keep a close watch on their toxicity that is manageable.
But if tomorrow you have fit patients with good ECOG, it's manageable.
Yes,
with
yes.
a good team with you.
I think
so. As we see,
the others can suggest. I have started using DDMVAC more due course of time.
Okay. So downstaging in CN plus is also better, apparently.
Yes.
Please, you can.
Ganesh,
please.
Just a comment. What Dr. Amit said. There is a learning curve with every protocol.
Absolutely.
And after you get sufficiently adept with that protocol, you can go ahead. And Vesper has showed that DDMVAC is definitely better if the PS and GC of the patient is good.
Absolutely. So we take these comments, very good comments. And as you see, DDM-VAC is quite favorable with all-cause mortality as well as downstaging. So coming back to what Amit had said few minutes back.
Can I just ask one question? We
Please,
are
please.
going down the line of neoadjuvant chemotherapy for a 60-year-old who has got MIBC. If they ask you 3 questions in that, what is the probability that I might progress on this neoadjuvant chemotherapy? Then the second, what is the overall response rate of neoadjuvant chemotherapy? And then the third is for a T2, what is the overall T0, pathological T0 without chemotherapy and with chemotherapy?
So
These
for
are
a
the
T2,
normal numbers we have to give it.
so for a T2, the benefit definitely, if it is T3, T4, the benefit is more. So for a T2 N0, M0, if patient is any a factor which is not putting the patient fit for cisplatin based, I will not err on the side of giving. For in a overall scenario, I think the if you clinically watch them, and what I do that I do a scan after 2 cycle.
No,
If there
that
is a
was- Yeah, so what is the number of patients wherein you abandon chemotherapy after 2 cycles?
I think in a clinical practice, if I can recall, I think 10-15% patient may progress while on that, but not, we have to catch them before they become inoperable. So rather than waiting for 4 cycle, if there is any symptomatic progression,
So, Sanjay,
otherwise,
the follow-up questions I have.
So disease progression on NSCT is less than 5%.
5%.
So, Deepak, Amit said about cisplatin ineligibility, and we have an answer as surgeons to that, upfront cystectomy.
Yes.
But with emerging evidence, you have single agent and combination agents available today. So would you give neoadjuvant with that?
As of now, no. But immunotherapy, some trials of immunotherapy, they are coming.
Yeah, I mean, immunotherapy data is there, not that it is not there. So that is what, Amit, what do you say on this? Because whatever you both say, we'll take it. I'll
So
put
I
the
think-
data here. This is about single agent.
I think with the current evidence, I will not jump on giving the immunotherapy as a single agent in a cisplatin or if there is something because of some obvious reason, if surgery can be delayed because of any other reason, then you can use, because if you look to the pembrolizumab data, the path CR rate is close to, I think 35-40%.
What the question, Sanjay, you are asking, if you see here, YPT0N0 is 44%. These patients, if they have YPT0N0, they are going to do excellent in their cancer-related outcome. So that is what.
Yeah, but only thing is that these all data is based on the phase 2 study, which has a number less than 100. So for a phase 2, we cannot change, but because of any other reason, if we have to defer this the local treatment, definitely we can consider immunotherapy single agent in those group of the patient, but not in all.
Okay, so no combination with chemotherapy.
Yes, till the time I think there is the one trial which is due
No,
for
because
this.
I have now changed to a private hospital where I see my medical oncologist has used this combination.
No,
And
at this point of
it has
time,
been
no.
used favorably. Like, fortunately, I don't know what anyone.
No, at this point of time, there is no data which shows that chemo plus immuno as a NSCT. This Niagara trial, which is the durvalumab, that is going to get some data, and it looks like to be a positive trial. Then we might have changed.
Cisplatin eligible patient.
Cisplatin eligible patient.
Okay. So going to, we already said we'll see response after 2 cycles of.
I generally do personally feel because you can catch up the early.
So my question
And if
relates
it
to
is
same
dose and MVAC, then 3 cycles.
Those is MVAC.
response assessment.
DDMVAC 3 cycles,
yeah.
GC will be 2 cycles.
And how? Again, CT, PET CT?
CT scan.
CT scan.
No, let's say that if somebody had a PET CT at the outset, do you repeat? So the baseline investigation.
If the initial assessment
is
was
what we
PET
repeat.
CT, would you repeat a PET CT or a CT? That is the question.
I don't think so. That PET CT, if done, if you have incorporated the CCT as a component, you can take the information for the. If only PET CT was done without contrast and patient there is no contraindication for giving the contrast, then we can repeat the CCT. Otherwise, by default, most of the PET CT is with the contrast. So PET CCT.
The issue would be there would be some lymphadenopathy noted on the PET CT scan, not that much commented on the CT scan. Then now you just repeat a CT scan. You don't know what happened.
It's a technical problem. I agree with you. given personal choice, even I may want to
Sanjay,
get.
But if we even casually talk, we see a lot of people doing PET CTs only.
Yeah, that's the reason I'm saying.
We are,
real life,
we are staunchly holding the CT domain here, but within all honest purposes, everybody is using
The problem of PET CT is sometimes instead of solving, it's a troubling problem. Like you get a node in the mediastinum, maybe you don't know what to do with that node. Then you are so primary treatment will be dead, and everyone will be focused on the mediastinal lymph node, which is 1 centimeter where SU of 4. Nobody knows what to do with that node.
I'll do the other way around. If the primary analysis was done based on a CT scan, you would just repeat the CT scan. But if it was done based on a PET CT scan,
then you may.
preferably a PET.
You may.
Yeah, that's what.
Probably overall doing a PET CT is better, I think. No evidence, no evidence.
No evidence.
So I would like to ask my radiation oncologist friend Mangesh. This patient does not want surgery. Upfront CN plus say PT2 or PT3A, but CN1. Bladder preservation.
After chemo?
No.
That you will have to tell us.
So
Whatever is your choice. Bladder preservation, I know, CTRT.
So we have a data from UK group, Dr. Ananya Chaudhary and her group. So they say, the response to NSCT, if the patient has response to NSCT, that group is doing well.
Okay.
So,
So we would give neoadjuvant and then do concurrent CTRT.
Trimodality therapy.
But the only thing is that there is no randomized data which has shown that NSCT followed by CTRT versus CTRT alone is better. So it's a retrospective data we are extrapolating. Since the NSCT works well in the surgical side, it may be better, but there is no randomized trial which shows that, like in head and neck, we do directly with CTRT. We don't give them the NSCT. And we all know that NSCT doesn't help in organ preservation in head and neck. So we are extrapolating that NSCT is helping, but we don't have a level 1 evidence to suggest that.
In a way, NSCT response works well at every place. In general, it works well only. With surgery you do, with probably radiation you do. Dr. Harish, if we give, again, what about the quality of life?
Quality of life, it's acceptable. Stage-wise, this disease control also is really comparable to surgery. Even the NCCN also is category 1 recommendation in this N1 group.
Okay. So if we get a complete response, say, so we all said the prognosis is better only. Suppose if the patient shows complete response.
So, Ganesh, one point I want to make it very clear. We are talking about complete response imaging wise and not pathology.
Imaging.
Is that
Yes, sir. Everything is imaging.
Imaging wise. Okay.
Imaging wise. So I think we discussed these 2 points, that the prognosis is good, and we discussed this point also. If there is with Mangesh saying that if there is a complete response at both sides, avoiding. I just wanted to show this slide, which was published in the NCDB data 2020. Patients with more than PT2 post NAC had worse OS when compared to the otherwise more than PT2 who underwent only surgery or surgery and adjuvant. So this is one important point actually, where everything is centered upon the response to the downsizing therapy which we are giving. So coming to our surgeons, what will be your template of lymph node dissection?
So extended template with the 2 trials, of course, there is a debate about it. But what we do as a conventional extended template, I think we should continue doing that because there are limitations of these 2 trials.
Super extended?
So all these trials actually came from Dr. Skinner's fellows. So I think extended is something which is good enough.
That is what I got in this thing. Again, this one question came when I was reading a lot. What is the value of the lymph node dissection? We have intense discussions in surgical thing. Template should be down, up, here, there. But what is the value?
So all 3 values do exist, diagnostic, therapeutic, and prognostic. Because it's been discussed about templates, numbers, as well as density. All the points are correlated.
So many times they say that diagnostic and prognostic is a better value than therapeutic because
even therapeutic.
Because therapeutic, you will have a very small segment which comes in that therapeutic.
But Ganesh, I think with the availability of the adjuvant nivolumab, so after if the patient has received neoadjuvant cisplatin-based chemotherapy and the tumor is not downsized below P.
That is what I showed in the
slide.
So
if you do remove a node and the node is positive, you can consider even the YPT0 but node is positive, then you can consider them at the adjuvant nivolumab in those group of the patient.
Right.
So I think it is some sort of a indirectly with the current evidence
Also-
therapeutic value.
So number of lymph nodes also showed some correlation. If you had 1 or 2 lymph nodes, it was significantly better, and the survival just dropped down when the number of lymph nodes increases. As with this factor has not quite been discussed in most literature, but extracapsular lymph node invasion, it is one of the worst prognostic factor, they said, with respect to bladder cancer related outcome. So coming
Sorry,
back
can
to
I
you,
just,
Amit.
can I ask regarding the template one? Let's say that the lymph node was a bit outside your template. It's lower aortic or intra-aortic cable. Had a complete response with neoadjuvant chemotherapy. Now it is not being visualized on your CT scan. Would you stick to your normal extended template, or you say, I know that there was some disease there, I want to get that out?
If it
And
if it is not
there
going
is
to
a-
add much of morbidity, then we should try and take it out, or at least sample that area which was previously lighted up or was enlarged. But if it is going to be extremely up, like properly retroperitoneal, I don't think we should. Then it probably doesn't make sense in even operating that patient.
Because we know that there isn't any therapeutic effect.
It will be labeled as M1A or a metastatic disease to begin with.
Jagdish sir, do you agree with that, or?
Sorry?
Do you agree with that?
So Sanjay,
See-
non-regional lymph node will be query M1A
M1A,
also.
yes.
Yeah, correct.
Yeah.
I mean, I agree with
Okay.
this. See, extended, we did those things because that time the chemotherapy was not available. And with these drugs available now, I think we'll have to cut down on the templates. In years to go by, I mean, come by, you'll find the lymph node dissection will come to sampling only.
Okay.
This I'm seeing it.
We are actually discussing CN1, that non-regional goes to M1A. So if you have a response in M1A, you'll have to counsel and treat accordingly.
Yeah.
And drugs availability, I say that's an addition actually. So Amit, if there is no response at 2 cycles, your
Then I will-
standard mode of
Yeah.
advice is
So I will definitely go for early cystectomy in this patient.
no change in regime, nothing.
No.
Kashyapi sir, agree with surgery.
Yeah, surgery not to be done if it is not operable. Then only change of a regime. Otherwise, the surgery.
Okay. Ashwin, the first question.
Generally
no
no.
side effects
Generally
of
no. Generally no.
HSC.
We wait for about 3 weeks at least from the last cycle, maybe before operating. That's the precaution.
So Deepak, what would you commonly see in such patients as side effects? Common side effects which we
Patients
see.
who have received chemotherapy, peripheral neuropathy,
Neuropathy.
that is neutropenia, that is for short duration.
And
Do we
sometimes the
have
nutritional.
any kind of markers within your
But the other thing is that nutritionally, sometimes we have to make sure that they do not get nutritionally challenged, because the time they, and after the surgery, they further reduction. So I think making a nutritionally stable patient, keeping a watch on the albumin, following with the dietitian helps in overall manage of the patients. Otherwise, they have to go for surgery. The albumin is already on the 3 side, around 3, and then their PS deteriorates and the recovery might be an issue.
Ganesh,
Yes, sir.
I'd like to pose a very
We
common.
have time. Go.
So you asked Amit, what will you do if there is no response or poor response to chemo?
And sir said, if operable, I'll operate.
Yeah, absolutely. I agree. I just like, it's a conundrum. I will pose two sides of the issue. On one side, the response to chemo has not been great. It's
Biological
poor
bad
biology.
disease.
Poor biology. Do you really want to subject somebody to a cystectomy?
So
when
palliative
the biology is poor and the chances that this is going to metastasize are extremely high even after you do a cystectomy. It is not all 100%, but it is quite likely. On the other hand, the option of CTRT also doesn't make great sense because it is not a chemo responsive, probably not a radio responsive tumor. So how would you deal with this problem? How would you rationalize
maybe
this?
that cystectomy you can term as palliative then.
No, the response, it's a small tumor that's gone. The node has not responded. So it's a common thing that we see. No, you CTRT, no? Option is there.
But I feel that surgery will be better rather than sending them for CTRT. Even if there is no.
Better based
I
on
think
what?
we don't have an answer, but I was reading a lot of articles. We don't have any data anywhere.
So my
But we do
direct
have
question
data.
would be, do
So we have a data for surgery versus CTRT in a node positive disease. There is a data that the surgery and radiotherapy are same for are both
with
same in
respect
node
to
positive
overall
disease.
survival, I think.
Yes, or node positive
We'll
disease.
have to see overall survival, like what is the quality of life also. I think we'll have quick comments. I have 2-3 more slides.
So a couple of points. The first thing is that when do we expect the response? Is 6 weeks optimum time? The answer is possibly no. In that case, I think I will possibly continue the chemotherapy, complete 4 cycles. I think there will not be PCR, and I will carry on with nivolumab in adjuvant therapy.
Okay.
That's the point.
Vinit sir, any?
So, if I were to extrapolate in another way, this could be a primary refractory disease which is not responding to chemotherapy. So, how good would it be whether you give chemoradiotherapy or otherwise?
Yeah.
But I'll agree with Dr. Amit. We should go ahead with surgery for whatever benefit it is. One, we'll know what is the response, and two, we can, intensify the treatment.
Absolutely. And maybe it is a very morbid cancer which is symptomatic. So the SWOG 8710 trial did say that, I just wanted to put this apart from the toxicity, that there is myth about patients not reaching surgery. In SWOG 8710, 81%, 82% in both arms could easily undergo the surgery. These were the normal side effect profiles which we had discussed. They manage very well. I asked a question to Deepak about reliable biomarkers, which Amit says no. Some of the things which I found here was, which are very far genetic or genomic biomarkers predictive of pathologic complete response. And efforts are being made to identify. There is nothing concrete in our hands. So CN1, we are talking about CN1 and the role of, I just put a slide on adjuvant chemotherapy. So there is no established role. All the trials which are there in CN1, they say adjuvant is in T34 or PN plus. So let me just take the last question. So what will be the role of adjuvant chemotherapy when you have given neoadjuvant? In which patients you will consider? So if you have a response which is more than YPT2N0 or any criteria.
So I think in this scenario, if the patient has received neoadjuvant chemotherapy and even the disease has not downsized beyond, so I think there is no data to suggest that the giving chemotherapy. But
these are the patients who fare
yes,
badly.
if affordability is not a problem, adjuvant
has also asked some
adjuvant nivolumab is the choice for this patient.
Adjuvant nivolumab.
If the patient is if not affording, then we have to just wait and watch and let the disease come back. Changing chemotherapy doesn't help in this.
But adding adjuvant nivolumab might help.
Yes, if the patient has not received any chemotherapy upfront, and then even if he's not fit for cisplatin, not affording for, then we can consider giving carboplatin gemcitabine in an adjuvant setting for whatever benefit, because surgery has already been done. So in those scenarios, we can still consider adjuvant carbogem.
Okay. So I think most of the points we have touched upon. This is just a graph to show you CN1, 2, where there is CR or PR, partial response, they fare the best. Stable disease or progressive disease, they are next. And upfront cystectomy come in the third. And there is one more graph which I would like to show here. So this is with treatment, induction chemotherapy, and those who become PN0. They are the best here, uppermost graph. Radical cystectomy without induction chemo, but who come PN0. I think downstaging has happened. CN1 to PN0, they do the next best. And as we know, the node positives do bad. So I think, thank you so much.
There is also an interest in
I have ended this discussion.
Yeah, one last comment. The adjuvant chemotherapy.
Right.
I think what Dr. Amit said, that holds very important relevance. Those patients who have not done well post NAC, they are the ones who would benefit more from IO in the adjuvant setting.
Sorry. Thank you.
Hey, we are not talking about the part right now.
Yeah.
CN, yeah.
Thank you.
Because our discussion was CN1, that's why.
Thank you very much. We'll have the next panel.
Can I get down?
No, sir. You are the person, stop people from fighting across the board. Okay. This, I was planning a bit more earlier in the overall desk because palliative treatment is something that we don't tend to discuss often, but almost quite a lot of our patients do end up needing. So I'm going to request Dr. Amitabh Ray to be the moderator. And I'm requesting Dr. Joydeep Ghosh, Kushal Narang, Dr. Sujana Priya, and Dr. Arunangshu Chakrabarti. I got it right. Arunangshu Chakrabarti. Thank you.
Good evening, ladies and gentlemen. With the permission of the chair, sir, can we start? We can start. Thank you so much. Good evening, ladies and gentlemen. As rightly mentioned by sir, we're going to take up a difficult area for a discussion by a group of 4 people on stage. 3 of them are clinical oncologists. One of them is a critical care specialist who also works with palliative care, if I'm right. Yeah. So I think that more or less completes the quorum for such a difficult topic. So we have been assigned the role to discuss over the next 30 minutes palliative treatment options in uro-oncology, what works and what does not. Very interestingly worded. I'll start with a clinical situation, and this is for all 4 of you. Think of a patient with advanced urological malignancy. I'm not giving you a diagnosis. Comes to you with hematuria to your OPD. The patient has a symptom which needs to be palliated. Now, I'm going to leave out germ cell tumors here because they're going to pollute the entire topic to a very large extent, so we won't be talking about it. So the 3 main areas of concern for us, at least for this particular patient, would be prostate, urinary bladder, and renal cell carcinomas. I'll start with Dr. Arunangshu. Suppose a patient has been asked to meet you with hematuria. Would your approach be different to these 3 primary diagnoses that you can see up here?
Hello. No, I mean, first of all, with hematuria, they don't come to me because I'm in the pain clinic.
I agree.
So, yeah.
Hypothetical situation.
Yeah. So in that situation, I'll just follow that there's 3 diagnoses.
So you would look at the diagnosis before you give them a palliative therapy option. Dr. Joydeep, what would your approach be towards each of these?
So there are 2 situations where the patient comes with a upfront hematuria before visiting any doctor. Very unlikely they will come to an oncologist at that point. That will be either a local physician or a neurologist. Second situation is somebody who's already diagnosed with one of these and comes with a hematuria. So obviously the approach will be different in both the situations. If I'm knowing the diagnosis based on the subsite, I will try to involve that particular team, most likely the surgeons or the radiation oncologists. And if I don't know the diagnosis, obviously it will be the surgeon who will be evaluating the patient.
Dr. Priya, you have something to say.
Firstly, any patient with hematuria, I'll probably assess the extent of hematuria, look at the vitals because it's bleeding. That is the first approach I would take before I jump into oncological conclusion. So I'll assess the extent of hematuria, I'll check his hemoglobin. I mean, do the routine vitals ABC, and then assess if it's a prostate malignancy and if it's really bleeding. I would, and if it's already established that it's a prostate malignancy, I would probably preferably start him on antagonist, probably Degerlix. And if it's urinary bladder, my approach would be a bit different. I'll probably involve the urological surgeon in this. And I mean, me being a radiation oncologist, if the urological surgeon is not helping me out, then I'll probably offer him a palliative approach with radiotherapy. And RCC again is a different ball game. It's mostly in the surgeon's court because if it's bleeding, I don't know if radiation really helps out there. But yeah, the surgeon has to take a call for RCC.
So Dr. Kushal, I can see you picked up the mic already. So
Yeah, I mean, first of all, upfront patient presenting as hematuria, we have to find out whether it's a oncological cause or non-oncological cause. So besides the routine labs, I'd ask him to do a urine routine and a urine cytology and probably an imaging of the CT scan of the abdomen and pelvis to find out where exactly is localized the site of the lesion, if it's an oncological cause, and then proceed accordingly. So oncological cause likely, then I would prefer to get a biopsy done so that we establish a diagnosis from the relevant site and then proceed accordingly.
I think our panel beautifully brought out the conundrum that all of us face, especially when you're looking at palliation of symptoms in urological malignancy, because it's not a one size fits all, as might be true for other subsites. So with that, we'll enter into what we are going to discuss today. We all know this, just for the sake of completion. Palliative care is patient-centered, coordinated care intended to decrease suffering and improve quality of life for patients with advanced disease. And it may be offered right up front or towards the end of therapy. Now, Dr. Priya, again, which one do you prefer and why?
I'm sorry, I didn't.
So I think what I'm trying to ask is up there, because what we most of us tend to do, and that is not so much because we don't want to do it, but as we were discussing just before coming up on stage, the availability of routine palliative care services is not as wide or as accessible as we think it is. So we end up sending patients off to palliative care towards the end of their journey.
Correct.
But should that be the approach?
No, definitely not. I think a palliative, in a proper institutional setting, a palliative care physician is the first one to be involved. Along with the clinician, the palliative care physician also should be involved in the care path, where you take involved decision making. So that really helps out the patient, and you'll understand where the patient is going eventually. And that kind of a counseling is definitely needed.
Yeah, Joydeep, does that have an impact on survival? Doing
Yes.
such?
Yes, because there have been multiple studies in not just urological malignancies, but mostly in other cancers, where early initiation of palliative care has improved overall survival. Maybe because it impacts the tolerability of the drugs that would indirectly impact the survival.
Right. Dr. Arunanshu, for your as well as the audience benefit, I've just taken the example of probably the best established data in this particular regard. That's the Enable 3, where we know that initial involvement of palliative care services resulted in an improvement in overall survival, which was a significant improvement as far as this particular study goes. But the question that we all have is, what exactly is the palliative care doing here? In what way are they involved so that this kind of a result is evident?
So, first of all, palliation of pain is important. So when you block the pain, the patient emotionally also the patient thinks well, and all sort of like allied things like appetite increases, immunity also gets better. So pain palliation is number one. So many hospitals nowadays, cancer hospitals, they have this pain-free hospital initiative. So in our hospital also we are doing that. So we have like a separated, dedicated switchboard where the patient can directly approach and get a pain physician to see him or her for the symptomatic palliation, which can be before or on like parallel to the or after the primary therapy. And the intent of the primary therapy may be curative or palliative, it does not matter. But the patient has got every right of palliation of the symptoms. That is what I think is important.
Very true. I think you in your institute have actually started something which all of us should also get involved with.
Yeah.
As far as this particular trial is concerned, they had a very structured system of looking at what this was supposed to do for a patient, wherein the first initial consultation was with the palliative care physician. And then what becomes striking is the rest of it was done by nurses, and it was mostly telephonic. Such a small intervention actually made an improvement in survival evident is something which is eye-opening for all of us here, all of us on stage as well as in the audience. So I think it's a question of giving time to the patient more than anything else. If you look at the last bullet on this particular slide, it's 30 to 45 minutes per patient per session. How much time do you even spend on a clinical assessment and OPD consult? I cannot imagine that
Actually,
much.
that's very important because what happens, our patients, like pain patients who are coming to our clinic, they get so much time with us and they kind of start bonding, and they even ask their the original disease related questions, chemotherapy related questions to us, and we kind of become a conduit with the primary physician and between the primary and the patient, because they kind of depend the trust on us, because this person is continuously trying to improve the health of the patient in the from other perspectives.
True. So then that begs the question, is it time to therefore change our approach? Is it time to now look within and think about how we can change our approach to our patients and probably give them better survivals, not just better quality of life? So we need to perceive palliative care as a management option. This is important. It is not just something that you wouldn't do or something for a person who doesn't have any options left. You start from the beginning and quality of, yes, sir. Yes.
I just want to make a point.
Yes, sir.
And that is a support system. And where the support system is important, especially in urological cancers where the stoma management.
Right.
I think those guys, they are absolutely difficult for them to manage stoma, but their attendants who may be SSC,
Right.
I think they also make a lot of impact. And this is what I found on a very top guy whom I done a radical cystectomy. Ultimately, he relapsed. But his last 3 months where actually I was surprised to see the support guy
Right.
who was changing his bags and this thing, and that made him live for 3 more months, which
Very true.
I must say, this was a point. Support system, perhaps.
Absolutely, sir. Any panelist has anything to add? Because I think most of us agree on the fact that palliative care has to be an essential component. And just to add on to that, we live in a third world country, which will probably remain third world for a very long time, at least as long as we are alive. And we have to look at healthcare resources as well. The moment we start integrating palliative care into our practice, probably the pressure that we work with within the institute will reduce to some extent. So that is also another reason. Kushal, you're picking up the mic again. Yes.
Just want to say, how many of us have received the compliment from the patient, Doctor Sahab, आधी problem तो आपसे बात करके ही solve हो गई. So I think that's what.
I think all four of us can vouch for that. Most of us have actually. So yeah, that is very important. Yes, Dr. Priya, you have something to add? Okay, so I think we can now jump into a little more serious discussions where we need to define palliative care in uro-oncology. Now, I know we don't need to do that. Palliative care is a very well-established topic by itself. But the big question, we all do not have access to a hospice, I agree. But which would be the patient with urological malignancy where you would actually consider this? And I think Dr. Runangshu can take this. When would you recommend hospice versus palliative care in hospital for a patient who comes to you with a urological malignancy?
So, for example, we Tata Medical Center have got one additional wing called Premashraya, where we can house the patients who are kind of not about to be admitted in the hospital, but they still remain some level of supervised care. So you can call it a kind of hospice, not ideal hospice, but kind of hospice setup. So the thing is that most of those patients who stay there, like their treatment is on a palliative intent now. They are not in a curative intent pathway. And secondly, those patients are not very sick that they need critical care support or they need IV, etc.
So would you liaise with your treating team, the clinicians who are treating the patient before taking such a decision? I think Joydeep was with you for a very long time. Joydeep, how did you do this?
So unfortunately, palliative care used to come when we are run out of treatment options. I would be honest that very rarely in busy OPDs like medical oncology, we would think of palliative care on day one. That doesn't happen in the practical situation. Probably one of the reasons is that the oncologist to palliative care physician ratio is very, very altered in our areas. So yes, I agree with Dr. Unangshu that we have to have a very structured program, and we all systemic therapy, all people dealing with systemic therapy should bring in palliative care as soon as possible, rather than trying to.
Right. So just to add on to what has already been discussed, the international guidelines seem to recommend a predicted survival of less than 6 months would be someone who should go to the hospice. Do not subject them to treatment, even if they come to you upfront. That seems to be the consensus. I think that's something we can adopt here as well, rather than, taking a one-size-fits-all approach with whatever treatment is available. You can actually think of that. A difficult question. Sir, I know you're the chairperson here, but you're the only one who can deal with this. what is the role of palliative surgery in uro-oncology? Because this is something that all us non-surgeons are at sea at times. We need your help with this.
There are two types of surgery. One is a surgery which is ablative. Another is ablative plus reconstructive.
Right.
As far as possible, if it reconstructive is problem, I think there is no place for that. Palliative, only ablative surgery, no problem, less morbidity. That could be one.
Fair enough, sir.
Absolutely. That's
I think experience more than anything else. He summarized it in 2 lines, which probably we would have gone on and on about.
One
How
more
about
point I want to bring
Yes,
in. And recently, I was in Stuttgart, where integrated medicine were being talked about, and I was surprised to see the results of some Indian people who talked about the role of mistletoe. And well, I mean, they showed the data. I was surprised, and I was chairing that session. I never knew that mistletoe is, comes from the, the plants.
Joydeep, how excited are you about palliative systemic therapy? I know a lot of new things have happened over the last decade, but how would you then look at this situation with palliative systemic therapy across the board in uro-oncology? I know it's a very big blackboard to cover, but
So, if you look at systemic therapy, there are two aspects of looking into it. One is you're giving systemic therapy with a palliative intent. That is like treating all stage 4 cancers. The second is you're giving systemic therapy to reduce the pain. So, most of the uro-oncology patients, fortunately, a large chunk of them do not have pain as an issue. Yeah, prostate cancer does, but others don't have much pain as an issue. So but they do have large symptom burden. We have seen patients of RCC with extensive disease, large abdominal mass, mets from head to toe. We have seen bladder cancer patients with creatinine of 10. So these are the situations where we tend to give systemic therapy, but the biggest hurdle is these patients are not fit enough for systemic. So it's a double-edged sword situation where you're willing to give to palliate, but the patient is not the right candidate to give any form of treatment. That's the reason why in these patients we tend to end up only with palliative pain control rather than systemic therapy.
what about the new developments with the targeted therapies?
Yes. So that is one area that it will be exciting because we do have non-chemotherapy targeted therapy options. Like for bladder, we have enfortumab. For prostate, we have many non-chemotherapy options. RCC also is largely IO. So once we have all of our patients able to afford these therapies, I think the threshold for starting these patients on systemic therapy will come down significantly.
I think you've hit the nail on the head. It's about palliation at what cost? And the cost is not just medical, it's financial. So that would be another barrier which a third world country needs to overcome before we start talking about systemic therapy overall, or reducing our threshold for prescription. Very exciting area for the two radiation oncologists present here. Now we have SBRT. I know Vedang sir is here, big proponent of SBRT for RCC also. How often and how easily would you take up a patient with so-called palliative, approach towards a radical treatment, given the fact that you now have the equipment to do it? Dr. Priya, you can start, and then Kushal, you can carry on from there.
Again, it depends on whether we're dealing with a low volume metastatic burden or a high volume metastatic burden. Now that we are dealing with the concept in the era of oligometastatic spectrum, I believe we can probably start with systemic treatment, see how it goes, and then probably add radiation to it. So that is one way of looking at it. If we are really deep down looking at the palliative scenarios in general, so I think the first thing we have to address, if the patient comes with a symptom, address the symptom first, not the cancer. So that is what we do in our clinic regularly. If the patient comes with a back pain, assess the back pain, optimize his analgesia, and then start the systemic treatment, whatever is directed towards the cancer. So yeah, maybe that's the approach we have to take. And coming to the palliative radiotherapy scenarios, we have a lot of options to treat. Again, it depends on the performance status of the patient, his longevity index, and those kind of scenarios. If the patient is going to live long enough, like prostate cancer, it behaves more indolently. So I mean, even stage 4 cancers, they live long enough. So there you can probably go and treat them aggressively. In the same way, urinary bladder, the biology is bad. So the biology is bad, and probably the approach has to be a bit different.
Yeah, Kushal, if you finish this, then sir has a message for us. Yeah.
Okay, so just, I mean, in view of the new advanced technology, and as you mentioned, we are moving from per se palliative treatments to treating everything with a more radical intent. My approach would be to try and create the palliative situation into a more radical one by going full on and offering SBRT or high doses per fraction for most of the scenarios where earlier we would often write off the patient and
Right.
just evaluate the symptoms.
Very
So-
true. So instead of looking at everybody as palliative, we now need to choose better. And that begs the question, who should then lead the palliative team? The radiation oncologist has armory now, the medoncs have so many drugs and everything else. And so then who should be the deciding factor? I'll go to Dr. Runangshu. How would you then, decide?
So, if you are talking about a palliative care setup, obviously the palliative care physician should be the lead in that, and because he knows when to call for which service, and depending on that situation, he can call upon.
My point exactly. So it is not just enough to know how to manage pain and bleeding and obstruction anymore. We need to have our palliative care team more involved with the treatment decision making and the reason behind that. So with that, as Dr. Vedang rightly pointed out, it's time to go into specifics, and we'll start with prostate cancer because that seems to be the most controversial of all when it comes to doing only palliative care. So the first question I'll take to Dr. Kushal. Hormone sensitive prostates versus castration resistant prostates. Would you look at both differently? And if so, why?
Yeah, of course, if a patient has a hormone-sensitive prostate cancer, they would more rely on systemic therapy to bring about a response for us, and that can also double up as a palliative measure. Versus a castrate-resistant prostate cancer who has progressed despite multiple lines of therapy in the past, we'll look at that patient more as a palliative candidate.
Dr. Priya, how comfortable are you with an oligoprogressive CRPC, which is a couple of sites of progression in a known castration-resistant prostate without systemic therapy? Would you be comfortable doing only SBRT, which is one of the weapons that we have?
So let's take a scenario like this, wherein the patient has exhausted multiple lines of systemic treatment and is only progressing in one particular site, or maybe two encompassable sites by radiation. Yeah, then definitely I would be intending to treat that patient with maybe an SBRT or a high dose radiation per fraction, provided if he's exhausted all the systemic options.
Very true. And Joydeep, that brings me to you. Systemic options. Do you actually think this is palliative care at all? I mean, you have about 7 or 8 lines of therapy
Yes,
for a prostate
not at
patient.
all.
Yeah.
I mean, we have a long way to go in prostate cancer. Patients survive for years with all the newer ADTs.
So then that brings us to the big question. Each of the treatment lines that we have their own set of unique side effects. So, Dr. Runangshu, are you involved in the treatment of side effects of treatment at all, or is it just the symptoms?
Not much, because I mainly deal with the pain clinic, and the prostate patients, they generally do not report that much to the pain clinic. Only when they have like vertebral mets. There are some indications like vertebral mets. They have bone pain.
So I'm
so-
sorry to
yeah.
sort of butt in like this, but I think this is an area for us to think about. We have patients who are on androgen deprivation therapy coming to us with, gynecomastia, with hot flashes, and we try to manage them on our own. The question is why? And that is what brings me to the point of the underutilization of palliative care services when it comes to symptom management, not just disease related, but also treatment related. At the same time, we radiation oncologists are very closed about the side effects of radiation. We don't want any help there. We try to do everything on our own. I think it's time we opened up. We started involving a palliative care services as much as possible to get out of any difficult situations that we may be facing. Urothelial cancer. And I have taken the liberty of calling LUTS hematuria and bladder outlet obstruction as a dreaded trio. This might actually be pointing towards death for a patient. I'll start with Kushal again. Kushal, do you think this is a medical emergency?
Yes, indeed. I mean, bladder outlet obstruction can have a multitude of effects. It can straight away lead to effects on your kidneys, lead to renal failure, and then ultimately down the cascade.
And that exactly what brings me to the point of who should be the team leader in palliative care. As you rightly pointed out, if this patient had gone to you, you probably would have asked sir to come in and do a channel TUR to get the patient out of trouble. So it's not just important for a primary specialty to be involved. It is for someone who has that broad overview, eagle's eye view, to understand which direction the patient will get the best palliation from. And that brings me to a very difficult question, which I will go with to Dr. Priya. Suppose you have a patient with a stage 4 urothelial cancer. Let's, for sake of convenience, make it a bladder cancer. And this patient has been given systemic therapy by Joydeep, seems to have good palliation of symptoms as well as reduction of disease burden. Would you then think of local therapy at all?
If the patient is not symptomatic at the moment, maintaining well on systemic treatment, no, not at that point. If ever down the line, if he becomes symptomatic, yes, I would definitely be tempted to treat.
And what about the oligometastatic paradigm and urothelial? I know it's difficult.
I know,
but
I know. It's a very difficult, the biology of, the prostate and the urothelial are completely different. You're comparing, like apples with oranges.
Correct.
So the oligometastatic paradigm, I would still be tempted to treat with systemic treatment. Like I said, if you exhaust everything and you're progressing on only one site, maybe if you look at a lot of oligometastatic trials, the patient is not responding to systemic, then I would preferably add radiation to see how it goes.
Joydeep, immunotherapy, urothelial cancers, long-term survival is possible at all, like we see for lung?
Not like lung, but yes, it has the combination of
Carry on.
the combination of EV plus IO has significantly improved the median OS to nearly 2 years.
Right. So this is something important because now survival seem to be improving, wherein palliative care, if done with the expectancy of a short survival, might now start kicking it with their own side effects, which again need to be managed separately. Is again food for thought. Just to finish off with this, I decided to present these two. I know they are all retrospective data, and this is food for thought for all local therapy guys out here, meaning surgeons and radiation oncologists. Yeah, because they do have data for a dose dependent survival benefit, even with stage 4 bladder cancers who have responded to systemic therapy. And this is something I think which probably Vedang sir would be leading the way in this, designing a study which we might actually participate in, wherein our stage 4 bladder cancers can be given some amount of local therapy, be it cystectomy, be it radiotherapy, and the dose that they seem to have reached is a dose of more than 50 gray. Fractionation, probably conventional, we could think of something else, but that seems to be making a difference, probably going down the line of prostate again, oligometastatic prostates. So with that, we come to MRCC. This is primarily a medical oncologist domain, so I'll directly go to you. How do you look at MRCC when it comes to palliation now? Because we know about survivals that are going into years, even with TKIs, now with IO. How do you look at that now?
So large role is with the surgeon because the main symptom burden is the disease volume and the hematuria. So in that situation, we involve the surgeons. Other than that, if it's a metastasis causing pain, then we would treat it with the help of the pain clinic and continue on the systemic therapy or give radiotherapy to the painful sites.
Dr. Priya, palliate or ablate in RCCs?
Again, it depends on the number of sites we are dealing with at the location. Yeah, if it's a single site, ablate.
Yeah.
Yeah, if it's like
Can I-
multiple sites.
Can I make it
disseminate-
slightly more difficult?
Yeah.
Radimmune. What do you think about it?
I mean, it's been some time I mean, I know about this, but I'm right now, I'm not able to recall the entire
Yeah,
concept of
yeah,
radioimmune
yeah.
right now. But yeah, I mean, I'm honestly, I'm not able to recall that. Yeah.
Okay. And sir, I would again ask you to help us out here. We used to have a time in the past where even stage 4 RCCs underwent nephrectomies, palliative nephrectomies. Then these guys come up with TKIs and IO, and that seems to have been thrown out. Do you think there is still a role for that?
This debate has started when I started having my residency 40 years ago, and it will still go on. I think we'll have to manage it case by case rather than there can be no dogma or a diktat.
Absolutely, sir. So it's personalization more than one size fits all. I know he's picked up the mic to say no survival benefit with palliative nephrectomy, but I think that's a discussion for another day. And yeah.
Sorry, are you
Yes.
suggesting immunogenicity and radiation?
Yeah, yeah.
Oh, yeah, sorry. Yeah.
Okay.
I
so-
mean, there is no great evidence behind it, but we usually keep talking about the abscopal effect and how radiation makes it more immunogenic and
Yeah.
that kind of a thing. But if you ask me for a very high level evidence, I may not be able to.
There is none, but all of
Yeah,
us are doing
exactly.
it. That's something. So I think we more or less reached the end of what we wanted to discuss. But something that makes a lot of difference for a patient's journey is hospital admissions. And I think we'll end with this because we have something left. I'll just skip through that. But I think this part is important because a lot of these patients who are extremely symptomatic come to you, palliative care physicians, and say, please admit us. What is your approach there? How do you manage that situation? Because, yes, no, hospital burden versus financial.
No, first of all, that practically speaking, we have to deal with the patient's expectations and give them a realistic idea of what is going to happen, and they have to come at terms to that. That is the first thing. That would be the base on which we'll start working on in these situations. If the patient expects that patient has come with a heart failure or something, and then we'll admit in ICU, and the cancer will be cured. So that sort of expectations should not be there. We
Very
should
true,
clear
but
the board in the beginning.
Absolutely. But there is something to suggest that there may be a role for a subset of patients who are extremely symptomatic. A hospital admission might actually help them get rid of the symptoms much better than home-based care. And
yes,
there is
of course.
data regarding
Yes,
that.
of course.
Again, one size fits all doesn't work here.
Yeah.
I'll skip through this because we as radiation oncologists have started looking at ablation of bone metastasis in a very big way. Again, not for everybody, but for a subset of patients that seems to do very well, much, much better than the palliative radiation paradigm that we used to have here. So the topic mentioned what works and what does not work. Unfortunately, we haven't talked about that at all. So I think I'll use the last two slides to didactically tell our audience what works and what does not work. So what works is comprehensive system management. It includes symptom control as well as pain management. Psychosocial support, as rightly pointed out by you, is something that we don't pay enough attention to, but that works. Multidisciplinary approach, all the people sitting up here, all of them will be involved. And early intervention, as already proven by clinical trials. Now, to break the suspense as to what does not work. Inadequate communication. I think all of us at some point in our careers have been sort of responsible for this. We don't communicate enough, and that's where probably the palliative care team can help us because they might get a little more time with our patients. Limited access is not our problem. It is a problem of the healthcare system of the country. Palliative care service is not as well established or as accessible as it is probably in other countries. Inconsistent care, coordination of fragmented care is something that we have to deal with. Late referral is something all of us are guilty of, and that is something we have to get rid of. And finally, we should not be thinking that patient has no treatment, so why send them off to the other department? Probably they should be taken up on a board with multidisciplinary care physicians present to give them the right decision. And this last slide is to thank Dr. Murthy and somebody who's not present here whose shoes I had to fill in, very big shoes, but I hope I was able to do what was needed. Thank you very much.
That was brilliant. Thank you very much. JNK sir, we are done now. You're still posing for the next photos. Thank you. That was a difficult one to chair, but thank you very much for filling in at the last minute. Now we have got two important things. We have got the general body meeting in 2 minutes. And then after that cultural program, Mahendrapal is there, then we can have the cultural program. We can start GBM 2 minutes ahead of schedule. That's good.